ठीक है।
Good morning to everyone. I, Dr. Vaishnavi, along with my colleague Dr. Ayush, extended a warm welcome to our esteemed and respected dignitaries, respected Director Sir, Professor R.K. Dhiman Sir, respected CMS Sir, Professor Sanjay Dhiras Sir, respected Head of Department Emergency Medicine, Professor R.K. Singh Sir, respected Tanmay Ghatak Sir, Associate Professor, and respected Utsav Anandmani Sir, Assistant Professor, and respected Principal Ma'am, College of Nursing, Dr. Radha Krishnan Ma'am, and guests and speakers.
Today, we have gathered here to celebrate World Quality Week, national level quality webinar, which is being organized by Indian Society of Critical Care Medicine in collaboration with Quality Cell Department of Hospital Administration and Department of Emergency Medicine, SGPGIMS. It is a time dedicated to recognizing and advancing quality initiatives that enhance healthcare services and patient experiences. This week is an opportunity for us to reflect on the standards we set, the continuous improvements we strive for, and the collaborative efforts that drive excellence in healthcare.
Thank you all, distinguished speakers, and all the audience for joining us in this celebration of commitment to quality and excellence. We look forward to insightful discussion and shared learning as we move forward together in our pursuit of a safer, more effective healthcare system.
Now we'll begin with our inaugural session. Now I invite our respected Associate Professor, Department of Emergency Medicine, Dr. Tanmay Ghatak Sir, to kindly come to the central stage and deliver the opening remarks.
Good morning. Good morning, distinguished guests, esteemed speakers, and participants. Healthcare quality refers to the degree to which health services increases the likelihood of desired outcome for individuals and for population. It relies on evidence-based professional knowledge, effectiveness, safety, and patient-centered approach. Without quality, organizations cannot achieve customer satisfaction and cost efficiency. The World Quality Week is celebrated to highlight the significance of quality in organizations and society. This year's theme is quality from compliance to performance. Quality improvement is a collaborative endeavor. Therefore, Indian Society of Critical Care Medicine Lucknow City Branch and Emergency Medicine Association UP in partnership with Quality Cell at SGPGIMS is organizing the national webinar to enhance awareness of healthcare quality, patient safety, and improved outcomes. The agenda is designed to address the current healthcare needs and align with the year's sustained quality in healthcare. As part of Quality Week celebration in SGPGI, our objectives are to promote a culture of continuous improvement, enhance awareness of quality standard and protocols, celebrate quality achievements and recognize efforts, and foster interdisciplinary collaboration. I am delighted to acknowledge our chief guest for the day, Professor R.K. Dhiman sir, who is Director of SGPGIMS. Your leadership and dedication to healthcare quality have been an ideal example and an inspiration to us. And we also privileged to have our guest of honors, Professor Sanjay Dhiras sir, who is CMS, SGPGIMS, Professor R.K. Singh sir, who is Head of Department in Emergency Medicine, Professor Harshavardhan sir, who is Head of the Department of Hospital Administration, and Mrs. Radha K, who is Principal College Nursing in SGPGI. I welcome all of them from core of my heart, and I would like to take a moment for a highlight the esteemed speaker of today's session, like Professor Surendra Verma, who is a pediatric endocrinologist, who will be delving the implementation of the artificial intelligence in medicine. Subrajyoti Bhaumik is a pharmacologist and is in Peerless Hospital and addressing clinical audit. The Bhaskar Narayan Chaudhary will speak on on hospital HAI surveillance, hospital acquired infection surveillance. He is a microbiologist, and Rajesh Harshavardhan sir is hospital head hospital administration and is a LLB also. He'll cover the legal aspect of medical practice. Pratibha ma'am is a medical specialist and geriatric specialist. She will talk up on patient related experience measures and patient reported outcome measures. That is very important in quality care. And Rajagopal RG is a MBA, and he will talk on zero defect, zero effect. And ultimately, my dear friend, Dr. Sukhen Samanta from UAE, who is a DM from SGPGIMS, will close the scientific session. Will talk on hospital operation and efficiency. This event, I hope, will bring the exceptional groups of professionals, scholars, and practitioners committed to the advanced quality of healthcare. And these goals, and our quality CME webinar goal will support the culture of SGPGI standard. And we did NAC last week. Just we have completed NAC evaluation last week, and it will improve the SGPGI quality standard as well. Thank you all for being here today. Let us make the event a remarkable one. Thank you. Over to you.
Thank you, sir, for your kind words. I request our nursing officers, Ms. Meenakshi and Ms. Kanika, to felicitate Dr. Tanmay Katak, sir, with a token of appreciation.
I now respectfully invite Principal, College of Nursing, Dr. Radha K. Ma'am, to kindly come to the center and deliver the welcome address.
Good morning, everyone. On behalf of Indian Society of Critical Care Medicines, Lucknow branch, in collaboration with Quality Cell, SGPGIMS Department of Hospital Administration, and Emergency Medicine of SGPGIMS, Lucknow, UP State, India. We are proud to serve as the three key pillars organizing today's event. It is only happening in SGPGIMS. I am Dr. Radha K, and it's my privilege to extend a warm welcome to all of you as we come together to celebrate World Quality Week. The theme of World Quality Week is Quality from Compliance to Performance. As we gather here today, we recognize the critical role of quality improvement plays in the healthcare sectors, especially in all the hospitals, emergency departments, and critical care units. It gives me immense pleasure to extend a warm welcome to our distinguished guest speakers who have graciously joined us today in the webinar. Dr. Harshavardhan sir, Professor and HOD Hospital Administration, a guest of honor, and Dr. R.K. Singh sir, Head of the Emergency Department, is also the guest of honor who have joined today in this webinar. The two pillars have been pivotal role in driving the quality initiatives and shaping the emergency care landscape. We thank you both of your support, sir, and leadership in making this event possible. We are also privileged to have Professor Sanjay Dira, sir, Chief Medical Superintendent, whose valuable insight into hospital administrations and quality management will undoubtedly inspire us. And our keynote speaker, Professor R.K. Deeman, our esteemed director, will be sharing his expert knowledge and vision on quality improvement in the healthcare system. We are excited. Our keynote speaker, Professor R.K. Deeman, our esteemed director, will be sharing his expert knowledge and vision on quality improvement in healthcare systems. We are excited to hear from you, sir, and look forward to your thoughtful, provoking address. The resource persons for today's event include esteemed experts for both India and abroad. who will be presenting on a range of important topics, including artificial intelligence in medicine, clinical audit, healthcare-associated infection surveillance, legal aspects of medical practice, patient-reported experience measures and patient-reported outcome measures, zero defect and zero effect, hospital operations and efficiency, healthcare artificial intelligence. These professionals bring value, insights, and knowledge that will help us advance our understanding and practices in these critical areas of healthcare. As we move through today's program, I encourage all of you to engage and encourage with esteemed speakers, participate in discussions, and share your experiences as we collectively explore, including nursing college from PG students also joined in this webinar, explore how we can continue to elevate the standards of care in our healthcare facilities. Once again, I extend a heartfelt welcome to each one of you and thank you for your presence and commitment to improving quality in healthcare. Let us make this World Quality Week a memorable and impactful celebrations excellence in the healthcare worldwide. Thank you. Thank you once again.
Thank you, ma'am, for your kind words.
Now I request our nursing officers to come forward and felicitate Dr. Radha K. ma'am.
सोसाइटी से इन्वॉल्व है और अपने हॉस्पिटल की क्वालिटी ऑफ
Now I request all the dignitaries to come forward for the lamp lighting.
निकल रहे हैं ना। जब यहाँ पहुंच जाओगे ना करटिया तब बता देना, क्योंकि मैं भी एक फंक्शन में हूँ, फिर वहां से निकल के आऊँ। ठीक है।
It is with great honor that now I invite our esteemed director, Dr. R.K. Dhiman, sir, to kindly take the stage and enlighten us with his profound insights as to address the keynote. His leadership and expertise continue to inspire and guide the growth of this. So,
Thank you. Professor R.K. Singh, Head of the Department of Emergency Medicine. Professor Radhake, the Principal of the Dr. Tanmay Ghatak, Dr. Mani, my dear colleagues, ladies and gentlemen. Primarily, we are celebrating the World Quality Week to highlight the significance of the quality in organizations and the society. I want to tell you that only yesterday we finished NAC assessment. NAC stands for National Assessment and Accreditation Council. And assesses the quality, the facilities, and many more things at one go of a university. Similarly, this is the qualitative data. Similarly, we have the quantitative, how many teachers, how many students, how many equipments, whether they are properly maintained or not. And more importantly, whether we are providing a quality service or not. So the quality matters. Even if you are a smaller organization, if the quality is not good, when I say the quality, that means we are sticking to the norms. For example, if I take the example of the emergency medicine, the entry of the patient in the department, we have the MRTC building, Emergency Medicine and Renal Transplant Center. As soon as the ambulance comes outside, the service to the patient starts from there. So the quality is that there should be someone, because in the ambulance you don't know how much sick a patient in that. Maybe on the ventilator, maybe gasping, maybe sometimes we see that even the oxygen is not there, just finished, all these things. So the quality is something like that. If a patient whose heart is beating and comes in the emergency medicine, he should be taken care of from there. After the resuscitation, taken inside also, and the proper care is given. That's what I believe the quality. The quality does not come within a day or so. If I say the SGPGI is one of the topmost institution, and I say nobody can say that it has come within a day or so. When the foundation stone of this institute was laid down, then the quality was assured, and we set the aims also, vision and the mission, and we are going accordingly. So our area is basically the medical. Again, three pillars I will talk of: patient care, teaching and training, and all three segments. And now we are talking of the outreach programs also. So ultimately, that this society should be benefited. The quality of the services at all levels, whether it's from the PSC, CSC, district hospital, medical college, and ultimately the state. One of the best example that I have seen the quality services, I think you will all remember 2020 and 2021. It was the COVID. The quality was ensured. And we set the aims, each and every aims, I will say. whether it is surveillance, whether it is testing, or whether it is a treatment also. So the government work on all directions. And when I say the government, I am talking of each and every doctor or paramedical staff or even non-medical staff. Swachhata, cleanliness matter at that time also. Our protocols, we followed them very rigorously. And that's why we come to know that the COVID care was the best in UP. I am not saying it. Everybody says, not nationally, but internationally also. WHO says, and even the Time magazines features also the quality care of the COVID care. So there are many things. I just said that it is not a one-day job also. It is a very continuous process actually. It should be over. It doesn't, whether it's a student or it's a consultant or it's the residents or paramedical staff. So all process has to continue simultaneously. So that is the one aspect actually, that our mission and the vision and the mission should be very clear. And number two, what I feel actually, if we are talking of the quality, I already told you that is not the one-day job. So it is the series actually, every time, every year at least, we should revise our goals also. And we should set our aims also, so that everything is increasing. Since we are in SGPGI, so SGPGI has the great responsibility not only to improve its own quality, which is very good actually. And if you take a criteria of the NIRF, then we can say at least we are sixth in the as far as the quality standards of the institutions is concerned. If not fifth or not seventh, at least we are the sixth also. But if we see our medical colleges over here, so somehow we are good in numbers. We are getting the students also, who are the future doctors also, future nurses also, future technicians also. So think if the quality is not maintained after they pass out after 4 years or 5 years, and particularly after 5 years of passing out, that is a very crucial period where you will say that this is the quality. If they are improving, then it is easy to improve further. If they did not improve and if their standard is not up to the mark, then it would be a Herculean task to increase the standards of the quality further. What I'm trying to tell you, I think you must have by now thought what I am saying. I am saying our institutions who are very good, not only the SGPGI, maybe others, we must have a role of the hand holding the other medical colleges. हाथ पकड़ के सिखाने वाली बात है. Those we have mastered over here, those protocol we have over here, I think this is the time that they should be followed over there. Just a minute. Hello? I have to receive one VIP also, therefore. So what I'm trying to say, maintain yourself, but more important is help your colleague over here. And as a SGPGI, we must help the other medical colleges also. And one area where we can help all the medical colleges, 31 or 51, whatever the number is, they cannot be made the SGPGI. But some of the services can be made like a SGPGI. And one of those services is, I personally feel, is emergency medicine. And second is the trauma. Both are very, very important because everybody wants the immediate care. If somebody is having the MI, so there should be provision that the patients be taken to the hospital within an hour. And if the reperfusion studies or the treatment has to be done, it should be done over here. So what I'm trying to say, Dr. R.K. Singh, I think one of the most competent person I have seen. Why I'm saying so? He not only have the skill, but he has the brain also. Brain plus the skill, then you can imagine what wonders could be done. So he is doing also. We have done tele ICU project on the similar aim that we are the hub and 6 medical colleges, they are the spoke. Their ICU we will manage from here. We will not manage forever. We will train them. We will train their faculty. We will train their residents. We will train the paramedicals or even hospital attendants and the safai karamchari कि कैसे करना है कैसे नहीं करना. So our aim is not that we are feeding them. Our aim is not that we are giving them a fish to eat. Our aim that they should know how to fishing. Fishing is important. They can do. And after a year or so, they become the hub and other 6 surrounding, they become the spoke model also. So basic aim is strengthening. I'm just coming now to the one example. Is strengthening the emergency medical care, not in SGPGI, but in whole Uttar Pradesh. That is our aim. So improving quality care in SGPGI is not that difficult, or maybe in the RML or this thing. The difficulty, the challenge, the opportunity, both. Opportunity that we can do it, we can improve the quality at the state level, and the challenge is that how to do it. So you require some guts to do it over here. I tell you one thing, there is no dearth of the money. Financial issues are not that much, rather than we do not have that kind of the manpower who can train further also, and maybe many more things. So, I have just given one example. Similarly, you can have the trauma, at least 2 that you can have. Third, I have from the pathology, where we are bringing the digital pathology. This is all improving the quality. At the moment, I am not thinking to improve the quality of the SGPGI. We have already finished our NAC, and most likely we are going to get good grades also. So it is a term that we should improve the quality of our neighbors. It is the time to improve the quality of our medical colleges also, irrespective whether it is the government or this thing. So आप तो देखते ही हैं सारा, तो क्वालिटी तो बहुत ही इम्पोर्टेंट है इन सब चीजों के लिए. There are many things here. Okay. Enhance awareness of the quality standards and protocols. I already talked to you. Empower staff through quality improvement training. I have talked to you, giving one example, citing others also. Celebrate quality achievements and recognize efforts. We will celebrate once the NAC result comes. Encourage patient safety and quality and care initiative, foster interdisciplinary collaboration. जब हम कहते हैं कि हमने quality improve करना, it doesn't mean it is all medical. It also includes the engineering sections also, so many other things also. So I'd like to stop over here and thank you once again for inviting me. This is a very, very important topic. And we should not only discuss, I think that is the first step we should discuss, we should conclude, we should make the protocols and then follow them. Then you will see even in 1 year, you will be having great improvements in the quality care. So with these words, thank you so much. Thank you, RSL. Thank you, Mani. These three, they are now front पे हैं वहाँ पर emergency के, and I wish them that they should do much better in future also. That should be an example, already example. Yours tele ICU is an example for others, already example. Create many more such examples. Thank you so much.
I request R.K. Singh sir to felicitate our guest of honor, Dr. R.K. Dhiman sir.
Thank you.
I'm honored to now invite our esteemed guest of honor who has joined online, Professor Dr. Sanjay Dhira Sir, Chief Medical Superintendent of SGPGIMS, to share his valuable insight and thought with us to address this distinguished gathering.
Good morning, and dignitaries on the dais, Professor R.K. Singh, HOD Emergency Medicine Department, Principal Radha K. Ma'am, Principal of College of Nursing, Dr. Tanmay Ghatak, Dr. Mani Ussav, and rest of my colleagues. First of all, I would like to congratulate Dr. Tanmay and Dr. Harshvardhan for collaborating with each other and the Indian Society of Critical Medicine, Lucknow branch, and Quality Cell Department of Hospital Administration coming together to organize a webinar on quality from compliance to performance. This is a very important topic because compliance breeds incompetence, and incompetence will result in decrease in patient safety and satisfaction. So I welcome wholeheartedly this webinar on quality from compliance to performance. I hope that we will be having an academic feast in which mostly we will focus on the day-to-day small things that we can do so that the quality of the patient care can be improved. My all the wishes for a very successful event, and let the academic feast begin. Thanks a lot.
Thank you sir, for enlightening us.
Now, I'd like to invite a distinguished guest of honor, Dr. R.K. Singh, sir, Head and Professor, Department of Emergency Medicine, take the stage and grace us with its insightful thoughts.
Good morning, everybody. Professor Bhiman, the director of SGPGI, has briefed almost everybody about the importance of this quality week. He highlighted a lot of aspects that are important for quality initiatives that need to be done. So I wholeheartedly accept the invitation and congratulate the entire team of ICCM Lucknow, the Emergency Medicine Uttar Pradesh, as well as the hospital administration of SGPGI for this initiative, for celebrating this quality week for the hospital itself. Now, for me, quality means patient. Patient satisfaction is the hallmark of a quality of a hospital. So if the patient is not satisfied with the quality that is being given to him in the hospital, I mean, the hospital as such has failed. So if the administrators are on this platform, I would rather say that each department should have a quality feedback from the patient, whether or not his XYZ segments of care have been duly satisfied or not. And you can rate them. Each department will have quality metrics which are different. And emergency medicine will have satisfaction survey in terms of different aspects, and ICU will have for different aspects. The OPD segments running departments will have it for different aspects. So there will be a quality patient satisfaction survey form. So if the hospital has that patient quality certification or survey form, each department have a different aspect. And if that department takes all those feedbacks, I think unless your customer is satisfied, no matter how much we talk on this forum, everything will go down the hill. So let us all vow for this day and try and make feedback forms that have to be filled at the time of discharge by the patient. And the discharges are not to be given to the family unless that quality or that patient feedback certification is given by the patient. So do not discharge the patient unless you have that feedback survey form from the patient. So, and then you can have many aspects. The emergency medicine has got almost like 8 or 9 aspects of that quality feedback from the patient. I wish the entire hospital, and I also encourage Dr. Harshvardhan to design it for each department of SGPGI. There are 34 departments. So each department shall have one feedback form for the patient when he's discharged. And that feedback forms looks into a lot of aspects, right from registration to acceptance to quality care being provided on XYZ aspects within the hospital to that patient, to the quality of cleanliness, to the quality of care, to the quality of financial support that the patient is bearing, timing metrics, whether the investigation could be done on time, whether the results were given on time, whether the investigation was received by the bedside, whether there was financial problems, whether the cleanliness of the area was good, whether the HAI bundles were followed in toto. So there are so many aspects of each hospital segment can have that quality estimation from the point of view of patient satisfaction survey. So if each hospital bed or each hospital ward has that patient survey form, which is specific to that department, automatically then all that information is available to the hospital board It is online, it can be made online so that these things are available and everybody can see. There's nothing to hide. If everybody is hiding, if everybody is feeling defensive about these things, then the quality improvement will never come. So one has to be open about what they are, what quality they provide, and then make the effort to change those metrics over time. Give time. So first make a form which is specific to that department, then get the data, and then start working from there. Okay, so over time, put out those dashboards for your hospital, for your departments, and see where you are reaching over time. So say in 6 months, you re-audit that entire segment again. So whether my HAI is coming to 0 or not, what is my HAI level, what is my VAP, what is my COTI, what is my hand hygiene compliance, what is my infection surveillance reports, what is the antibiogram status of my, what is the antibiotic policies I have. So there are so many segments. So each unit will have their department specific segments which they want to work on. And then they have to get it assessed first by the customer. The customer is the patient. So if the patient is telling you that the care or the cleanliness or the consultation time or the staff is not behaving optimally, that means there is some work needs to be done in those areas. So how do I know? So unless the patient is complaining these, either I wait for the complaint and then do, or I have a feedback which looks into all those aspects. So each department makes those feedback forms specific for their department and runs it down the line. And then over the period of time, you will have audit of those things. And then you can escalate the quality of care over time. And you can even project it that my department has, say, 0 HAI, has 0 COTI. The ideal is 0 COTI. The ideal is 0 VAP. The ideal is 0 CRBSI. So can I achieve that? And then what has to be done in terms of the PDSA cycle, that is plan, do, study, and act protocols that need to be implemented for my department. So I would just end my small information as to the quality week and encourage everybody. And again, congratulate and thank all the people who are present in this forum, both online and offline, for that initiative of the quality week. Thank you so much for inviting me. Thank you.
Thank you, sir, for valuable words. Now request Dr. Tanmay Khatak, sir. Illustrate Dr. R.K. Singh, sir.
उसके बाद इनको बुलाना, ठीक है? तो जब ये हो जाए ना, अभी देखना बाकी इनके उससे बुला रही है। तब तक एक लेक्चर हो जाएगा। अंदर में है ये अच्छा तो अभी कुछ ना Yes, ready.
And you have a break. By the time they will reach. 5 minutes. By the time they will. So you give breaks.
Uh, all the uh, all the ones who have joined and all the audience, please wait for a while. The speaker will connect soon.
अरे यार क्या ही है। हम्म, या तो साला ये मोबाइल में रख लो।
When using a traditional IV catheter, pressure must be applied over the vessel to try and keep the blood from coming out of the open hub of the catheter and prevent exposure to the clinician. There is an inherent risk of When using a traditional IV catheter, pressure must be applied over the vessel to try and keep the blood from coming out of the open hub of the catheter and prevent exposure to the clinician. There is an inherent risk of contamination when making a connection to the catheter because the connection point is down on the patient's skin. Any blood that happens to leak out onto the patient must be cleaned up before the transparent dressing can be applied. Once the catheter is secure, any additional blood that may have contacted other surfaces must also be cleaned up. The BD Nexiva closed IV catheter system is a pre-assembled system ready to insert right out of the package. Having the extension pre-attached reduces the number of connections made during the insertion process, where contamination or blood exposure could occur. To help facilitate insertion success, initial blood return can be seen in the catheter and then continues to flow up the extension to help verify placement throughout the insertion process. The needle is automatically shielded upon removal, and the vent plug will keep the blood contained within the system. The tubing can be easily clamped and unclamped, allowing the clinician to control flow. The dual port design shown here features two needle-free connectors. The BD Nexiva IV catheter is also available in other configurations. A low-profile built-in stabilization platform helps stabilize the catheter. A transparent dressing helps stabilize the system, protecting the insertion site from the outside environment. When using a traditional IV catheter, pressure must be applied over the vessel to try and keep the blood from coming out of the open hub of the catheter and prevent exposure to the clinician. There is an inherent risk of contamination when making a connection to the catheter because the connection point is down on the patient's skin. Any blood that happens to leak out onto the patient must be cleaned up before the transparent dressing can be applied. Once the catheter is secure, any additional blood that may have contacted other surfaces must also be cleaned up. The BD Nexiva closed IV catheter system is a pre-assembled system ready to insert right out of the package. Having the extension pre-attached reduces the number of connections made during the insertion process, where contamination or blood exposure could occur. To help facilitate insertion success, initial blood return can be seen in the catheter and then continues to flow up the extension to help verify placement throughout the insertion process. The needle is automatically shielded upon removal, and the vent plug will keep the blood contained within the system. The tubing can be easily clamped and unclamped, allowing the clinician to control flow. The dual port design shown here features two needle-free connectors. The BD Nexiva IV catheter is also available in other configurations. A low-profile built-in stabilization platform helps stabilize the catheter. A transparent dressing helps stabilize the system, protecting the insertion site from the outside environment.
Good morning, everyone.
Enabling evidence-based improvements to enhance patient outcomes. Audits also promote accountability and efficiency among healthcare teams, ensuring consistent adherence to best practices. Ultimately, they drive continuous quality improvement in clinical settings. With this, I would like to invite our next speaker, Professor Dr. Subrajyotik Bhaumik, sir, to speak on his topic, clinical audits.
Thank you. Good morning, everyone. And firstly, let me thank my dear friend for inviting me here. She and also the organizers for inviting me to this very important World Quality Day celebration. Let me share my screen and please let me know if my slides are visible. Are my slides visible? Can anybody tell me?
Yes, sir.
Okay.
Yes, sir.
Okay. Thank you so much. Thank you. It's an honor to speak to this August gathering at the SGPGI Lucknow. Today, my topic is clinical audit, but let me tell you, clinical audit sessions are actually taken for one whole day. And today, I will try to do justice. I will just say, maybe I'll just give a snapshot or just give a trailer of the movie Clinical Audit. If somebody is interested, they can connect to me afterwards. So, I have no conflict of interest to declare for this particular session. So what is an audit? An audit is an evaluation of data, documents, and resources to check if performance of systems meets specified standards. In the history of medical science, the first clinical audit was conducted by none other than a nurse, Florence Nightingale. In the Crimean War of the 18th century, she used to go around in the night time to look at the higher mortality rates among the injured and the ill soldiers. And she figured out that majority of these soldiers, they were killed or they died not because of the grievous wounds they had, but because of the infection they sustained. So hospital-acquired infection was actually figured out by Florence Nightingale by the first clinical audit which she did in the 18th century. Clinical audit, people confuse it with research. Research is not clinical audit. Research is concerned with discovering the right thing to do. Audit is ensuring that the right thing is done. And if you see research, it creates new knowledge, whereas clinical audit tests the care given against knowledge gained from research. Means, how are you managing your patients in tonsillectomy in your setup vis-a-vis the standards laid down of management of tonsillectomy by the Indian ENT Association? Research is based on hypothesis. Clinical audit is based on standards. Research may involve experiments on patients, whereas clinical audits never involves experimentation. It should never involve anything beyond normal clinical management. It abides by an ethical framework and does not require ethical approval. Many times, many doctors ask me if I need to do a clinical audit, do I need to go to my institutional ethics committee? Answer is no, because you are trying to improve your quality of clinical excellence. What is the definition of clinical audit by the NICE, which is in the United Kingdom? It is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria, and very importantly, there should be an implementation of change. Now, ladies and gentlemen, we do only half of the clinical audit, that we only compare, but we don't implement change. If we don't implement change, clinical audit is not complete. All aspects of structure, processes, outcomes, and care are selected while clinical audit is conducted. and systematically evaluated against explicit criteria. Where indicated, changes are implemented at an individual level, at a team level, at a service level, and very importantly, further monitoring is used to confirm improvement in healthcare services. So the overarching aim of clinical audit is to improve clinical service by improving professional practice and general quality of services delivered. Ladies and gentlemen, please remember, clinical audit is a quality improvement process that measures current patient care with outcomes against agreed standards of best practice. There are various kinds of clinical audits. Today, we don't have time to discuss them, but I will discuss today the standard-based audits. We can have adverse event audits, peer review audits, patient survey audits. I'm not going to go into that discussion. We are just going to adhere to the standard-based audits. This is the audit cycle taken from Jones and Carthon, which is basically talks about that whenever we are trying to do audit, we are trying to look at what are we trying to achieve. And there has to be a cycle going on. That audit cannot be a one-time affair. So we do the data analysis, we then compare it with the evidence, we have a proper sample, we then achieve it, we benchmark it with national or international standards, and doing something to make things better, we then implement changes and again we re-audit. So please remember, it is a continuous cycle, the audit cycle. What are the prerequisites? Good record keeping system. So I'm sure SGPGI Lucknow has a great record system and you are conducting a lot of clinical audits. It should be cared by fair and impartial personnel. So if you are an ENT surgeon, you are trying to improve your outcome in patients. If you only do your audit, that might not be very fair and impartial. So you must involve Department of Quality or other healthcare professionals to do your audit. Clinicians, nurses, other staff, as well as patient anonymity should be maintained. So clinical audits, we can definitely publish them, but it is better to maintain anonymous data. Initiatives should be from within. That is, the department should feel that they need to improve the clinical outcome of their patients. Purpose should be simple and clearly stated. And intention should be always to improve and become better. There are 5 elements of clinical audit. We must involve the users. So as I mentioned, clinical audits cannot happen without clinicians. They have to select a topic in assistance with the people who are aware of it. They need to define the purpose. They need to provide, the management has to provide necessary infrastructure, and we have to identify the skills and people. So there are people who need to be trained on clinical audit processes to carry out the audit. We need to encourage them to participate. How do we involve users? The focus of any audit project must be those receiving care. So clinical audit always involves patients and the clinicians take part of it. The users are genuine collaborators rather than mere sources of data. So if it's the audit conducted in the Department of Cardiology, the cardiologist has to be genuinely, they need to believe that this audit will improve the patient outcome. There are various sources of information for clinical audit. We can look at medical records. We can look at direct conversations between the doctors and the patients. And there's a, yes, please. Okay. So the role of clinical audit staff is involving data management. So all the staff will get access to the data. They will facilitate the data. They will record the data. There will be project management, and there we have to develop the training capabilities of these staff. And remember that these staff are very precious staff, the people who know clinical audit skills. So they need to develop skills over a period of time. In terms of ethics, let me be very clear. We do not need any ethics committee approval for clinical audit. It should be conducted within an ethical framework, meaning that patient data should not be available to anyone and everyone. We should abide by the principles of data protection. We should ensure patient and staff confidentiality, and we should ensure the data is collected and stored appropriately. So patient confidentiality must be maintained during clinical audit. How do you select a topic? The topic priorities should be concerning to high cost. So like knee replacement surgeries, high volume, it could be angiography or risk to the staff or users. It could be also a clinical audit involving mammography to the patients. There should be evidence of a serious quality problem which can be evident from patient complaints or high complication rates. So if there is a surgical complication following bile surgery, then that can also call for clinical audit. There should be good evidence available regarding standards. For example, systematic review or national clinical guidelines. So if we are doing an audit for mammography in patients, whether they are receiving more, whether unnecessary mammography is being conducted in our hospital or not, at least standards should be available from the Indian Breast Radiological Society or the British Breast Radiological Society or the American Breast Radiological Society, to which we can compare our performance. What can be audited? Structure, as I clearly mentioned, what you need, what you do, process, how do you intervene in case of bleeding variceal, in bleeding varix, and outcome. If you expect that 100% of your patients will receive surgical safety checklist or surgical prophylaxis before surgery, has that been done or not? That can also be audited. So some of the examples of clinical audit which you can undertake in your hospital is in patients who are suffering from pain. They could be from the Department of Surgery, orthopedic pain relief medication. Our medication ordering, percentage of patients whose known adverse drug reactions are documented on the current medication chart. What percentage of patients receive aspirin for acute myocardial infarction at discharge? And the availability and the use of electronic clinical information, management information, staff development, and quality projects. Very important to define the purpose. Once the topic of the clinical audit has been selected, the purpose must be defined. A suitable audit method can be chosen. And this is referred to, the purpose is referred to as aim. The following series of verbs may be used to define aim. Always an audit will aim to improve or to enhance patient satisfaction, to enhance patient or to improve the outcome of a surgical outcome in a certain situation. We can also aim to increase the usage of aspirin usage in acute myocardial infarction to ensure and to change. Objectives, a good clinical audit, apart from having an aim, will also have objectives. This is where the focus of your efforts is, where the greatest potential for improving the quality of care. And it's very important that all stakeholders, colleagues, and managers, they come on the same board to frame the objectives. Every clinical audit should have one primary objective, and there could be multiple secondary objectives. Once we have defined the aim and objective, we come to the audit standards. This is the very important thing. Clinical audit, by definition, is we have to compare our current practice with a standard, sometimes referred to as a criteria. Standards are always specific, and we must ensure that the currently available standards are used. So I'll give you an example that in case of uses of surgical prophylaxis in patients with inguinal hernia, the latest antibiotic protocol has to be used, which is in use in SGPGI. SGPGI can have antibiotic prophylaxis protocol in the year 2022, in the year 2021, but it has released the latest in 2024. So when we do an audit in 2024, we will have to compare it with the antibiotic prophylaxis, which has been mentioned in the antibiotic protocol book of SGPGI in 2024. It should be based on the best available published evidence. Audit criteria can also quantify the practice, and it should be derived from evidence base. How to set standards? Standards can come from guidelines and protocols, which are from national and international bodies. If they are not available readily at your hospital, please do literature search. It should be based on the strongest, most up-to-date evidence, what is constituting the best practice. And I can definitely tell you that there is a tool known as Up-to-Date by Walter Kluers, which can help you to figure out the standards for conducting clinical audit in the hospital. Now, which is the hierarchy for the strength of evidence? It is always the systematic review. See, the weak evidence is personal experience and opinion, expert report committees, non-randomized control trials. They are better than the personal experience, but at the top of the pyramid is the systematic review or the randomized control trial. It eliminates or reduces bias by giving the most reliable evidence. So, ladies and gentlemen, if you have to select the best available evidence for the usage of aspirin in emergency department when an AMI or an acute myocardial infarction patient comes in, please look at a systematic review which has been published in the last 1 to 2 years. We must set targets. In case in our emergency department, we find that 80% of the patients are given low dose aspirin on admission. Our target should be that at least 95% of the patients should be getting it. While setting targets, factors should be, which we should consider is the clinical importance. Ideally, honestly speaking, I'm wrong there. 100% of our patients should actually get low dose aspirin. So the clinical importance determines that what target we should figure out. Practicability. Now, say for example, in case of hand washing, when we are doing the clinical audit, sometimes practicability of 100% hand washing is not there. So if we are hovering around 45%, we will say that 65% of these patients need to 65% of our healthcare workers, which could be nurses or could be doctors, need to have hand washing capabilities or must do complete hand washing capabilities. While setting the target, remember SMART: specific, measurable, agreed, relevant, and theoretically sound goals. So the goals should be specific, it should be easily measurable, it should be agreed between the Department of Quality and the clinical department and where the clinical audit is being performed. It should be relevant and it should be theoretically sound, which needs to be backed by the published literature. Data collection is how much data do we collect? Many people ask me, what is the sample size? It is better to improve a single aspect of care. So suppose we are looking at the surgical patients, we just want to focus on the pre-surgical prophylaxis. There is no point looking at the DVD prophylaxis. There is no point looking at the back care of these patients. There is no point looking at 20 other things of this surgical patients. It is better to focus your clinical audit on the single aspect and change that and improve it rather than looking at 20 things and not changing anything. Data collection should be planned before clinical audit. User group must be included. So the Department of Surgery must be included in case of pre-surgical prophylaxis audit with any exceptions noted. We must include nurses, doctors, surgical JRs, and SRs, as well as Department of Quality for collecting the data. There should be a limited time period. We cannot say we will collect data for 2 years. That audit has got no meaning. And it also needs to be discussed, why is this important? Because pre-surgical prophylaxis, if it is not done in the proper way, can lead to infection of these patients, Agreement on these points helps to limit the amount of data which needs to be collected. Who will collect? Data will be collected by the audit team. Other staffs may collect, say, Department of Quality. Sometimes there are medical record people who can also collect the data. And there must be a structured form in which this data will be collected. And there has to be an adequate sample size which needs to be there for every clinical audit. The sample size usually is between 20 to 50 cases for a process-based audit. But if you really look at the sample size mentioned by the NAPH, this is on the population size of the patient the sample size for clinical audit is mentioned by the NABH. So for 50 population size, so if there are 50 patients who are undergoing bile surgery in a month, 44 patients need to be audited. If there are 5,000 patients of, say, for example, inguinal hernia in a month, only 357 patients are sufficient to undertake clinical audit in your hospital. And once you have this entire data sheet ready, we will now have to compare the current standard with what has been mentioned by the structured standard which we have selected. So say, for example, again, I go back to the surgical safety, to the pre-surgical prophylaxis, and we say that every patient who is undergoing surgery, inguinal hernia surgery, must receive a first-generation cephalosporin in 100% cases. And this is the standard is the antibiotic protocol by SGPGI Lucknow 2024. But when we do the audit, we find that 60% of them are actually meeting it. So the work is that from 60, we need to increase it to 100. So we look at percentage of cases which meet the standards. We look at percentage of cases which do not meet the standards, percentage of cases which is non-applicable, and percentage of applicable and cases meeting each standards, and we calculate them. We identify the deficiency, we look at the solutions, and we also design strategies to improve deficiency of care. This is the clinical audit outcome. If we don't do this, only collecting data is wastage of the entire time and effort. Once this thing has been collected and a complete report has been generated, we must inform the outcome to the people that what is the current practice, and so how do we plan to improve the current, and not only informing will be essential, but implementing change. Ladies and gentlemen, this is the most important thing. If we don't implement change, then change will change you. We have to understand that it is published literature clearly says that if the clinical audit is not followed by implementing change, this is a totally futile attempt and it is not going to lead to clinical excellence. Implementing change has to be planned. It has to be broken down into manageable tasks and achievable targets. So as I mentioned, that surgical safety prophylaxis is 60% because 60% of your department of surgery adheres to it, 40% does not adhere to it. So at least call a meeting of those 40% clinicians who don't adhere to it. Let us show them the data, ask them why they are not adhering to it. It will require a lot of discussion. We will have to show a lot of evidence. And then definitely we don't expect from 60% it will jump to 100% in a couple of months. But at least if the 60% becomes 80%, that is also a huge achievement. We need to communicate. Letters have to go out from administrators, from medical superintendents, from medical directors to these specialists who are not adhering to the clinical guidelines. And regular training will impart the behavioral change. Sometimes pilot projects needs to be done. That means first-time projects. So if we know that a particular unit is not adhering to that particular surgical prophylaxis campaign, a pilot needs to be done in that unit only. Many a times people ask that why successful clinical audits cannot be done. It was published by Johnson et al. In 2000 that there could be lack of resources, there could be lack of expertise. People who conduct clinical audits, expertise in conducting clinical audit is not there. So we need to have trainings like this. And again, thank Ms. Jui Ghosh and the organizers for having this very important topic, because many times we have seen across India that we have great clinical data, but we cannot perform audit. There has to be a complete plan for audit. And there is many times poor relationship between the quality team, the management, and the clinicians results in unsuccessful clinical audit. We need to have supportive relationships between clinicians and the administrators so that successful clinical audit can be conducted. Once you have implemented the change, we need to monitor and evaluate the change. And again, it will be done using a proper sample size, information collection, and the analysis. And the modification, whatever has been implemented, and the changes which has been observed has to be documented. And if they are not reached, the target is not reached. Suppose from 60 we jump to 80, but the target was 100. If 100 is not reached, then we have to analyze why 100 has not reached. So if this is the re-audit cycle plan taken from the Royal College of Psychiatrists, after the re-audit, if all standards were met, then we have to do a repeat clinical audit at a later date. So if it is met, if we have done a re-audit in December, everything was met, we have to do again in June 2025. If some standards were not met, again we have to do, the action has to be again undertaken, repeat data collection only for the standards which are not met. If all standards are not met, then we have to again rethink, do some introspection on the action that has to be implemented, repeat the entire clinical audit process. And if nothing could be achieved, then conclusions could not be reached, then and the standards are unclear, then we have to look at whether we have selected a proper standard or not. We have to review and repeat the entire clinical audit. So re-audit is very important because with every re-audit, the quality of clinical excellence improves. See, where you are at cycle 1, you go to a higher level at cycle 2, and at the cycle 3, you achieve much higher level than you were at cycle 1. So to end my talk, let me summarize what I have told you. All clinical audit projects are part of the clinical excellence program. Clinical audit measures practice against target performance observed in national and international guidelines. They should always be written up as a report and presented to the senior management. We must share the audit findings to get the message of clinical audit project staff across to every key staff in the hospital. Implementation of change, very important step, is in a clinical audit must not be missed. It is a key step. And undertaking a re-audit after the change is implemented is a must. And many of the hospitals and healthcare professionals miss this. We cannot afford to miss this. To conclude, clinical audit is a team effort and never a blame game that this department did not do it, quality did not do it, administrators did not do it. We have to come together to ultimately benefit our patients. That is the overarching theme. Thank you very much for this opportunity. If there are any questions, more than happy to take it.
If anyone has questions, kindly ask this.
Sir, good morning, sir.
Good morning, ma'am.
I myself, Dr. Radhaki, Principal College of Nursing. So,
Okay,
sir, I would like to know commonly in India and nursing audit in which are the areas is necessity, sir, to make the quality?
So, madam, great question. See, nursing, madam, every clinical process which the nursing undertakes, starting from mouth care to back care to the urinary catheter care to ventilator associated pneumonia prevention care, everything which you are doing, DVT prophylaxis care, every nursing care could be a clinical audit. So say, for example, the back care, madam, which you are giving so that the patients don't develop pressure ulcer could be a great clinical audit. I mean, what first we see that what are we doing to manage pressure ulcers? What is the current pressure ulcer rate in my hospital? What is my current culture of management of pressure ulcer? And what does, say, for example, the pressure ulcer management by the Plastic Surgery Society of India? Or maybe it could be a nursing society dealing with pressure ulcers. So you compare your method of managing pressure ulcer by the nursing care, you compare it with what has been mentioned in the standard and try to figure out where you stand. Suppose, hypothetically speaking, 80% of the time you're doing the right thing, 20% of the time you're not doing the right thing. So what is the next move? You will have to implement strategies so that this 20% is also not missed. This 20% should be taken care of because you want 100% of the patients to get the best clinical care, the best nursing care, and not a single patient in your hospital should miss this care. So you implement changes, you implement strategies, and very importantly, madam, you again retake an audit. And from 80, you see that you jump to 92%. Will you be happy? Definitely, you are going to be happy because you have walked the quality improvement path, but target is not reached. So again, madam, we have to do some root cause analysis. Some CAPA has to be done, corrective action, preventive action. We have to again re-audit after certain time, which will be intervened by training. And eventually, madam, from 92, if we jump to 97%, that is also very, very applaudable because from 80%, you are now coming to 97%. Remember, madam, clinical audits are a continuous journey. We have to keep on doing it. There cannot be an end date to clinical audit.
Thank you, sir.
Anyone else? Any more questions? Okay, moving ahead. Thank you, sir.
Thank you. Thank you.
Moving ahead, hospital-acquired infection surveillance involves systematically monitoring infection rates within healthcare facilities to detect and prevent outbreaks. It enables timely interventions by identifying infection sources, thus enhancing patient safety and quality of care. Effective surveillance help reduce HAIs, lowering hospital costs and improving overall patient outcome. With this, I would like to invite our next speakers, Dr. Bhaskar Narayan Chaudhary sir, to speak on his topic, HI surveillance.
So good morning, everybody. Am I audible?
Yes, sir.
Yes, sir.
Am I audible and visible? Okay. So
Not
thank
visible.
you. I'm not visible.
उनको डिस्कनेक्ट करके इनको पिन करना है विजय कहाँ जाती है
Wait, sir. We are making the required changes.
Okay. So my video
Yes.
is on.
Yes, sir. You are visible now.
Okay. Thank you. Thank you very much for the introduction. And thank you particularly to Mrs. Dewey for giving me this opportunity to speak on a very important topic. It is HAI surveillance. Just a minute. Please, my screen is visible.
Yes, sir.
PowerPoint is visible now.
Yes, sir.
Is the first slide visible?
Yes, sir.
Okay, okay. So HAI surveillance, let me introduce, I think you have introduced myself. So I'm Chief Microbiologist and Senior Consultant in Department of Microbiology and Molecular Biology, PLS Hospital, Kolkata. And I am also happen to be the Infection Control Officer. So Shubhra Jyoti, who talked just now, also belongs to my hospital. And together we are taking care of this antimicrobial stewardship program and the infection control and quality control So infection, as you all know, are may be classified into type 1, which is community acquired infection. Type 2 is healthcare associated infection, where the patient is not actually hospitalized, but coming in contact with some healthcare that is getting antibiotics and something else. And the third one, type 3, is actually nosocomial infection, which is acquired in the hospital. And nosocomial infection of some duration with chance of fungal infection is sometimes classified as type 4, although we can also tell it to be a type of type 3 infection. So this nosocomial infection is prevalent in all the hospitals of the world. However, how advanced the hospital setup is, but the rate is higher in the developing countries. So are my slides changing?
Yes, sir.
Okay. So nosocomial infection, I'm not going into the details of the definition because this is known to all of you. So infection acquired by a patient in a hospital or healthcare facility in whom it was not present or not incubating at the time of admission. It usually manifests after 48 hours of hospitalization. So regarding this duration, there are two schools of thought. One is the CDC guidelines, which we are mostly following, the NHSN guidelines, where they mention 2 days, that is 2 calendar days. Okay. But as per the WHO guidelines, it mentions 48 hours. So we are following mainly 48-hour guidelines, but the CDC guidelines, the other criteria, we're following the CDC criteria. Okay. So 2 calendar days means patient admitted in the night today. So develops an infection on the 3rd day, that is today is 11th of November. So patient is admitted at 9 p.m. So on 13th of November, if the patient manifests an infection and it meets the other criteria of nosocomial infection, it may be classified as hospital acquired. But as per the WHO criteria, 48 hours duration is needed to declare an infection as nosocomial infection. So actually, we are following many other criteria. So say community acquired infection like a typhoid, enteric fever, when it manifests on day 3 or day 4, okay. But we are getting a community acquired infection like enteric fever or an MSSA infection or a streptopneumonia infection, then we cannot classify it as a nosocomial infection, although it is diagnosed or manifested after 3 or 4 days after hospital admission. And many a times we are getting patients who are coming from other institutions. There they have either acquired a nosocomial infection, which is manifested after the patient is admitted in our setup. So that will not be considered as hospital acquired infection. It's a type 3 infection, but it is not acquired in our hospital. So we do not take into consideration such type of infections while we'll calculate the nosocomial infection rates of our particular hospital or a particular unit. Okay. So nosocomial infection rate is expressed as a percentage of total admissions over a stated period of time. Usually we are calculating the nosocomial infection monthly. So you all know the most important source of these nosocomial pathogens happens to be the patient's own endogenous flora. So patients' skin, mucous membrane, oral cavity, nose, throat, gastrointestinal, genitourinary tracts, they harbor millions of harmless commensal bacteria, which may be harmful in patients with impaired immunity who are immunocompromised, or which may cross the barrier of skin or mucous membrane due to breaches caused by injury or invasive diagnostic or therapeutic procedures, which is more prevalent in the intensive care units. So they now enter the normally sterile tissues underneath where they cause harm or infection. So these 2/3 of the nosocomial infection are acquired in this manner. And the remaining 33% or 1/3 of the infections are exogenous when the source of infection is external. And the most important route of transmission is through the unwashed or improperly washed or improperly disinfected hands of the hospital personnel. So if hand hygiene is taken care of, we can reduce the nosocomial infection rate by approximately 33% or 1/3. Okay. So There are other methods, other routes of transmission also. It may be the environment, it may be the medical devices, but in good setup, in a hospital with good setup, everything is taken care of the environment, everything is taken care of the medical devices. There are CSSTs, all sorts of disinfection measures and other measures are taken, aseptic measures are taken. So these are very uncommon routes of infection. So hospital is teeming with millions of bacteria which are exposed to different types of antibiotics. So they become multi-drug resistant. And let me now concentrate on, I will mainly talk on the experience based on our hospital experience, but you can translate it to your hospital and all other hospitals also. So these are the data from Peerless Hospital, the hospital I work in for the last 8 years. So last year, 2023, that is, we had total number of 3118 isolates. And out of this, urinary tract infection contributed around 32% of the isolates, and bloodstream infection 26%. SSTI, that is skin and soft tissue infection, 10%, and colonization was in 13% of the cases, and respiratory tract infection 11%. So out of these isolates, around 78% were gram negative, unlike in the Western literature where gram positive infections are more common. 13% were gram positives and 9% were fungal infections. And amongst the gram-negative bacilli, Klebsiella and E. coli happen to be the commonest bugs, followed by the other Enterobacteriaceae, Pseudomonas, and Acinetobacter. And amongst the gram-positive, Enterococcus happen to be the most common isolate, followed by Staphylococcus aureus and coagulous-negative staph, and then the other gram-positive cocci like pneumococci and others. But what is alarming is the resistance rate. As you can see from this slide, around 72% of the Klebsiella isolates were carbapenem resistant. 22% of the E. coli in 2023 were carbapenem resistant. 51% of the other Enterobacteriaceae, 57% of the Pseudomonas, and 88% of the Acinetobacter isolates were carbapenem resistant. And we found polymyxins resistance also, in particularly in Klebsiella and Pseudomonas, in the order of 4 to 5%. And pan-drug resistant Pseudomonas around 4%. Okay, so that is an alarming situation, and we are doing the gene study, that is the all the isolates, inpatient isolates, they are processed for PCR by open system to see what type of carbapenems the organisms are harboring. Okay, this is for the gram negatives. And for gram positives also, we process the staph isolates for MR detection, that is methicillin resistance detection, and the Enterococcus isolates for vancomycin resistance detection. So this is the data of last 1 year for the carbapenems producing gram negative bacilli, including the Pseudomonas and Acinetobacter, but commonest was Enterobacteriaceae. 50% of the carbapenem resistant organisms were NDM producers, 26% were NDM and OXA48 co-producers, and 19% were OXA48 producers. So this has got a clinical implication because ceftazidime avibactam will work against the OXA48 producers, but not against NDM producers, where ceftazidime avibactam and aztreonam combination has to be given. So amongst the staph aureus, around 37% were MRSA, that is methicillin resistant staph aureus, and all of them, most of them were MAKE-A mediated MRSA. A few were MREJ mediated MRSA. And amongst the Enterococcus isolates, 44% were vancomycin resistant, and mainly VAN-A and VAN-B, both were isolated in most of the VRE isolates. Now coming to the surveillance, for the surveillance, the primary necessity, which I think you have in all the hospitals, is the infection control committee. So it may have different subcommittees. One of the important subcommittee happens to be the antimicrobial stewardship committee. So this is mandatory in all the hospitals. So the chairperson should be the medical superintendent or medical director, and the member secretary or the infection control officer should be the microbiologist. And the nurses play a very pivotal role, a very important role in this. So there should be infection control nurses, at least one infection control nurse per 100 beds. So we are a 500 bedded hospital, PLS hospital. So we have 5 infection control nurses. One of them is the chief of the infection control nursing team. So, and you have the members from all the clinical units, the chiefs of all the clinical units, particularly the intensive therapy unit, the surgical unit, the medical unit, and the nursing superintendent and the medical records officer and pharmacologist, or if you don't have pharmacologist like Shubhrajyoti, you can have the pharmacist or clinical pharmacist. And the invited members are the chiefs of all supportive services like the OT sister in charge, the OT chief technician, the CSSD technician, which is very important, dietetics department, and the housekeeping department representatives. So the infection control measure, the practices in our hospital, these are mainly the hand hygiene. As you all know, that happens to be the most important aspect of infection control or infection prevention. Rational use of the PPE, donning, doffing, you know about the COVID, it taught us many things about this donning, doffing and disinfection, but we are already forgetting or overlooking some of the measures that COVID taught us. The isolation, positive pressure and the negative pressure isolation. Okay. So positive pressure for the patients who are themselves immunocompromised, like burn patients, post-transplant patients, and negative pressure for the patients who are infectious to others. So patient harboring MRSA, VRE, patient having CDI, patient having influenza, tuberculosis, they should be placed in negative pressure isolation wards. Then biomedical waste management happens to be another important aspect, which I will not discuss much in this lecture. Then cleanliness and care of the equipments and instruments or devices, environmental cleanliness, linen management, spill management, handling of NSI and body fluid exposure, outbreak management policy, and employee vaccination and health checkups. So these are all the different important aspects of infection prevention and control. So other aspects of HAI surveillance happen to be, you should have an infection control manual, a safety manual. Then there should be hospital and laboratory surveillance, continuous surveillance. Okay. High risk areas and procedures should be identified and risk categorization and management should be done. There should be a contingency plan. Then sterilization and disinfection of medical devices and hospital environment, environmental and sterile supply sampling. That is also very important. I will discuss this a little later. Then engineering controls. So biomedical engineers and engineers play an important role. Construction, renovation, and demolition policy. So what should it should you should have a policy on these aspects also. Maintenance of strict aseptics during invasive procedures. This is known to all of you. Standard precautions, say all patients when they are admitted are to be considered as seropositive, HIV reactive, and then measures should be taken accordingly. That is known as standard precautions by WHO. And the bundle care to reduce the rates of COTI, CLABSI, VAP, SSI, and CDI, that is Clostridium difficile infection, and antimicrobial stewardship and surgical prophylaxis guidelines. So these are the other aspects of high surveillance. So what are the challenges that we face in our hospital? One is the leading causes are NSI, needle stick injury. So recapping of pain insulin, that is one of the challenges that we have identified. Accidental prick during cannulation, another challenge. Hand hygiene, that is the most important challenge that we are facing, compromised hand hygiene among the doctors and the other staff. Hand hygiene happens to be the the high percentage amongst the nurses. So nurses are the best practitioners of hand hygiene. But the doctors, particularly the senior doctors, they are defaulters, and the other stuff like the technicians, the physiotherapists, the phlebotomists, when they are collecting the blood, many of them are defaulters. Then PPE, donning of proper PPE during invasive procedures and dressing is compromised. So that is another challenge. And another challenge that we have faced is the improper disposal of biomedical waste, often rectified by nurses. So despite repeated training and repeated teaching to all the staff of the hospital, we are still having breaches in biomedical waste disposal policy. Sometimes we find the shrubs to be discarded into black bins or the non-infectious waste amongst non-infectious waste. Sometimes we find the wrong placement of the biomedical waste in different color coded bins. So what are the checklists and audit tools? So on the left hand side, the checklists, protocols and checklists, they include the COTI checklist as per the CDC guidelines, the CLABSI checklist, the VAP checklist. In adults, we are mainly looking at PVAP, that is possible VAP or probable VAP, and the ventilator associated events. And then SSI checklist, needle stick injury and blood and body fluid exposure checklist, thrombophlebitis, hospital acquired pressure ulcer, which Subhrajyoti just mentioned a little while back, and antimicrobial stewardship and surgical prophylaxis checklists. Okay. So these are mainly audit tools, and amongst the audits, we are doing the continuous hand washing audit, the MOS parameters, that is, the VAP, CLABSI, COTI, SSI, NSI, all the NABH accredited hospitals have to follow these bundle cares and audits, regular audits. AMS, that is antimicrobial stewardship audit, surgical prophylaxis audit, disinfection practices audit, biomedical waste management audit, kitchen audit, mortuary audit, linen audit, all sorts of audits are going on in the hospital. So we are fortunate in our hospital for the last 2 or 3 years, we are using this IVAR app. It's a very unique app developed by IVAR in collaboration with JIPMER Pondicherry. So now many of the hospitals across India are using this app. So we are actually getting the realistic data. All our infection control nurses are trained on this app. They are dividing the words amongst themselves and going there for daily rounds and capturing the actual data in this IVAR app. Okay. But if you don't even have the app, you have to do this surveillance on a realistic basis, on a daily basis. So this is hand hygiene audit tool in the IVAR app. We are finding that whether the 5 moments of hand hygiene and all the steps, the 6 important steps or 7 important steps of hand hygiene are done. So that is a very important audit that is being done regularly by our infection control nurses. Of course, it's a sample audit. You cannot audit the 100% of the staff, but you can audit at least a sample. So we have to audit at least 200 or something like that. Sorry. Am I audible?
Yes, sir.
Yes, sir.
Okay. So hand hygiene audit, we are going. So what we are seeing, the partial compliance is more around 70 to 75%. But the total compliance, the complete hand hygiene, some of the moments or some of the steps are obviously missed. So the total compliance that we are seeing from this app is only around 30% among all the sections of the healthcare workers. So that is alarming. So we are continuously training them, but still then we are not improving the percentage. So it has improved from 20% to 30%, now 35%, but not more than that, the total compliance. But the partial compliance is in the order of 70 to 75%, but our target is to take it beyond 90%. Okay. So here we are seeing the nursing staff shows the best hand hygiene practices. The doctors are very defaulters, and the other housekeeping and group D staff, they also in between the nurses and doctors. So on the right hand side, you can see the biomedical waste audit, which we are also doing on a regular basis, not daily, but on a regular basis. So whether all the different types of bags are available at different places, whether the waste is segregated at the site of generation. Okay. So does the blue box contain any non-blue category waste and those things? These are also audited at regular intervals. Now, this is the most important, the ventilator, central line and urinary catheter care audit through the IVAR app. So this audit criteria, the checklist, which is filled in by the nurses, it is as per the NHSN guidelines of CDC. Okay. So for example, in ventilator bundle care, we are seeing whether the head and elevation is 30 degrees, the hand hygiene, whether it's done, daily oral care, need of PUD prophylaxis assessed, DVT prophylaxis, then assessment of readiness to remove is documented, cuff pressure monitored, sedation vacation and early weaning from ventilator, all these things are audited. In the central line bundle care, hand hygiene, alcohol hub decontamination, CHD2, then local sites of infection or thrombophlebitis, dressing changed, those things are audited. And on the in the urinary catheter bundle, we have the closed drainage system, urinary catheter, whether it's secured or not, drainage back above the floor and below the bladder level, catheter care, hand hygiene, vaginal or meatal care, perineal care, and there are many, sorry for the spelling mistakes here, single-use gloves where handling or emptying and those things. Okay. So checklist for prevention of surgical site infection is also available. Now the IVAR app is also capturing SSI. It has got the SSI checklist also. So where the surgical clippers are used for hair removal, antimicrobial agent administered as per protocol. We are following the West Bengal government surgical prophylaxis guidelines, which is as per the ICMR guidelines. Normal body temperature maintained throughout the surgical procedure. Blood sugar is maintained below 180 milligram per DL during the surgical procedure. If applicable, flash sterilization is used only for items to be used immediately. We discourage flash sterilization. In fact, in our hospital, we don't have flash sterilization. We have the plasma sterilizer where we can sterilize very quickly. So OT staff are aware of the policies concerning patient care responsibility when having potentially transmissible infectious conditions. So this is the SSI tracking to the IVAR app. So the types of suprapubic tenderness, loin pain, urgency, frequency, dysuria, all these things are in the SSI checklist, and this is also other things we are calculating. I'm not going into the details of this. Now coming to the compliance rate, how it is calculated, that we have shown you all the, and then we can see the data. The data can be generated on a monthly basis or on a weekly basis, or usually we are generating it on a monthly basis. See, it can be done on the basis of the word wise also. So here the data is word wise. Okay. So in one word, we found the doctor compliance was 59%. Nurses compliance was 85%, and others and allied staff compliance was 69%. Okay. So, and we are finding both the total compliance and the partial compliance to hand hygiene. So that is how we are tracking hand hygiene compliance, and we have to do the root cause analysis, and kappa has to be taken accordingly. This is the BMW audit compliance across different words. I'm not going into the details of this. Now the bundle care audit compliance, this is also done word wise. So each word, there are certain colors here. So, sorry. So red stands for central line compliance. The yellow stands for urinary catheter compliance, and blue stands for ventilator compliance. So ventilator is not there in the non-critical words. So in the non-critical words, the ventilator compliance, in some cases, the CLAPSI compliance are also not taken into care. So only the COTI compliance applies to all the words. So here, word-wise, we find the compliance to the bundle care. So in this word, particularly BC Roy word, say 80% compliance to central line and only 47% compliance 47% compliance. Units say here this Mother Teresa ITU. So here you find that 100% compliance, 100% compliance to ventilator, 56% compliance to urinary catheter bundle, and 78% compliance to central line. This compliance is also calculated on a monthly basis from the IVAR app. So if you do it manually, you have to do it on a based on a checklist, and you have to capture the realistic data. You have to visit the wards. The infection control officer nurses may divide the wards amongst themselves, and go there and find the actual compliance rate, and the end of the month they have to manually calculate it. So it's easy if you do it on an Excel sheet and plot the data on an Excel sheet, and from there you can do the calculations. So we do the root cause analysis of bundle care non-compliance. We find out where was the different points, questions, whether the dressing was changed or not, whether the CHD2, that is chlorhexidine packed with 70% alcohol for dressing changes were used or not. So we find the percentage of this. Then hand hygiene, assessment of readiness to remove the documented. Okay, alcohol have decontamination, perineal care, vaginal or meatal care. All these things are taken care of in different types. So first, these are the central line compliance points. These are the urinary catheter compliance points, and these are the ventilator compliance points. So accordingly, we find out what was the compliance in different sector of this bundle. Okay, and then accordingly we do the root cause analysis. After root cause analysis, we take the corrective action. And if the compliance is still low after taking the corrective action, we take the preventive action, mainly training of the staff. Okay. So corrective action and preventive action for CLAPSI, regular training on central line bundle care is being conducted for all nurses, including flushing of the central line, scrub the hub with alcohol swab, hand hygiene practices, close supervision and continuous audit through IVR app is being performed. And any non-compliance noted are being pointed out to improve compliance to prevent CLAPSI. So this is COTI root cause analysis and CAPA. Continuous training classes were conducted for the prevention of COTI. Urometers and valve fitted to prevent the backflow of urine. Urobags were introduced in our hospital because we had a high COTI rate 2 years back. Now our COTI rate is nearly 0%. Okay. So after introducing these urometers and valve fitted urobags, which have a sample port, this has prevented COTI to some extent. And continual audits and re-audits through the IVR app. So this is the high dashboard for the last few months. So here the different types of COTI rates, monthly COTI rates, monthly CLAPSI rates, monthly VAE rates, and the SSI rates monthly are being tracked. And we are getting all the data from the IVR app. But if you do it manually, you have to calculate it on the manual basis. Okay. So I'm not going into the different definitions because the definitions are known to all of you. COTI, CLAPSI, and VAE, these are calculated per 1,000, say, urinary catheter days, per 1,000 bloodstream infection, that is 1,000 central line days, 1,000 ventilator days, like that. But SSI is calculated as a percentage of total number of surgeries, including major and minor surgeries conducted in the OTs. So this is a process flow of COTI: record device insertion and removal, record the symptoms. Then you can do the apply device and symptom criteria. Then urine culture is done, whether the patient is symptomatic. Apply urine culture result, whether it's growth or no growth. If urine culture is positive, apply COTI identification CDC rules. Approve whether case is COTI or not. So all these are as per the CDC guidelines we are tracking to diagnose an nosocomial infection or urinary tract infection, whether it is catheter associated urinary tract infection or not. Okay. So this is the COTI dashboard. Okay, this is also the monthly COTI rates. We can do it word-wise also. This was a total rate in the hospital. You see the COTI rate is very low in our hospital. It was actually 0% in several months. And whenever we had one case of COTI, the rate was around, it was less than 1 per 1,000 in most of the months.
Yes, yeah.
Okay. So this is the CLAPSI record flow. Okay, CLAPSI flow, the process flow. Record the device insertion, removal, record symptoms, applies device criteria, then blood culture is done, whether it's done or not. If it is not done, then blood culture request by clinician. If the blood culture is sent, then apply blood culture result, whether it's positive or not. If it is positive, then apply the CLABSI identification CDC rules and approve whether it is a case of CLABSI or not. So it's very easy to follow this process rule, this process flow, and identify an infection, a bloodstream infection, whether it's CLABSI or not. So this is the CLABSI dashboard over the months, and this is the CLABSI rate. So CLABSI increased in certain months. Say October 2023, the CLABSI rate was nearly 3%, 3,000. Okay, this is not percentage. Sorry for the mistake here. It's as per thousand. Okay. In February 2024, it was 2.14, and in March 2024, it was 1.97. So we had 4 cases of CLABSI in February and 3 cases in March and 6 cases in October 2023. So we did the root cause analysis and we took the kappa accordingly. So mainly in October, there was a whenever there are certain outbreaks, say influenza outbreak or a COVID outbreak or any such outbreaks, we are finding the rates of COTI or CLABSI, rates of CLABSI climbing up during those periods, and particularly after new recruits. In October or in January, many of the, in September, in July to September, and in January, many new nurses joined. So after that, we find that the rates are going up, or probably they are not properly trained when to track or to take care of the bundles. So this is VAE flow. I am not going into the details of this. So this is the high dashboard for VAE. So we didn't have any case of VAP or PVAP over the last 1 year, but we had some cases of IVAC. Okay. So we had 1 case of IVAC in September 2023 and 2 cases in March 2024. After that, also we have followed this infection-associated ventilator-associated complication, that is IVAC. So we are tracking IVAC also in our hospital through the IVAR app. This is SSI tracking and follow-up process, because most of the patients after surgery, they are discharged after 2 to 3 days. But after that, they have to be followed at home. So frequent phone calls to the patient to find out whether they are following the instructions given in the hospital, or they are having any such symptoms of SSI. So that is also done, and they are encouraged to visit the hospital whenever a symptom or sign suggestive of SSI, where a symptom suggestive of SSI is identified. So the patient is observed, observation through mobile contact, inpatient care, SSI, home events, update lab information in the web, and SSI evaluation is done in the web, that is in the IVAR app, and SSI confirmation is also done like that. But SSI does not want a positive culture. Unlike in the other cases, CLABSI, COTI, and VAE or VAP, we have to have a positive culture report. But in SSI, even with a negative culture report, if the surgeon diagnoses it as a case of SSI, then it stands as an SSI. It's not necessary for a culture proven, for a culture to be positive to stamp it as an SSI. So surgery register, home surgeries, then SSI calls that I have already told you. So this is the wound classification, different types of wound: clean, contaminated, dirty. This has to be filled in by the surgeon after the surgeries. Then pathos is important, present at the time of surgery, visible pus, abscess, or operation site. At operation site, documented in OT note or not. And then the SSI, superficial incisional, then deep SSI, and organ space SSI. This checklist has been prepared just as per the NHSN or CDC guidelines. If you go into the website of CDC, we'll get all these guidelines, and they are updated every year. So please have the latest update with you. And this is SSI format from the OPT. The nurses in the OPD, mainly the daycare nurses who are there in the OPD, are trained about how to track the patients, whether they have any symptoms of SSI. They also are trained. Besides, the surgeons are also encouraged to report all SSI cases to the microbiologist or to the infection control nurse when they are coming for visits. Whether there is discharge from operation site, whether there is pain or swelling or redness or heat, incision is deliberately opened by the surgeon, or fever or culture sent from the wound. So culture happens to be one of the criteria, but it is not a foolproof criteria. It's not actually mandatory criteria. Okay. So this is SSI rate in our hospital. After we tracked the SSI, started tracking SSI through IVR app and through regular surveillance, keeping in touch with the patients over phone. Then the SSI rates, SSI is actually underdiagnosed, somehow underdiagnosed. But now we are getting 1 or 2 cases of SSI. We are diagnosing once every month. Okay. So these are the total HAI cases in our hospital over the last 6 months, say October to March 2024. And these were the high rates as per the, these are the line diagram. So high rate was high in October and November. Then in December also it was high. Then it came down in January, February, and March. So these are the actually the benchmarks. The benchmark was calculated in our hospital based on the percentage of different types of infections in the last 2 years. Over the last 2 years, the average of the different infections are taken. So the total benchmark for 2023 was 1.25 per percent, that is percent, total nosocomial infection rate. And it came down to 0.88% in 2024. And this is the actual rate month-wise. So it was 0.7% in October, came down to 0.57% in November, again went up to 0.78% in December. The highest rate was in March, that is 1.19%. That was the nosocomial infection rate in our hospital, total. So high benchmarks are changing. In 2022, these were the high benchmarks for different infections. CLABSI, it was 8.19 because during the COVID times, we had high rates of CLABSI. So the benchmark also went up. Then it came down to 6.5 per 1,000 in 2023 and 2.97 per 1,000 central line days in 2024. So the benchmark also continues changing per year. And this is the NSI rate that is also tracked. So we are having NSIs, particularly through pen insulin and those devices. And this is the fishbone analysis to identify the causes of NSI and how to take care of the NSI. Root cause analysis is done through this. Then risk mitigation, as I already told you, the construction, renovation, after construction, renovation, demolition, and this is continuously going on in our hospital. So we have to fill in a checklist and do the risk mitigation. Then other measures, I have already told you, water supply to be sent, drinking water samples regularly for potability, particularly the RO water for sterility check once every month or sometimes once every fortnight. The screening of hospital personnel for nasal swabs and nail clippings for bacterial carriage is done only during outbreaks. That is, outbreak is say 2 or more infections by the same organism in 2 or 3 patients who are admitted in the same ward or in the hospital at a point of time. Then kitchen hygiene, homogeneous diet culture, AC filters and ducts should be manual. They should be manually cleaned every month, and those things. Monitoring of sterilization and disinfection. So we do it with the chemical indicators, with every load and biological indicators at least once weekly. And sterile supplies are also monitored for sterility once new batch is opened. And environmental sampling is actually not very cost effective. It's a time consuming process. So it's not recommended by CDC. It is recommended only for 4 situations: to support an investigation of an outbreak of a disease of infections, for research purposes, to monitor a potentially hazardous environmental condition, and for quality assurance projects. So only 4 types of routine environmental microbiological sampling that are recommended are biological monitoring of the sterilization process by using the bacterial spores, monthly culturing of water used in hemodialysis, that is RO water should be cultured at least monthly or fortnightly. Then periodic environmental sampling to evaluate the microbial or particulate quality for regular maintenance of the air handling system, particularly the HEPA filters, and the biological safety cabinets and the laminar airflow cabinets should also be checked for sterility at least on a fortnightly basis. And the most important, most common method by which we are doing it is by the sampling method, that is the air culture method or settle plate method. So air sampling can be done with air sampler, but most of the hospitals do not have the air samplers. So we are doing it by the settle plate method. So acceptable limit for if you have the slit air sampler, the colony count should be less than equal to 35 CFU per cubic meter in general OTs and less than 10 CFU per cubic meter in neuro OTs when OT is empty. Okay. And the colony count should be at least less than equal to 180 CFU per cubic meter when the OT is functioning. But for the settle plate, acceptable colony count per plate in OT is 10 colonies, less than equal to 10 colonies in general OTs and less than equal to 2 colonies in neuro OT. Okay. Settling per 9 centimeter placed exposed for 60 minutes, that is 1 hour. For biosafety cabinet and laminar airflow cabinet, they should be put for 10 minutes only with the airflow on to check the efficacy of the UV lamp. Another is the surgical prophylaxis risk categorization, because most clean and clean contaminated surgeries, they need only a single agent, mostly first or second generation cephalosporin, either a single dose or not more than 48 to 72 hours post surgery. And duration of prophylaxis should not be more than this time. And we have the antimicrobial stewardship audit tool also, say alternate 2 or 3 days, so twice or thrice weekly, the microbiologist, the pharmacologist, the infection control nurse, the critical care specialist, and one surgeon are in the team, AMS team. They are visiting the wards and visiting the patients on antibiotics and seeing their antimicrobial stewardship, whether the antibiotic choice is appropriate or not. If not, then they are suggesting to change the antibiotic protocol. Okay, so this is the data that we are gathering, the AMS data. So the most important measure, the challenging aspect is the duration of surgical prophylaxis. We are finding it to be much less because the antibiotics for surgical prophylaxis, they are unnecessarily being continued for 5 days or 7 days in the patients. So that is the most challenging aspect that we are facing regarding antimicrobial stewardship, that is a surgical prophylaxis. In the medical words, the patients, the antimicrobial stewardship is slowly improving, and it has improved a lot over the last 2 years. But the surgical prophylaxis, the duration of prophylaxis is not at all improving. So duration of prophylaxis is around in the order of the compliance to duration of prophylaxis is in the order of 40 to 60% maximum, not going up before that, above that. Okay. So proper hand hygiene, I will end my presentation by again emphasizing on proper hand hygiene, because that can reduce the nosocomial infection rates by approximately 1/3. So infection control is in our hands. Practice meticulous hand hygiene. So that is all from me. Thank you very much for your patient hearing. If there are any questions, I can take them now.
Thank you. We are honored for your presence.
Okay.
If anyone has any questions, please ask. Anyone? Okay.
Okay.
Thank you, sir, for sharing your insights. Now, moving ahead. Legal aspects in medical practice ensure patient rights and healthcare provider accountability, safeguarding both parties. Physicians must adhere to laws regarding consent, confidentiality, and malpractice, which protect patient welfare and professional integrity. Understanding these legal frameworks is crucial for minimizing legal risk and delivering ethical, compliant medical care. With this, I would like to invite our in-house speaker, Head and Professor, Department of Hospital Administration, Dr. Rajesh Harshvardhan, sir, to speak on his topic, legal aspect in medical practice. Given by him.
वहाँ दिख तो नहीं रहे थे
के इस 31वें एपिसोड में आपकी निरंतर सहभागिता और सहयोग से ये शो अब तक 1 लाख से भी ज़्यादा बार देखा जा चुका है। इस कार्यक्रम की शुरुआत माध्यम से यहाँ से बहुत सारे विषयों पर विभिन्न एपिसोड प्रसारित होते हैं। हमारे अगर आप आज तक के एपिसोड्स की बात की जाए तो बहुत सारे विभिन्न विषयों से संबंधित मुद्दों पर चर्चाएं की गई हैं। इनमें महत्वपूर्ण हैं कार्डियोलॉजी, अस्थमा, डायबिटीज़, उच्च रक्तचाप, सर्वाइकल कैंसर, गर्भावस्था संबंधी जटिलताएं, नवजात शिशुओं की देखभाल और भी बहुत सारे महत्वपूर्ण विषय। ये सभी पुराने एपिसोड्स जो हमारे हैं वो चैनल की प्लेलिस्ट में भी उपलब्ध हैं और इनसे संबंधित प्रेजेंटेशन SIHFW की वेबसाइट्स पर भी देखे जा चर्चा करने के लिए आज हमारे बीच जो उत्तर प्रदेश में ही नहीं बल्कि पूरे देश भर में इस विषय के एक बहुत ही महत्वपूर्ण विशेषज्ञ हैं, वो हमारे बीच आज उपस्थित हैं। डॉक्टर राजेश हर्षवर्धन जी, आप अस्पताल प्रशासन विभाग, संजय गांधी स्नातकोत्तर आयुर्विज्ञान संस्थान लखनऊ में प्रोफेसर एवं विभागाध्यक्ष हैं। इसके साथ ही आप एपेक्स ट्रामा सेंटर के अतिरिक्त चिकित्सा अधीक्षक और क्वालिटी के सब डीन के रूप में भी अपनी सेवाएं दे रहे हैं। डॉक्टर साहब के बारे में आप ऐसे ही जान सकते हैं कि वो थ्रू आउट गोल्ड मेडलिस्ट रहे हैं। इन्होंने बहुत सारे MBBS, MD और बाकी आगे की PhD वगैरह की डिग्रीज भी की हैं। यहाँ में भी पढ़ाई की है और फॉरेन से भी इन्होंने डिग्रीज ली हैं। आपके बहुत सारे रिसर्च पेपर प्रकाशित हो चुके हैं और आप विभिन्न संस्थानों में जा करके इस विषय पर लोगों को जागरूक करते हैं और लोगों का ज्ञानवर्धन करते हैं। तो आज हम डॉक्टर राजेश हर्षवर्धन जी का स्वागत करते हैं और उम्मीद करते हैं कि आज का एपिसोड हम सभी के लिए बहुत ज्ञानवर्धक होगा और उपयोगी साबित होगा, क्योंकि आज क्लिनिकल साइड से हट करके एडमिनिस्ट्रेटिव साइड की हम लोग बात करेंगे जो बहुत ही महत्वपूर्ण है। और इस इंट्रोडक्टरी सेशन के साथ मैं डॉक्टर साहब का एक छोटे से मेमेंटो के माध्यम से स्वागत करना चाहूँगा। स्वागत है डॉक्टर।
Thank you very much, sir. Thank you.
नाउ ओवर टू यू डॉक्टर साहब।
You're welcome. Thank you.
ये क्या हो
कहाँ होगा?
नवजात शिशुओं की देखभाल और भी बहुत सारे महत्वपूर्ण विषय। ये सभी पुराने एपिसोड्स जो हमारे हैं वो चैनल की प्लेलिस्ट में भी उपलब्ध हैं और इनसे
है इस कार्यक्रम का जो उद्देश्य है बहुत ही मीनिंगफुल है, सो दैट हार्नेसिंग द आईटी टेक्नोलॉजी और आईटी मीन्स ऑफ डिस्सेमिनेशन इंफॉर्मेशन, प्रत्येक शुक्रवार को एक विषय विशेषज्ञ को बुला करके स्पेसिफिक विषय पे हम परिचर्चा करते हैं, ताकि जो लोग सुदूर जिलों में 75 जनपद में अपनी सेवाएं दे रहे हैं पीएमएचएस केडर में, वो इससे लाभान्वित हों और खुद को अपग्रेड कर सकें। विषय जो आज हमें दिया गया है वो है ब्रॉड हेडिंग जो है या ब्रॉड सब्जेक्ट है वो हॉस्पिटल एडमिनिस्ट्रेशन है, अस्पताल प्रशासन। मैं दो इस पे लेना चाहूँगा, दो मिनट इस पे लेना चाहूँगा। मैं ये बात आपके समक्ष रखना चाहता हूँ कि आप चाहे आप एज ए सीएमओ काम कर रहे हों एक ज़िले में, एक जनपद में, या एज मुख्य चिकित्सा अधीक्षक काम कर रहे हों किसी डिस्ट्रिक्ट हॉस्पिटल में, और मे भी आप अधीक्षक रूप में काम कर रहे हों किसी सीएससी सामुदायिक स्वास्थ्य केंद्र या किसी पीएससी पर। मूलतः आपकी जो ट्रेनिंग हुई है, जो आपकी पढ़ाई हुई है, वो मूलतः चिकित्सा विज्ञान के क्षेत्र में हुई है। प्रशासन के क्षेत्र में जहाँ तक मैं समझ सकता हूँ शायद आपने कोई विशेष प्रशिक्षण या कोई उपाधि प्राप्त नहीं की है, लेकिन बाई डिफ़ॉल्ट, बाई वे ऑफ योर ऑफिशियल ऑब्लिगेशन, आप सब लोग शनह शनह क्रमशः जैसे जैसे आपकी सीनियरिटी बढ़ती है आपके पास प्रशासनिक दायित्व आने लगते हैं, जिसके लिए आपका प्रशिक्षण प्रोफेशनल वे में होना काफ़ी ज़रूरी है। इसलिए जब मुझसे ये अनुरोध किया गया कि मैं इस विषय पे आपसे मुखातिब हूँ, आपसे रूबरू हूँ, तो मैंने सोचा कि चिकित्सा प्रशासन एक काफ़ी विस्तृत क्षेत्र है। हम लोग इसको ऐसे कहते हैं कि हेल्थ केयर डिलीवरी, द वर्ड इज़ हेल्थ केयर, जिसके तीन वर्टिकल हैं, हेल्थ केयर प्रोवाइडर, हेल्थ केयर ऑर्गेनाइजेशन एंड हेल्थ केयर सीकर। हेल्थ केयर प्रोवाइडर जो है, प्रोवाइडर है, वो डॉक्टर एंड पैरामेडिकल की टीम है। हेल्थ केयर ऑर्गेनाइजेशन वो है जो हॉस्पिटल्स, इंस्टीट्यूशंस, मेडिकल कॉलेजेस, पीएससी, सीएससी, डिस्ट्रिक्ट हॉस्पिटल्स वो हैं, और हेल्थ केयर सीकर्स वो हैं पेशेंट्स जो सेवाएं ले रहे हैं। तो पहले तो आपको ये जानना है कि आज के टर्म में, आज की भाषा, आज के समय में इसकी स्टैंडर्ड भाषा क्या है, और वो है हेल्थ केयर प्रोवाइडर, हेल्थ केयर सीकर एंड हेल्थ केयर ऑर्गेनाइजेशन। नौ दूसरी बात, अस्पताल प्रशासन के का जो आयाम है, जो स्पेक्ट्रम है, वो काफ़ी बड़ा है। इट्स क्वाइट एक्सटेंडेड एंड इट हैज़ गॉट मैनी वर्टिकल्स। कम से कम इसके 50 सब वर्टिकल्स हैं सारे। इसके हम इसके डिवीज़न को मिला लें, एक व्यक्ति जब वो एक अस्पताल का प्रशासन कर रहा होता है एज अ चीफ मेडिकल सुप्रिटेंडेंट और मेडिकल सुप्रिटेंडेंट और विच एवर वे, उसको कम से कम 50 मूल वर्टिकल्स या डिविजन्स को देखना होता है अपार्ट फ्रॉम पेशेंट केयर। तो हम प्रशासक की भाषा में हम कहते हैं जो हेल्थ केयर शब्द है उसका दो टुकड़ा है, इसके दो पार्ट हैं। एक पार्ट है क्लिनिकल केयर, दूसरा पार्ट है मेडिकल केयर। क्लिनिकल केयर वो पार्ट है जब आप एक डॉक्टर के रूप में अपनी सेवाएं दे रहे होते हैं, पेशेंट को ऑपरेट कर रहे होते हैं, वार्ड में देख रहे होते हैं, ओपीडी में देख रहे होते हैं, दैट्स द क्लिनिकल पार्ट वेयर इन यू आर वर्किंग सोनली एज अ क्लिनिशियन एंड यू आर रेंडरिंग क्लिनिकल केयर either in the OPD or OT or in ICU or SDU or wherever। लेकिन इस क्लिनिकल केयर को देने के लिए, in order to provide this clinical care, you need a system, you need a healthcare organization, you need an entire team, you need infrastructure, you need equipment, you need manpower, you need supplies। बहुत चीज़ों की आवश्यकता होती है। जब वो सारी चीज़ें एक जगह लॉजिकली अरेंज हो जाती हैं तभी कोई ये क्लिनिकली ट्रेन्ड क्लिनिशियन कैन डिलीवर क्लिनिकल केयर टू द पेशेंट्स। तो दूसरा पार्ट है जहाँ पे हम डायरेक्ट पेशेंट केयर ना दे रहे होते हैं, उसको मेडिकल केयर कहते हैं। मेडिकल केयर एंड क्लिनिकल हेल्थ केयर। सो हेल्थ केयर को हम कंपार्टमेंटलाइज करेंगे, उसका 25% क्लिनिकल केयर है। अगर एक सर्कल बनाएंगे, 1/4 इज क्लिनिकल केयर and 75% is medical care, which is non-clinical care। हॉस्पिटल में बिल्डिंग होनी चाहिए, बेड होनी चाहिए, इक्विपमेंट होंगे, मैन पावर होंगे, उनकी ट्रेनिंग होगी, कैपेसिटी बिल्डिंग करना है, एडमिनिस्ट्रेशन है, एस्टैब्लिशमेंट है, फाइनेंशियल मैनेजमेंट है, बजटिंग है, प्रोक्योरमेंट है। देयर आर 1000 थिंग्स दैट इज टेकन केयर ऑफ फॉर हॉस्पिटल टू बी एन एफिशिएंट हेल्थ केयर organization, healthcare provider to render quality healthcare service. तो आप ये बात आप समझ गए कि दो प्राइमरी डिवीजन है, क्लिनिकल केयर जो कि 25% पार्ट है पूरे हेल्थ केयर डिलीवरी का, और 75% पार्ट है मेडिकल केयर, जो आज भी क्लिनिशियन के द्वारा ही आम तौर पे देखा जा रहा है। लेकिन अब समय बदल गया है और बदल रहा भी है। द टाइम हैज चेंज, इज चेंजिंग एज वेल, वेयर इन ग्रेजुअली हायर इंस्टीट्यूशंस में तो आ ही गए हैं, मेडिकल कॉलेज में भी आ गए हैं, जहाँ पे डिपार्टमेंट ऑफ हॉस्पिटल एडमिनिस्ट्रेशन, अस्पताल प्रशासन विभाग एक स्वतंत्र प्रोफेशनल विभाग के रूप में कार्यरत है। और वो मेडिकल केयर पार्ट ऑफ हॉस्पिटल एडमिनिस्ट्रेशन जिसको हम कहते हैं उसको देख रहा है, जबकि जो डायरेक्ट पेशेंट केयर डिलीवरी है, जो क्लिनिकल केयर का आर्म है, वो क्लिनिशियन देख रहे होते हैं, एंड टुगेदर दे प्रोवाइड द हेल्थ केयर। नाउ आज का विषय मैंने कोर हॉस्पिटल एडमिनिस्ट्रेशन या मेडिकल केयर का चूज नहीं किया है, बिकॉज ये मेरा पहला टॉक है इस आपके शुक्रवार की शाम डॉक्टर के नाम प्रोग्राम में। तो मैंने एक ऐसा बिंदु उठाया है जिसका सरोकार दोनों तरफ से है, और वो बिंदु है लीगल एस्पेक्ट ऑफ मेडिकल प्रैक्टिस। क्योंकि जब एक क्लिनिशियन अपनी सेवा दे रहा होता है तो कई बार ऐसी स्थितियां बनती हैं जहां पे थिंग्स मे गो रॉन्ग, या अभी हम आगे आएंगे। और जब व्हेन थिंग्स गो रॉन्ग देन इट स्टार्ट्स इम्पैक्टिंग द एडमिनिस्ट्रेशन, तब उसका जो एडवर्स इम्पैक्ट है वो प्रशासन पे पड़ता है, और देन एडमिनिस्ट्रेशन टेक्स ओवर एंड डील्स विद दैट सो कॉल्ड alleged मेडिकल नेग्लिजेंस। तो आज हम आपके पास आए हैं इस विषय पे बात करने के लिए, जहाँ पे मैं आपसे मुखातिब होऊंगा और आपको बताना चाहूँगा कि एज ए डॉक्टर इन बोथ द कैपेसिटी, इधर एज ए क्लिनिशियन और एज एन एडमिनिस्ट्रेटर, एज अ मेडिकल स्टूडेंट, एज अ CMS, एज अ CMO, आपको बेसिक बातें क्या जाननी चाहिए। इसलिए मैंने आज एक हाइब्रिड टॉपिक का चुनाव किया है, rather than going specifically a specific segment of hospital administration. I thought it would be appropriate of me to begin with a topic which is at the juncture, at the crossroads of both the dimensions, the clinical care and the medical care, the patient care and the hospital administration, and this is one such topic. मैं अभी आपको gradually over the course of time मैं आपको बताऊंगा कि लीगल एस्पेक्ट ऑफ मेडिकल प्रैक्टिस में के कॉन्टेक्स्ट में, के परिप्रेक्ष्य में, के दायरे में, व्हाट ऑल यू आर सपोज टू नो, व्हाट ऑल यू आर सपोज टू अंडरस्टैंड, व्हाट आर द फंडामेंटल टेनेट्स which you must be aware of in order to be sure of the fact that the clinical care you are rendering as a clinician doesn't impact you adversely, or for the administration it should not become a challenge if something goes wrong at all in any case. मैं शुरुआत करूंगा इस तरीके से, जो मेरा कंडक्ट प्रोटोकॉल आपके सामने स्क्रीन पे दिख रहा होगा, कि लॉ है क्या, लॉ के टाइप्स, कितने तरह के लॉ होते हैं, क्या इसका रोल है हमारे हेल्थ केयर डिलीवरी में, क्या इसका इम्पोर्टेंस है फॉर क्लिनिशियंस, क्यों ज़रूरत है हमारे प्रशासक को इसको जानने की, कहाँ पे देयर आर इंटरसेक्शंस बिफोर आई कम टू द मेन टॉपिक, कोर टॉपिक अंडर इट, दैट इज़ मेडिकल नेग्लिजेंस। फिर हम बात करेंगे कि अगर मेडिकल नेग्लिजेंस क्या है, कब हम कहते हैं मेडिकल नेग्लिजेंस है, क्या सावधानियां बरतनी चाहिए, इससे संबंधित कानून क्या है, कंज्यूमर प्रोटेक्शन एक्ट 1986, हाउ इट डील्स विद द केसेस ऑफ alleged cases of medical negligence, and thereafter we will see couple of cases and we will discuss with you few cases which were actually dealt with the judiciary in our country, either at the level of High Court or Supreme Court or wherever. So this is the generic outline of my talk today. I hope you will find it interesting, and I also believe that it will at least help you understand, develop a perspective to look at. लेकिन इससे पहले कि मैं आपसे कानून की बात करूं, या लीगल एस्पेक्ट ऑफ मेडिकल प्रैक्टिस की बात करूं, या मेडिकल प्रैक्टिस में, या क्लिनिकल प्रैक्टिस में, या हेल्थ केयर में, या मेडिकल केयर में एज एन एडमिनिस्ट्रेटर और एज ए क्लिनिशियन कानून के डिफरेंट जो डायमेंशन है या डिफरेंट जो लॉ हैं उसका जिक्र करूं, इसके पहले ये मेरे लिए ये आवश्यक हो जाता है कि मैं आपको ये बताऊं कि एक और वर्ड है, एक और शब्द है, एक और डोमेन है, एक और दायरा है जिसको हम लोग कहते हैं एथिक्स। एथिक्स और लॉ, दीज आर टू म्यूचुअली एक्सक्लूसिव डोमेन। दोनों अपने आप में बिल्कुल अलग डोमेन है, अलग विभाग है, अलग ब्रांच है। कोर लॉ पर आने के पहले मैं आपको थोड़ा बताना चाहूँगा एथिक्स के बारे में भी। एथिक्स क्या है? एथिक्स की बारे में थोड़ी चर्चा करने के बाद हम शिफ्ट करेंगे लॉ पर। एथिक्स के बारे में आपको इतना बताना चाहूँगा, दो आई हैव गॉट अ केस स्टडी, रियल टाइम केस स्टडी फ्रॉम अ प्रीमियर इंस्टीट्यूट ऑफ द कंट्री, जहाँ पे एक एथिकल डिलेमा क्रिएट हुआ था। और ये केस था, अ पेशेंट वॉज हैविंग ए neurological condition and he was put on ventilator in an ICU, or there was no possibility of his life to continue without ventilator, and there was no definite treatment, either therapeutic or palliative, are available to take care of that patient. अगर उसकी लाइफ सपोर्ट हम हटा लेते हैं तो पेशेंट विल ऑब्वियसली there would be, he would die, और अगर हम रखते हैं तो देयर इज नो एंड टू इट। तो ऐसी स्थिति में आप क्या करेंगे? आप अपने हॉस्पिटल में अगर ऐसा पेशेंट है जिस पर, जो कि लाइफ सपोर्ट पे है, इफ यू विड्रॉ लाइफ सपोर्ट द पेशेंट विल लूज लाइफ। If you don't withdraw life support, your one bed is occupied and there is more serious patient waiting outside who can be taken on that bed, and his life is, his diagnosis is, his disease condition is treatable and you can save one life. But you are not able to do that only for the fact that your bed is occupied with a patient whom you cannot save and is simply there on the bed with the life support devices. ऐसी स्थिति में क्या करेंगे? Therein comes the role of ethics. आज के डेट में, इस वक्त तक हमारे देश में इस पर कोई कानून नहीं है। रिसेंटली गवर्नमेंट ऑफ इंडिया, मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर ने एक ड्राफ्ट तैयार किया है पर्टेनिंग टू विड्रॉल ऑफ लाइफ सपोर्ट, जिसमें 20 अक्टूबर तक पब्लिक से कमेंट मांगा गया है बिफोर इट गोज टू द process of legislation and eventually a law is promulgated on it. But इस वक्त तक, till this point in time, there is no law, no statute, no rule, no regulation, no government order, no executive order on account of this topic. Then what will you do in that case? आप क्या करेंगे ऐसी स्थिति में? एक पेशेंट बाहर वेट कर रहा है, उसको इलाज करके उसकी जान बचाई जा सकती है, और हमारे पास एक ही पेशेंट है जिसको हम सारी मेडिकल नॉलेज, फैसिलिटी और एक्सपर्टीज के बावजूद उसको हम सेव नहीं कर सकते, एंड ही इज कंटिन्यूइंग ऑन द बेड विथ लाइफ सपोर्ट, एंड देयरइन कम्स द रोल ऑफ एथिक्स. दैट्स व्हाई आई वांटेड टू मेक यू अंडरस्टैंड दिस फर्स्ट बिफोर आई गो टू लॉ subsequently. I will skip this case because it will take time. I have given you the brief idea about the case that I wanted to discuss with you at length had I been more time, which I don't have for now. But आपको मैंने इसका सार समझा दिया है. अब हम देखेंगे कि एथिक्स क्या है और एथिक्स के संबंध में आपको क्या क्या जानने की जरूरत है, और लॉ कब एथिक्स लॉ में कन्वर्ट हो जाता है. मैं आपको एक एग्जांपल भी दूंगा. सो इस केस में क्या होगा, आई एम लिविंग यू टू अप टू यू टू पॉन्डर. मैंने छोड़ दिया आपको सोचने के लिए. अब मैं आता हूं अपने प्राइमरी टॉपिक पे, एथिक्स पे. एथिक्स क्या है? I want to make you understand this word before I switch on to law. Why? Because इसको ऐसे अगर मैं समझाऊं, for any concern, any issue, any problem, any challenge, जिसके लिए एक पर्टिकुलर कंट्री में, एक स्टेट में, एक नेशन में कोई लिखित कानून अवेलेबल नहीं है, देन वैसी स्थिति में उस विषय को हम कैसे डील करेंगे, हाउ विल रिस्पॉन्ड टू दैट कंसर्न, जो अभी आपको मैंने एग्जांपल शेयर किया बेड वाला. व्हाट विल यू डू इन दैट केस, हाउ विल यू अराइव एट अ डिसीजन. सो इन दैट केस ethics has some role to play. Or in other words, for all those concerns जिसके लिए written law available है, वह law के दायरे में आता है, and for all those concerns जिसके लिए written कोई भी लिखित कानून, अध्यादेश, अधिनियम, रूल, रेगुलेशन, ऑर्डर कुछ भी अवेलेबल नहीं है लिखित में, then in that case that situation has to be dealt with from the fundamentals of ethical concepts. आप समझ रहे मेरी बात? Ethics is something which is not covered under law. अगर उस विषय पे लॉ है तो फिर एथिक्स पे कभी नहीं आएगा वो. एथिक्स का रोल तभी आता है जब उस विषय पे कोई कानून बना ही ना हो. अगर बायोमेडिकल वेस्ट मैनेजमेंट रूल है तो उसका कोई भी बिंदु एथिक्स पे नहीं आएगा. It won't be considered from the perspective of ethical codes. Like Medical Council of India has got Code of Medical Ethics. तो वो चीजें यहाँ पे प्रख्यापित या लागू नहीं होंगी क्योंकि we have got a specific law for this. Likewise, MTP Act. Likewise, PCP and DT Act. Provision of the determination of gender of the baby prior to birth. Likewise, Environment Protection Act. तो इतने जो कानून है, जब कानून अगर है तो एथिक्स का कोई रोल नहीं है. जिस विषय के लिए, जिस विषय वस्तु के लिए कानून अवेलेबल नहीं है, कोई भी लिखित कानून नहीं है, इन ओनली इन दैट केस वी एज एन आर्बिटर, द वन हु इज डीलिंग विद द केस, हैज टू डिपेंड अपॉन द एथिकल कोड्स और एथिकल गाइडलाइंस. सो दैट इज द बैकग्राउंड. नाउ एथिक्स क्या है, इसके लिए थोड़ा सा हम विल ट्रेवल बैक इन टाइम. एथिक्स आर एक्चुअली linked with two words, values and morality. What are values? Values are the degree of the conviction about something, the way we conduct our life. What I mean to say, अगर कोई एक व्यक्ति गवर्नमेंट सर्विस में है तो उसकी एक प्रोफेशनलिज्म है that he will come in time, he will maintain punctuality, or he will not take bribe, or he will not do something wrong. So value is the belief system that an individual develops during the initial formative years of his life or her life. Initial formative years of one's own life, each one of us develop our belief system about what is right and what is wrong. क्या सही है और क्या गलत है, इसकी जो परिभाषा हमारे मन में है, इसकी जो अवधारणा हमारे मन में है, इसकी जो समझ हमारे मन में है, उसको हम वैल्यू कहते हैं. इट इज ऑलवेज इंडिविजुअल. इट वेरीज फ्रॉम इंडिविजुअल टू इंडिविजुअल, कल्चर टू कल्चर, कंट्री टू कंट्री, रिलीजन टू रिलीजन. कोई एक बात सही माना जाए अगर किसी एक देश में या एक समाज में या एक संस्कृति में या एक धर्म में, वो हो सकता है कि उसको सही ना माना जा रहा हो किसी और परिप्रेक्ष्य में. तो वैल्यू इज ऑलवेज सब्जेक्टिव. ये व्यक्तिनिष्ठ होता है और इट वेरीज फ्रॉम, there could be different belief system between siblings in the same family even. एक ही घर के, एक ही परिवार में दो भाई बहनों के बिलीफ सिस्टम अलग हो सकते हैं. तो वैल्यूज आर द एक्यूमुलेटेड बिलीफ सिस्टम. आपके सारे बिलीफ सिस्टम अबाउट गुड एंड बैड, राइट एंड रॉन्ग को हम वैल्यू कहते हैं. वैल्यूज आर ऑफ 3 टाइप्स: एब्सोल्यूट वैल्यू, कोर वैल्यू एंड पेरिफेरल वैल्यू. एब्सोल्यूट वैल्यू है जिससे आप कभी भी कॉम्प्रोमाइज नहीं करेंगे. Absolute values are those values which you will never compromise. महाराणा प्रताप ने कहा कि हम मुगलों की अधीनता कभी स्वीकार नहीं करेंगे चाहे मेरी जान क्यों न चली जाए. He was a nationalist to that degree. So eventually he lost his kingdom. He died also in the forest, but he never compromised. Absolute Gandhi, Mr. Gandhi, he never compromised on 2 of his absolute values: non-violence and truth, satya or ahimsa. Absolute values are those belief systems which you never compromise. चाहे कुछ भी हो जाए, आपकी जान क्यों न चली जाए. They are absolute values. Then comes the core values. Core values are your usual code of conduct. जो आप अपने जिंदगी को जीने का जो यूजुअल तरीका बनाते हैं उसको हम कहते हैं core values. और each one of us follow our core value unless until there are life threatening situation. Say for example, किसी रिक्शे वाले का बच्चे को कैंसर हो गया है, काफी पैसे की जरूरत है, Till that point in time, he was earning his livelihood by rickshaw pulling. But at this point in time, when he has to save his kid's life, he may resort to some theft or robbery. Maybe वो चोरी डकैती कर ले. Otherwise, वो ऐसा था नहीं. Life circumstance, extreme of life circumstance compelled him to change his value system. Otherwise, people follow their value system, their core values. Third values known as peripheral values, जहां पे हम जानते हैं कि ये वैल्यू है, ये गुण है, ये वर्च्यू है, हम उसको फॉलो नहीं करते हैं. सदा सच बोलो. All of you know, how many of you speak truth all the time, always, in all circumstances, in your personal life, professional life, or social life? So, values are of three types: absolute values, core values, and peripheral values. Absolute values you will never compromise. Even you can give your, you can even at the cost of your life, you will uphold your value. Core values are values which you adhere with, except in rare circumstances. कोई आपके गन पॉइंट पे कह रहा है कि आप यहाँ साइन करो, आपने गलत कागज पे साइन कर दिया. It's like that. Otherwise, you follow your value. And peripheral values are which you hardly live by. सिर्फ कहने को होते हैं. Now, when these three values are compressed together for an individual, it becomes morality. फिर इसको कहते हैं morality. That individual is living a moral life. Means he is living his life based on these three set of values. They are absolute values, core values, and peripheral values. That is morality. Now come to the word ethics. When people live in groups, or when there is an organization, say for example SIHFW, State Institute of Health and Family Welfare, or for that matter my institute, संजय गांधी पोस्ट ग्रेजुएट इंस्टीट्यूट ऑफ मेडिकल साइंसेज, और वहां हजारों लोग काम कर रहे हैं हमारे यहाँ. तो when an organization, layman's language, moral values when are being practiced at the level of community, it is known as ethics. Or ethical values when are practiced से इस पे निर्णय करने के लिए कोई लिखित कानून उपलब्ध नहीं हो, वैसी स्थिति में हम अपने बिलीफ सिस्टम का, अपने वैल्यू का, अपने मोरालिटी का, या अपने संस्थान के या ऑर्गेनाइजेशन या समाज के एथिकल वैल्यूज का, एथिकल कोड का सहारा लेते हैं. अब वो जो केस था, पहला केस, जहां पे एक पेशेंट की जिंदगी हम बचा नहीं सकते और एक बेड ऑक्यूपाई है, और दूसरा पेशेंट जिसकी जिंदगी हम बचा सकते हैं वो उसको हम ले नहीं पा रहे हैं, कोई कानून इसके देश में नहीं है, तो इंडिविजुअल डॉक्टर और उस अस्पताल का प्रशासक निर्णय लेगा बेस्ड ऑन द एथिकल गाइडलाइन ऑफ दैट हॉस्पिटल. जब तक सरकार कानून न बना दे तब तक हर ऑर्गेनाइजेशन के पास लाइफ सपोर्ट विड्रॉल का कोई ना कोई गाइडलाइन बना हुआ है, और उस गाइडलाइन पे वो काम कर रहे हैं. और दीज ऑल गाइडलाइंस हैव somehow or the other been drawn from the ethical guidelines, ethical practices, ethical code of conduct, Nuremberg code of conduct, or it may be as the medical ethics code. कहीं ना कहीं किसी न किसी एथिकल कोड या गाइडलाइन से ही अथॉरिटी ड्रॉ करके हर हेल्थ केयर ऑर्गेनाइजेशन के पास एक रिटन या कन्वेंशनल सिस्टम है कि व्हाट टू डू इन सच केसेस व्हेन देयर इज नो पॉसिबिलिटी ऑफ प्रिजर्विंग लाइफ and the body is only being maintained by way of life support device, when we have a young patient who can definitely be saved by medical intervention. तो ऐसी स्थिति में ही हमें ज़रूरत पड़ती है अपने वैल्यू सिस्टम, बिलीफ सिस्टम, मोरालिटी और एथिकल गाइडलाइंस और कोड ऑफ कंडक्ट्स के अनुसार, या अपने एथिक्स कमेटी की मीटिंग करके भी लोगों ने ऐसा किया है. Higher organizations like AIMS, PGI, CMC, Vellore, PGI Chandigarh, at all these places we have ethical committees wherein we recommend these such cases to the committee, and ethical committee gives a decision as to what should be done in that particular case. Or at times it comes to us as an administrator, and we also decide based on the ethical values or ethical guidelines as is in vogue in our institution, and we come to a decision. Because we don't have a law on this. So I thought that this much of understanding is required out of either a clinician or an administrator who is heading a healthcare organization or a clinician who is giving clinical care to a patient. उसको ये बात समझ में आनी चाहिए कि जहाँ पे कानून नहीं है वहाँ पे हम निर्णय कैसे लें और वो पेशेंट के हित में कैसे हो. इतना बताना हमारे लिए आवश्यक था before I can take you to journey of law in terms of medicine or the legal aspect of medical practice. I hope by now or till now I have been able to make you understand these concepts, and now we'll move to the journey of law. Law क्या है? What is law? Law is a written guideline for peaceful mutual coexistence. लॉ कानून शांतिपूर्ण एवं सौहार्दपूर्ण तरीके से साथ रहने के लिए निर्धारित की गई लिखित व्यवस्था है. ब्रीच ऑफ विच इज पनिशेबल इन द कोर्ट ऑफ लॉ. उस व्यवस्था को तोड़ने पे कोर्ट के द्वारा दंड दिए जाने का प्रावधान होता है. इसको ही हम लॉ कहते हैं. टू रिपीट, टू रिटरेट, लॉ इज रिटन गाइडलाइंस, रिटन कोड ऑफ कंडक्ट for peaceful mutual coexistence, breach of which is punishable in the court of law. जिसका breach कोर्ट में punishable है. बट लेकिन ये अधिकार किसने दिया, कैसे बनता है, कौन बना सकता है कानून, कानून कितने तरह का होता है, ये जानने की थोड़ी सी, और हमारे अपने देश में लीगल सिस्टम का स्ट्रक्चर क्या है, थोड़ी जानकारी मैं आपसे बांटना चाहूँगा इस बाबत, ताकि जब मैं मेडिकल नेग्लिजेंस की बात कहूँ या उन कानून की बात करूँ जिसका इम्पैक्ट हेल्थ केयर डिलीवरी पे, हॉस्पिटल एडमिनिस्ट्रेशन में या क्लिनिकल केयर क्लिनिशियन को जिसकी ज़रूरत पड़ती है, तो उसके पहले थोड़ा सा यू हैव टू अंडरस्टैंड अ बिट अबाउट द वे लॉ ऑपरेट्स इन आवर कंट्री. In that context, we have to understand three things. First thing is, law बनता कैसे है, किसको law कहते हैं actually, in true sense. हर देश का एक संविधान होता है, एक constitution होता है. For every sovereign state, there is a constitution, and every constitution of that sovereign state defines the methodology of promulgating a law. हर देश जिसमें संप्रभुता अंतर्निहित है, हर वैसे देश के पास एक अपना संविधान होता है, और संविधान में विधायन यानी कानून बनाने की प्रक्रिया का निर्धारण होता है, लिखा हुआ होता है. हमारे देश के संविधान में भी आर्टिकल 368 में यह क्लैरिफाई किया हुआ है कि हमारे देश में कानून कैसे बनेगा. उसके लिए द प्रोविजन विच हैज बीन गिवन इन आवर कंट्री, इन आवर कॉन्स्टिट्यूशन इज अंडर आर्टिकल 368 दैट they have given this responsibility to either at the level of union center, to either the parliament, or at the level it has been given or devolved to the assemblies. So हमारे देश में जो कानून बनाने की जिम्मेदारी हमारे संविधान के द्वारा दी गई है, वो या तो संसद को दी गई है संघीय स्तर पे, या राज्य को दी गई है उनके राज्य स्तर पे, जो कि स्टेट असेंबलीज करती हैं. और जो हमारे पार्लियामेंट और असेंबलीज को जो ये अधिकृत किया गया है कानून बनाने के लिए, जब भी कोई ऐसा विषय जिस पे जनहित में या सरकार गवर्नेंस के लिए और फॉर पब्लिक वेलफेयर और फॉर एनी अदर रीजन गवर्नमेंट डीम्स इट अप्रोप्रिएट, द मिनिस्ट्री ऑफ लॉ थ्रू ड्यू प्रोसेस takes appropriate steps. Eventually a bill is drafted, and then bill is tabled into the parliament, and it goes to many standing committees and for public comment. Likewise अभी withdrawal of life support पे चल रहा है. और eventually either depending upon who is doing it, central government or state government, that bill is if after discussion deliberations approved by the either the parliament or the state assembly, it goes to president or governor for accent, उनके सहमति के लिए जाता है, then it becomes law. What I mean to say, हमारे देश में कानून बनाने का अधिकार सिर्फ और सिर्फ पार्लियामेंट या असेंबली के पास है, except in certain circumstances when president or governor they can issue ordinance, which eventually after 6 months or at the earliest possible time has to be placed before the parliament or the assembly for ratification. तभी वो कानून कायम रह सकता है. अब पार्लियामेंट और स्टेट असेंबलीज जो कानून बनाती हैं वो 3 तरह का होता है. सबसे स्ट्रॉन्गेस्ट जो टाइप है वो एक्ट है, और एक्ट जैसे एनवायरमेंट प्रोटेक्शन एक्ट, एक्ट में दिए गए प्रावधानों को लागू करने के लिए या उसको विस्तारित करने के लिए जो कानून बनाया जाता है उसको रूल कहते हैं. एक्ट गिव्स बर्थ टू रूल अगेन टू द सेम लेजिस्लेटिव प्रोसेस, and rule gives birth to regulation in order to give way to provisions contained therein in the rule, any specific rule like biomedical waste management rule, SGPGIMS rule. तो किसी सेक्शन के रूल को अगर हमें एक्सपैंड करना है, कुछ और डेलिबरेट करना है और क्लैरिटी लानी है, तो लेजिस्लेटिव बॉडीज बनाती हैं रेगुलेशन. तो लॉ का जो सबसे बड़ा दायरा है, डोमेन है, ग्रुप है, वो है स्टैट्यूटरी लॉ का, उसको स्टैट्यूट कहते हैं. वो लॉ जो पार्लियामेंट या असेंबली बनाती है उसको स्टैट्यूट कहते हैं, और ये 3 तरह का होता है, एक्ट, रूल एंड रेगुलेशन. तो दैट इज वन पार्ट. कभी कभी ऐसा होता है कि सरकार या कोर्ट के सामने ऐसा बिंदु आ जाता है जिस पर कोई कानून, कोई लॉ, कोई स्टैट्यूट, कोई रूल, कोई रेगुलेशन अवेलेबल नहीं है. फिर भी उस इशू पे निर्णय लेना है. व्हाट विल वी डू? कैन वी कीप सिटिंग? कैन वी क्लोज आवर आईज? वी कैन डू दैट. Jury can't do that. In that case, whenever an issue is brought before the judiciary to adjudicate upon, and at that point in time there is no written law or statute or act or rule or regulation on that particular point under consideration by the jury, in that case court adjudicates, jury adjudicates upon the issue keeping in mind the collateral dimensions of it and collective public sentiment, and whatever court adjudicates upon, that becomes case law or judge made law. There is second type of law. तो आप इस तरीके से 2 तरह के लॉ के बारे में जान गए. स्टैट्यूटरी लॉ जो पार्लियामेंट या असेंबली बनाती है, और दूसरा आ गया कोर्ट मेड लॉ और जज मेड लॉ और केस लॉज जो ज्यूरी बनाती है तब जब ज्यूरी के पास कोई ऐसा बिंदु लाया जाता है जिस बिंदु पे उस वक्त तक कोई भी लिखित कानून उपलब्ध न हो. वैसी स्थिति में कोर्ट ने जो निर्णय लिया होता है वो उसको कानून का दर्जा अपने आप मिल जाता है. ऐसा प्रोविजन, ऐसी व्यवस्था हमारे संविधान में है. अब डिपेंड करता है कि वो कोर्ट किस लेवल की है, डिस्ट्रिक्ट कोर्ट है, हाई कोर्ट है या सुप्रीम कोर्ट है. अगर डिस्ट्रिक्ट कोर्ट है तो उस डिस्ट्रिक्ट के सारे सबऑर्डिनेट कोर्ट्स के लिए वो कंप्लीटली लॉ है. बाकी डिस्ट्रिक्ट कोर्ट के लिए एक गाइड, एक रेफरेंस है. अगर ये निर्णय हाई कोर्ट ने लिया है तो उस राज्य के सारे डिस्ट्रिक्ट कोर्ट्स के लिए वो एब्सोल्यूट लॉ है. बाकी राज्य के लिए वो एक रेफरेंस पॉइंट है. बाकी राज्य के हाई कोर्ट अगर चाहें तो उसको माने, नहीं चाहें तो ये उनके विवेक पे छोड़ दिया जाता है. लेकिन अगर सुप्रीम कोर्ट ने किसी बिंदु पर डिसीजन दे दिया, अगर सुप्रीम कोर्ट ने एक जज मेड लॉ या केस मेड लॉ बना दिया, देन वैसी स्थिति में वो पूरे देश के लिए कंप्लीटली कानून बन जाता है. उस पर कोई भी सेकंड थॉट नहीं है. नो वन कैन चैलेंज दैट अनलेस पार्लियामेंट एक्चुअली मेक्स अ लॉ अपॉन इट थ्रू द ड्यू प्रोसेस ऑफ लेजिस्लेशन. तो अब तक मैंने कोशिश की आपको बताने की कि एथिक्स क्या है और लॉ क्या है. पहले मैंने बताया हॉस्पिटल एडमिनिस्ट्रेशन क्या है, फिर मैंने बताया हेल्थ केयर क्या है, मेडिकल केयर क्या है, क्लिनिकल केयर क्या है, फिर मैं आया वापस कोर टॉपिक पे, एक कोर टॉपिक पे जिसकी ज़रूरत क्लिनिशियंस को भी है, प्रशासक को भी है, और वो टॉपिक है लीगल एस्पेक्ट ऑफ मेडिकल प्रैक्टिस। लीगल एस्पेक्ट ऑफ मेडिकल प्रैक्टिस में मैंने आपको ये बताने की कोशिश की कि इसके दो दायरे हैं, दो परिक्षेत्र हैं, एक है एथिक्स का, दूसरा है लॉ का। जिस किसी भी बिंदु पे लिखित कानून अवेलेबल है वो लॉ के दायरे में आता है। जहाँ भी किसी भी बिंदु पे कोई भी लिखित कानून नहीं है उसको एथिकल कोड से, एथिकल गाइडलाइन से, एथिकल प्रिंसिपल से, एथिकल कमिटी से हम डील करते हैं। एथिक्स क्या है, मोरालिटी क्या है, वैल्यू क्या है, बिलीफ सिस्टम क्या है, मैंने आपसे इसकी बात भी करी। फिर मैं आया लॉ के साइड में। लॉ में आपको मैंने बताया लॉ क्या है, लॉ को डिफाइन किया, और मैंने बताया लॉ कैसे बनाया जाता है, हमारे देश में कानून कैसे बनता है, इसके बनाने की प्रक्रिया क्या है, कौन कौन कानून बना सकता है, और कानून के दो प्रकार का मैंने आपसे जिक्र किया, स्टैट्यूट्स एंड जज मेड लॉ। स्टैट्यूट पार्लियामेंट और असेंबली बनाती है, जज मेड लॉ कोर्ट बनाता है। यहाँ तक तो बात क्लैरिटी हो गई। अब मैं आता हूँ लीगल एस्पेक्ट ऑफ मेडिकल प्रैक्टिस के थर्ड पार्ट पे, जहाँ पे है मेडिकल नेग्लिजेंस, जो आपके लिए बहुत महत्वपूर्ण है, दोनों के लिए, जो क्लिनिशियंस हैं उनके लिए महत्वपूर्ण है, और प्रशासक जो अस्पताल चला रहे हैं उनके लिए महत्वपूर्ण है। क्योंकि अगर नेग्लिजेंस का कोई केस होगा तो उसको डील प्रशासन नहीं करना है, भले ही वो केस पैदा हुआ हो क्लिनिकल केयर देने के वक्त। हमारे देश में मेडिकल नेग्लिजेंस के संबंध में कोई प्रिसाइज लॉ एज सच नहीं है। आप लॉ का समझ रहे हैं, यानी कोई लिखित कानून नहीं है। तो कोर्ट कैसे एडजुडिकेट करती है, अब इसको देखने का दो नजरिया है, और उसके लिए आपको दो बातें समझनी होंगी। पहला कि मेडिकल नेग्लिजेंस है क्या, दूसरा अगर मेडिकल नेग्लिजेंस कहीं होता है और वो मैटर किसी कोर्ट में आता है तो कोर्ट उसको कैसे देखेगी, हाउ कोर्ट विल लुक अपॉन इट, हाउ कोर्ट विल प्रोसेस इट, एंड हाउ कोर्ट विल टेक ए डिसीजन ऑन इट। ये भी आपको समझने की आवश्यकता है। भाई पहले आप समझते हैं कि व्हाट इज मेडिकल नेग्लिजेंस। लॉ की भाषा में, कानून की भाषा में मेडिकल नेग्लिजेंस क्या है। कानून की भाषा में इज वेरी सिंपल, ये कहता है मेडिकल negligence is defined in the legal parlance as any act of omission or commission. To be very simple, very clear, ये कहता है किसी डॉक्टर को जो नहीं करना चाहिए था वो उसने कर दिया। जैसे ऑपरेशन करते वक्त पेट में कैंची नहीं छूटनी चाहिए थी, छूट गया, तो ये नहीं करना चाहिए था, कर दिया गया। या जो करना चाहिए था वो नहीं किया। से फॉर एग्जाम्पल पेनिसिलिन के इंजेक्शन देने के पहले स्किन में सेंसिटिव टेस्ट करने का होता, वो नहीं किया, तो एक्ट ऑफ ओमिशन हो गया। जो करना चाहिए था वो नहीं किया गया। वी आर सपोज टू डू अ सेंसिटिविटी टेस्ट बिफोर इंजेक्शन ऑफ द बेंजाथिल पेनिसिलिन और अदर पेनिसिलिन्स because they are very sensitive and there are very high chance of anaphylaxis. Whereas as a surgeon, when he or she is operating upon, he is not supposed to leave any operating instrument inside the visceral cavity. तो लॉ कहता है any act of omission or commission, मतलब omission means जो आपने करना था आपने omit कर दिया, नहीं वो नहीं किया, और commission है जो आपने नहीं करना था वो आपने कर दिया। If either of these two happens, it comes under the definition of medical negligence. That is the way law looks at it. अब सवाल पैदा होता है कि कब कहेंगे हम कि क्या करना था और क्या नहीं करना था एक डॉक्टर को इलाज देने की प्रक्रिया में। इसके लिए एक तीसरा पहलू है इसको देखने का, और वो है इंडियन कॉन्ट्रैक्ट एक्ट। इंडियन कॉन्ट्रैक्ट एक्ट कहता है कि जब एक पेशेंट और डॉक्टर के बीच में डायरेक्ट और इनडायरेक्ट, एक्सप्लिसिट या इम्प्लाइड, रिटन या वर्बल कॉन्ट्रैक्ट हो जाता है, तो उस इमीडिएटली इट गिव्स राइज टू सम ड्यूटीज फॉर डॉक्टर एंड सम राइट टू पेशेंट। आइए इसका एग्जाम्पल लेते हैं, एक उदाहरण लेकर समझते हैं इसको। यू आर सिटिंग इन अ बिजी ओपीडी एग्जामिनिंग अ पेशेंट and you are completely lost in your work. You are dealing with that patient. Meanwhile, आपके कमरे में कोई एक और पेशेंट आता है, वो आपको ग्रीट करता है, आपने उसको देखा तक नहीं, you are still examining your previous patient, और आपने उसको जवाब दे दिया yes or no में, or you replied just by nodding your head yes. He told you good morning doctor, you nodded just in affirmation, as if कि आपने उसके अभिवादन का जवाब दिया. अब लॉ कहता है कि the moment you responded to that patient's greetings, there was an implied contract between doctor and patient. क्यों? जो इंडियन कॉन्ट्रैक्ट एक्ट कहता है कि अगर कोई ऑफरर कुछ ऑफर करता है किसी ऑफरी को, और ऑफरी ने वो ऑफर एक्सेप्ट कर लिया और उसका एक्सेप्टेंस ऑफरर को कन्वे हो गया, तो कॉन्ट्रैक्ट स्टैब्लिश हो गया. मतलब अगर मैं कहूं कि अगर एक डॉक्टर ने एक क्लिनिक में या हॉस्पिटल में ओपीडी में बैठा हुआ है, इसका मतलब वो अपनी क्लिनिकल सर्विस या मेडिकल सर्विस को ऑफर कर रहा है, और एक पेशेंट जब उसके चैम्बर में आता है और उसको ग्रीट करता है और उस ग्रीटिंग का डॉक्टर रिस्पॉन्ड कर रहा है, मतलब पेशेंट आया है तो वो ऑफर ही हो गया, यानी उसको कोई मेडिकल केयर चाहिए. डॉक्टर को ग्रीट किया, डॉक्टर ने ग्रीटिंग को एक्नॉलेज करके सर नॉट करके रिस्पॉन्ड किया, मतलब वो पेशेंट से उसका कम्युनिकेशन हो गया. द मोमेंट इट हैपेंस, इट इज सेड इन द eyes of law or in the words of law, from the perspective of law, कि डॉक्टर पेशेंट इम्प्लाइड कॉन्ट्रैक्ट स्टैब्लिश हो गया. The very moment there is a doctor patient implied contract established, ये implied है. कई बार हम लिख देते हैं ऑपरेशन करना होता है, we take consent from the patient, वो तो बिल्कुल और भी स्ट्रांग होता है, because there you are taking written consent from the patient. अगर पेशेंट आपके अस्पताल में आया, उसने 2 रुपए की पर्ची बनवाई, तो कॉन्ट्रैक्ट स्टैब्लिश हो गया. बिकॉज अगर आपने 2 रुपए लिए और पर्ची दे दी तो कॉन्ट्रैक्ट बन गया. एज पर इंडियन कॉन्ट्रैक्ट एक्ट इज वेरी स्ट्रांग. हमारा इंडियन कॉन्ट्रैक्ट एक्ट काफी स्ट्रांग एक्ट है. और द मोमेंट देयर इज अ डॉक्टर पेशेंट कॉन्ट्रैक्ट, it immediately gives rise to 2 duties for the doctor, and these 2 duties are duty to render due care and duty to exercise due diligence. आप ध्यान सुनिएगा मेरी बात को, 2 स्पेसिफिक वर्ड हैं और ये वर्ल्ड ओवर फेमस है. The moment there is a implied contract between a doctor and patient, if it has been established, that very moment that implied contract gives rise to or devolves 2 duties upon the doctor, attending doctor, treating doctor, and they are duty to render due care and duty to exercise due diligence. बस 2 ही वर्ड में सारा डिलीजेंस है. render due care and exercise due diligence, मतलब आप इसका भी एग्जाम्पल लेते हैं. ड्यू केयर क्या है, ड्यू डिलीजेंस क्या है. ये प्रोग्राम जो है डिपार्टमेंट ऑफ हेल्थ एंड फैमिली वेलफेयर करवा रहा है, जिसका एक केडर है प्रोविंशियल मेडिकल हेल्थ सर्विसेज, PMHS केडर, जिसमें हजारों डॉक्टर काम कर रहे हैं एक 3-tier स्ट्रक्चर में. PSC, CSC एंड डिस्ट्रिक्ट हॉस्पिटल्स हैं. अब आप मान लीजिए एक छोटा बच्चा, 6 महीने का बच्चा, वो पहुंचता है PSC पर, सिम्टम है डायरिया, वॉमिटिंग, डिसेंट्री. वही बच्चा पहुंचता है CSC पर, डायरिया, वॉमिटिंग, डिसेंट्री. और वही बच्चा पहुंचता है मेडिकल आपके डिस्ट्रिक्ट हॉस्पिटल में, डायरिया, वॉमिटिंग, डिसेंट्री. अब आप सबको ये पता है कि PSC के सेटिंग पे पीडियाट्रिशियन नहीं होते, CSC पे हमारी समझ से पीडियाट्रिशियन मौजूद होता है, और डिस्ट्रिक्ट हॉस्पिटल में काफ़ी बड़ा सेटअप होता है और पीडियाट्रिशियन एक्सपीरियंस पीडियाट्रिशियन होता है. तो ये कानून आज के हमारे देश में जो मेडिकल नेग्लिजेंस को डील करने का कानून है, उसका नाम है बोलम्स टेस्ट. मैंने पहले कह दिया था आपको कि कोई लिखित कानून नहीं है, लेकिन एक जज मेड लॉ है. और ये जज मेड लॉ बनाया गया था ब्रिटेन में. ब्रिटेन में एक केस में आज से 100-150 साल पहले एक जूरी ने एक डिसीजन दिया था, और वो डिसीजन बोलम्स टेस्ट के नाम से पूरे वर्ल्ड में फेमस है. BOLAMS, बोलम्स टेस्ट. क्योंकि उस वक्त ब्रिटेन में भी, और हम लोग तब ब्रिटेन के उपनिवेश में थे, वी वर अंडर देम, हम लोग गुलाम थे उस वक्त। बोलम टेस्ट चूंकि ब्रिटेन में ये फॉलो हो रहा था, बाय डिफॉल्ट ये इंडियन जुडिशरी में आ गया, बिकॉज हमारा पूरा जुडिशरी इज बेस्ड ऑन द ब्रिटिश जुडिशरी पैटर्न। तो टुडे इन टुडेज कंट्री एट आवर प्लेस our courts, be it consumer court, be it district court, be it criminal court, be it civil court, be it high court, be it supreme court, anywhere, at all levels, the analyzed act of medical negligence is being dealt with under the provisions of the Bolam test. Bolam's test. Bolam test का मतलब क्या है? Bolam test कहता है, whenever an alleged act of medical negligence will be brought before the jury to adjudicate upon it, jury will recreate the scene and will try to examine an apple with an apple, an orange with an apple, an orange with an orange. इसका क्या मतलब हुआ? What does it mean? Let me give an example. मान लीजिए जो मैंने आपको केस एग्जाम्पल दिया था थोड़ी देर पहले, पीएससी पे, सीएससी पे और डिस्ट्रिक्ट हॉस्पिटल पे 6 महीने का बच्चा तीनों जगह पहुंचा, सेम डे पहुंचा, सेम सिम्टम है और तीनों जगह उसकी डेथ हो गई। तीनों के पेरेंट ने कोर्ट में मेडिकल नेग्लिजेंस का डॉक्टर के अगेंस्ट सिविल सूट फाइल कर दिया, क्रिमिनल ट्रायल शुरू हो गया फॉर एग्जाम्पल। तो कोर्ट इसको कैसे एग्जामिन करेगी? कोर्ट विल ट्राई टू रिक्रिएट दिस सीन at the level of PSC, at the level of CSC, at the level of district hospital. वो देखेंगे कि CSC पे PSC पे जिस डॉक्टर ने ट्रीट किया था उसकी एजुकेशनल क्वालिफिकेशन क्या थी, उसका लेंथ ऑफ एक्सपीरियंस क्या था, वहाँ पे इंफ्रास्ट्रक्चर क्या था, और तब कोर्ट देखेगी सेम सेट ऑफ सर्कमस्टांस में, सेम सेट ऑफ रिसोर्स में, सेम सेट ऑफ कंस्ट्रेंट्स में, विथ सेम डिग्री and same length of experience after obtaining degree, कोई भी दूसरा और डॉक्टर होता और जो उसे करना चाहिए था वो सब कुछ उसने किया है, then there is no negligence. What I mean.
For now, we are stopping the video because the next lecturer is waiting for a lecture. We'll continue it later on.
Moving ahead, patient-reported outcome measures and patient-reported experience measures are tools that provide a patient perspective on their health and healthcare experience. These tools improve healthcare by providing a fuller picture of health. This topic, I would like to invite our next speaker, Professor Dr. Pereira Pratibha ma'am.
Ma'am, are you there?
Hello, can you hear me?
Yes, ma'am.
Can you hear me?
Yes, ma'am.
Okay, so I'm going to start. I will be speaking in English and Hindi for the benefit of the students. So I was listening to a very interesting lecture जो law और regulations के बारे में जो है वो मैं सुन रही थी. Nowadays, it's very, very important that it's all intertwined. Whatever we do service to wherever, it is intertwined legally. And the main issue why this has become legally is, I guess, because somewhere जो बातचीत होती है एक दूसरे में, जो communication है, that communication breakdown हो रहा है. हम सुनने में थोड़ा प्रॉब्लम होती है, तो एंड जो हम महसूस करते हैं दूसरे के प्रॉब्लम, वी डोंट अंडरस्टैंड. सो दैट्स द रीजन व्हाई देयर इज सो मच ऑफ legal issues and legal issues that we are facing. So I always tell that when you're dealing with the patient, we have to remember 3 things which are very, very important. One, with the eyes, I look, but I must not look at things. I should see things. जो नहीं दिख रहा है, that is what I should look deep into it. That is what I see. when I'm speaking to my patient, I should not talk to them, but I should speak to them. So when I mean I should speak to them, that means I am giving a patient listening, understanding what they're telling me, and then I am answering back. So I should speak. So I should see, I should speak, and the most important part is I should not hear, but I should listen. So at these three levels, the communication should improve on the medical fraternity side, which is very important. So I should see things, I should speak, and I should listen. And that solves a lot of problem when we are dealing with patient. So this what I'm looking at PROM and PRAIN. It's a very nice, kind of abbreviation, but it's something very, very interesting where we look forward. So taking from the legal aspect, which was very important, what does it matter to patients? जब हम पेशेंट्स को देखते हैं उनको क्या महसूस होती है? हम लोग एक बड़ा डायग्नोसिस करते हैं और उसके ऊपर एक बड़ी ट्रीटमेंट डालते हैं और एक ऑपरेशन करते हैं. हम बोलते हैं ऑपरेशन सक्सेसफुल. पेशेंट घर जाता है लेकिन पेशेंट खुशी नहीं है क्योंकि वो जो सोचा था that what I'm going to do before the operation, I'm going to get up, I'm going to walk, I'm going to be very free, वो नहीं होता है. तो हम जो करते हैं ट्रीटमेंट और पेशेंट जो एक्सपेक्ट करता है, there is a gap and we don't understand that gap because we are so much guided by the standard of care protocols जो टेक्स्ट बुक में है, जो गाइडलाइंस में है, जो PubMed large meta analysis में है. So we are so stuck to a structured protocol जो हम black and white में देखते हैं, but we don't see the gray area जो patient को महसूस होती है. So उनके हिसाब से health domain है दर्द, pain, mobility, I have to walk, सुस्त, I'm fatigued, I'm anxious, मुझे I'm feeling low, वो वगैरह सारा उनकी quality of life है. Just the other day I saw a patient after hernia operation. She could not, she was weak, then she had an MI, and then they put a stent. Now she is completely weak. She isn't able to get up, move from one place to another place, completely withdrawn, and so much so into depression. She cannot understand why she cannot walk. But apparently the surgery is successful. The surgery has gone on well. हम लोगों ने एक stent डाला है. So patient जो value करते हैं वो उनके लिए मायने रखती है. And that is the gap that what sir was talking about legal, and what I'm going to tell you is how do you catch this gap and communicate with your patients better and therefore decrease the legal hassles that come up with care. So patient के अंदर में जो बातें हैं वो सोचता है बॉस मैं autonomy respected. Many times we give this consent forms and say इसमें साइन करो. Patient को टाइम ही नहीं है to read what is there in the consent form. Many times when we go for NABH assessment हम देखते हैं कि consent form में risk benefit of the procedure तो है ही नहीं. Patient won't even write the procedure name, तो उनको पता भी नहीं है ये क्या होता है. So और उनके वो बोलेगा कि मैं I did not participate at all in my decision. मैंने तो कोई पूछा ही नहीं. And जो है उसका cost और burden हमें care pathway लगा. So these are what patients value in their care, and what matters to them is all these things. Okay. So what patient want is, he wants to know how you're going to make my life easier. Can I take my care of my own self? You empower me. Though that patient which I saw, stent ho gaya, hernia ho gaya, double surgery. Some patients, surgeons are very happy. But then that patient is sad. I asked him, why are you sad? He said, no, I can't get up on my own. I cannot do things of my own. I need support. I am not empowered. I don't have ownership of my life. So that becomes an issue. And once the patient gets into depression, care or whoever looks after the patient, also it starts affecting me. So are we transparent? आप कौन सा cure care? So he will not bother about cure. या cure is a perspective, but वो पूछेगा care. आपने मेरा care कैसे कितना दिया? What is the reduce of cost? So यहाँ जो है अभी डिजिटल वर्ल्ड है, तो आप उनको देखना पड़ेगा डिजिटल में कितना है, आप कैसे कोलैबोरेट करते हो, आप पेशेंट कंट्रोल में कितने हो. So there has to be something which joins the two of them. That is what the patient wants. And therefore, this concept, patient reported outcome measure, उसको प्रॉम बोलते हैं, जो पेशेंट रिपोर्ट करता है आपको, एंड प्रेम बोलते हैं, जो लविंगली आप कर सकते हैं, पेशेंट रिपोर्टेड एक्सपीरियंस मेजर. सो वन पेशेंट रिपोर्टेड आउटकम. सो आप एक करते हैं, उसका आउटकम पेशेंट को क्या मायने रखती है. नेक्स्ट पेशेंट रिपोर्टेड एक्सपीरियंस, उनकी एक्सपीरियंस क्या है, आप उसके कितने मायने रखते हैं. So that is what we need to understand today, which is very, very important, that हम treat करते हैं, सब कुछ करते हैं, but how is it affecting the life of the person that you are treating? So it should become not guideline centered. It should not become standard of care centered. It should not become evidence-based care centered, but our care should become people centered. And you should do what matters to people most. So that teaches you here, you have to map out patient's health issue. That means आपको एक patient को उस आदमी holistically देखना पड़ेगा. Don't apply guidelines to the patient, but look at the patient overall, holistic, and see how you can treat this patient individually. So आपको map out करना पड़ेगा throughout their hospital stay. When they come, not only when they go and then you forget about him, but before you start anything, during what you're doing, and after your treatment also, and also a specific care path. So before prom and prem, you should understand what is patient reported outcome at all. वो क्या होती है चीज जो पेशेंट रिपोर्टेड आउटकम बोलते हैं. जो हॉस्पिटल से एनएबीएच जाते हैं उनको मालूम है कि हम फीडबैक लेते हैं. Those feedbacks are very different. Those are implied some feedbacks which general हम पूछते हैं, but उस feedback में hidden will be patient reported outcomes. वो बोलेंगे आपको, तो उसको आप analyze करना पड़ेगा. So patient reported outcome is where a patient अपने language अपने आप बोलता है, कोई उसको interpret नहीं करेगा. Now हम लोग जब feedback देते हैं, feedback में हम लोग yes no yes no yes no देते हैं. We are feeding it into their head. Did the nurse smile at you? Yes, no. Did the doctor shake hands with you? Yes, no. Did you get this on time? Yes, no. So we are feeding them. That is not patient-reported outcome. You have to leave them free to give them their, what did they expect before they came to the surgery? What is the knowledge they had, how they will improve, or a medical treatment, whatever be it. Now, after that, you give your outcome. That is PRO, patient reported outcome, no interpretation of patient's response, no clinician or anyone else. So, हम PRO का definition आपने सुन लिया कि वो patient बोलते हैं अपने आप से, कोई उनको interpret नहीं करता है, लेकिन हम उनको एक measurement करनी है. Whenever we see something, we have to measure it. अगर हम measure नहीं करेंगे, तो हमें we will not understand हमें कहाँ जाना है. So when we talk of PROM, it's a measure. Understand that. So PRO is what the patient tells you about the outcome. Now PROM, it's a measure. It can be either generic or which is developed in a general way, or you can do it in a specific health problem or population. दो नमूने के होते हैं. एक generic होती है, लेकिन एक disease specific भी होती है. So you can develop in two ways. So to measure the outcome, the PRO, you have PROM. M is a measure. What is PREM then? It is a measure which you collect patients directly about their experience with the healthcare. So, आपको overall satisfaction कैसी है, communication कैसा है, responsive कैसा है. Now, I will tell you one thing. Now, let us take a gastroenterology patient case. वो आते हैं, endoscopy procedure कराते हैं, तो एंडोस्कोपी प्रोसीजर के बाद you ask them, did your bleeding stop? He'll expect the pain to go. If it is an upper GI bleed, ligation, he will expect the bleeding to stop, the pain to subside, his nausea to improve. तो एक symptoms होती है. So whether all that what he faced, for what he came to hospital, he would have come with some symptoms. I would have bleeding per hematemesis, pain, उसमें आएंगे तो ये आपने प्रोसीजर किया तो प्रोसीजर के बाद वो इंप्रूव हुआ या नहीं, वो प्रॉम है ना. इसमें प्रेम कैसे निकालेंगे? जब एंडोस्कोपी के लिए पेशेंट आती है तो आते हैं पेशेंट, आप उसको घर भेज देते हैं. क्यों भेजते हैं? बिकॉज ही हैज ईटन ब्रेकफास्ट एंड कम. He was not told how he has to prepare for the endoscopy. And did they tell him that we are going to put a tube into your stomach and it is a big tube that you have to swallow the tube? Was the patient talking to him? Was the patient kind? So वो प्रेम हो जाती है. So endoscopy procedure में now you understand, एक ही procedure में एक ही whatever you do, प्रॉम भी होती है, प्रेम भी होती है. ओवरऑल होता है पेशेंट की सेटिस्फैक्शन. सो वो पोटेंशियल क्या है? वो दो करने से आपको एक ट्रैकिंग, यू विल ट्रैक द आउटकम. तो आप यू शुड बी वेरी नॉलेजेबल व्हेन दे कम, टेकिंग हिस्ट्री की आपको क्या महसूस होती है, आपकी तकलीफ क्या है. सो यू ट्रैक द आउटकम बेस्ड ऑन व्हाट हिस्ट्री यू आर टेकिंग. आजकल तो हम पेशेंट से बात ही नहीं करते हैं, वी सी सम इन्वेस्टिगेशन और उसको करा देते हैं. Also we can assess the severity of symptoms. कितने सीवियर से आए हैं, कहां तक हमने उनको हेल्प किया. फिर also we will assist in treatment, decision and intervention, और हम उन जनरल हेल्थ को मॉनिटर करेंगे. तो वो है पोटेंशियल प्रॉम ऑफ प्रेम का. सो जब हम गोल और ऑब्जेक्टिव्स देखते हैं तो वी डेवलप ए कल्चर ऑफ सेफ्टी. Whenever we do प्रॉम ऑफ प्रेम, अभी सेफ्टी कैसी होती है एंडोस्कोपी में? तो आप सेफ्टी बोलेंगे, अच्छा आप एम्प्टी स्टमक पे आओ, आप यू हैव टू swallow and you mentally you prepare, so anxiousness of the patient is reduced. You prepare him well, you save his time, money, going back and coming back, all of that. Now आपको पेन और वगैरह असेसमेंट होगा तो एंडोस्कोपी में आप क्या क्या डिसीजन लेंगे, everything you will be well prepared. Here also it comes कि आप HIC practices में how you will effectively see that you don't add any extra problem because of your HIC practices. So you look at the instrument, how it is sterilized. So culture of safety आ जाती है. प्रॉम और प्रेम इफेक्टिवली करेंगे तो इनअप्रोप्रिएट और अननेसेसरी के, अभी देखो आप यू डोंट टेल देम टू एम्प्टी स्टमक एंड कम, सो अननेसेसरी हो जाता है. यू विल सेंड देम बैक अगेन, दे विल कम बैक अगेन, दैट इज अननेसेसरी. Then you will judge how to minimize harm in all settings. So that is very, very important. So going further, so prevention और treatment में कैसी effective होती है? So you will use appropriate. अगर आप प्रॉम के बेस में आउटकम वो जाते हैं, you will use appropriate screening and prevention. आपको पता पड़ेगा कि कैसे prevention हमें लेनी है. Then based on that, you will strengthen intervention. For example, I've given here to prevent heart attack and stroke. So you will see how intervention आप करेंगे to prevent it. Then उनकी quality of life में आप क्या बदलाव लाएंगे, that is important. Then you will look at PRAME, how you will improve their behavioral health and access to quality. Overall, एक जो है गायनेक लेंगे तो पेरीनेटल आउटकम क्या है. So objective, I've looked at many areas. For example, prevention of cancer हमने एक लिया है, हार्ट अटैक का लिया है हमने, क्रॉनिक कंडीशन में कैसे करना लिया है, आपका बिहेवियरल हेल्थ और पेरीनेटल आउटकम. सो ऑब्जेक्टिव्स अक्रॉस आप कर सकते हैं. इट इज नॉट इनटू वन थेरेप्यूटिक एरिया, दैट व्हेन यू डू प्रॉम एंड प्रेम इट इज नॉट वन और जनरल. आप ईच थेरेप्यूटिक एरिया में यू कैन डू योर बेस्ट for effective prevention and treatment. So when we look at PROM, they are very, very important tool. So first, for patient's health, I'm going back. आप changes क्या होती है उसकी tracking और आपको evaluation of treatment outcome भी आप करेंगे. So through and through you will take the patient, because at the end of the day आपको है उनकी quality of life में जो है उसमें आपको important होना है. So when you look at health related quality issue, आप लोगों को पेन असेसमेंट, फंक्शनल स्टेटस असेसमेंट उसको हम करते ही नहीं है. नन ऑफ द केस शीट आई सी पेन असेसमेंट. अगर आप आगे देखेंगे नी और हिप रिप्लेसमेंट सर्जरी, उधर 2 वेरी इंपॉर्टेंट पॉइंट्स होती है. वो आते हैं क्यों? मेरे को दर्द है, मैं चल नहीं सकती हूँ, आई कांट वॉक. सो हम क्या करते हैं, एक्सरे लेंगे, वेरी बैड नी बोलेंगे, इसको हम मेजर करेंगे कि ये इतनी डिफॉर्मिटी है, तो ओके नी रिप्लेसमेंट कर देंगे. बट आफ्टर दैट डू वी रियली फॉलो देम अप that whether you know what they expected, what you expected, whether it has happened at all. Pain assessment कौन करता है? कोई नहीं करता. They go back, they have the pain. 1 second. So pain they don't assess at all. Next होती है functional status assessment. We don't know. I told you, I had a cardiac patient. सब हो गया, वो बेटी एक घर, because she can't even get up. Because what did she expect? What did we want for her to get up and move? So इधर gap क्या है? उनकी क्वालिटी ऑफ लाइफ जो थी, फॉर एग्जाम्पल बेसिक एक्टिविटीज ऑफ डेली लिविंग और एक्सटेंडेड एक्टिविटीज ऑफ डेली लिविंग, उसको मेजर ही नहीं करते हैं हम, तो वो जो रहता है वो रही जाता है. सो यू डू सर्जरी, बट व्हाट यू वांट टू गेट टू दैट लेवल इज क्वाइट गुड रिहैबिलिटेशन. तो सिम्टम्स बर्डन भी आपको मेजर करना पड़ेगा क्वालिटी ऑफ लाइफ ऑफ पेशेंट्स के. सो जब हम देखते हैं, ये है फ्लो. फर्स्ट आप पीआरओ देखेंगे, या आउटकम क्या है, वो क्या एक्सपेक्ट, यू शुड हैव अ गुड डेटा. उसके ऊपर से आप मेजरमेंट का करो. सो हावेवर ये जो पीआरओएम मेजरमेंट है, इट इज वेरी डिफिकल्ट. आपका एक्सेप्टेड स्केल्स है. सो प्रॉमिस है, एचओएस है, फोटो, दीज आर ऑल अवेलेबल ऑन द नेट. यूज दीज स्केल्स. ओके, देन पेशेंट रिपोर्टेड आउटकम बेस्ड ऑन परफॉर्मेंस मेजर, वो एक दूसरा स्टेप है. इसको लेके आप एग्रीगेट करो कि आपका पीआरओ में पीआरओएम करके वेयर आर यू, हाउ बेस्ट यू कैन असेस. सो नेक्स्ट टाइम यू गो इनटू अ फेलियर मोड इफेक्ट एनालिसिस, that this set of hip and knee replacement, you yourself have an idea what is the outcome they expect. आपको जनरल एक डेटा आ जाएगा, so you're well prepared आप क्या measurement करेंगे. So when you look at patient reported outcome, you will identify issue and population of interest. इसको हम target बोलते हैं. You have to identify the domain of importance to the patient. So this is target. Next, for outcome measure, so इसको first PRO, what is your target, फिर उसको measurement डालेंगे आप. You identify है, कुछ है नेट में, कुछ है measurement का tool, you pick it up. All these Oxfords and all have developed fantastic tools. So look at it. आपको एक knee hip replacement आती है, go to Oxford and say whether they have a patient outcome measurement tool. उसको आप यूज कीजिए before, during and after में, सब आ जाएगा. Then you do a patient reported outcome performance measure. आप एग्रीगेट करो 50 नी हिप रिप्लेसमेंट में आपको क्या हो गया, डेटा कैसा आया, आपने मिसिंग डेटा किया था क्या, सब आपको आ जाएगा इसमें. ओके, सो यू कैन डू वेरियस थिंग्स. आप सेटिस्फैक्शन सर्वे कर सकते हैं फ्रॉम योर फीडबैक से लेके आप प्रेम यू कैन डेवलप. प्रेम इज एक्सपीरियंस ऑफ केयर. सो आप उनका एक्सपीरियंस कैसा था. PROM is symptoms, functional status. I'm revising again. You take satisfaction survey, उसमें आप प्रेम और PROM दोनों निकाल दो. प्रेम है जो experience of care है, PROM है symptom, functional status, health related quality of life and related outcome. So when we look at it, again going back, you look at multidimensional है, so it can be generic or condition. Functional status is important. Revising again, symptoms and signs, burden आपको निकालना पड़ेगा, और behavior. Just go through this, which is very important, not what actually you are telling earlier. So symptoms में important symptoms आप पूछेंगे, pain, fatigue, sleeping, anxiety, cognition, depression वगैरह. फंक्शनल स्टेटस में आप पूछेंगे आप डेली एक्टिविटी कैसे करते थे, अब आप क्या कर सकते हैं. Social activities you will see, and how do they perform social roles. Quality of life में उनकी क्या perception है. You may have a perception of quality of life, but patients will have their own perception. So you will have to understand what their perception is. So this is the level of brain. So when you look at, it's all intertwined. health related quality of life, एक दूसरे तालमेल है. So whenever you do patient centered, at every level आपको prom और prem करना पड़ेगा. It is not that only one way you do like earlier we used to do. So this I'm not, I already told you. So try and measure patient centered and outcome wherever possible. So you can go coordination, community, look at cost, safety पे जा सकते हैं, caregiver पे जा सकते हैं, और clinical quality of care. Anywhere along in a process, you can develop this prom. So what the patient is telling you is he's the expert. We think we are the expert, but we are not the expert. It is the patient who are the expert. उसकी steps होती है. Whenever you're developing PRAME, you step 1, आपको मालूम होना चाहिए कि आप मेजरमेंट क्या करते हैं. सो डिस्क्रिप्शन ऑफ प्रॉम एंड प्रेम करनी है. देन यू चूज द राइट इंस्ट्रूमेंट. गो ऑन टू द नेट. ऑक्सफोर्ड में वहां यहां मिल जाएगा आपको. आप उसको निकालो. वैलिडिटी है उसके, रिलायबिलिटी है, रेस्पॉन्स है, आप उसको यूज करो. थर्ड, you look at barriers and support. In Indian context, it is very, very difficult. आप उन घर जाएंगे, फोन करके उनको पूछो, इट विल बी सन्स फोन नंबर दे विल गिव. लेकिन आपको पेशेंट को पूछना है. सन बोलेगा मैं काम में हूं, मैं मेरे पिताजी माताजी विलेज में हैं, मैं उनसे बात करके मैं फिर आपको बोलूंगा. बट इट इज नॉट पेशेंट्स लैंग्वेज. सो आपका बैरियर आइडेंटिफाई करना पड़ेगा. एट सिस्टम लेवल बैरियर, service level barrier, individual barrier for putting these measures. So that is very, very important. So for Indian context, the barriers are very critical and important. So we have prom cycle बोलते हैं. तो prom cycle में first आप goal को identify करो. Okay? So when you identify goal should be individual patient care होनी है, quality improvement है, external transparency. क्या चाहिए आपको? उस गोल को आप आइडेंटिफाई करो. बाद में एंड नेक्स्ट यू फेसेस में आप गोल को आइडेंटिफाई करो. फर्स्ट गोल है, फिर सेकंड फेस है सिलेक्शन. इस सिलेक्शन में आप करेंगे कि ओके मेरा गोल है इंडिविजुअल पेशेंट केयर, मेरा गोल ये है नी रिप्लेसमेंट. सो इसमें मैं कौन सी प्रॉम और प्रो कौन सी सेलेक्ट करूंगी. अगर नी रिप्लेसमेंट है, पेन और मोबिलिटी मेरा पेशेंट रिपोर्टेड आउटकम होगा. सो देन यू से व्हाट मेजरमेंट आई विल यूज. ओके, सो ये स्टेप 2 जो है सिलेक्शन है, और स्टेप 3 जो है वो इंडिकेटर है. इंडिकेटर मींस आपको इंटरप्रिटेशन करना पड़ेगा. दैट इज मेरे को 10 पेशेंट आए हैं नी रिप्लेसमेंट, उसमें 8 लोगों का आउटकम ये है, 2 लोगों का नहीं है. तो मैंने कितने पेशेंट को उसमें रख के प्रॉम मेजरमेंट में आई हैव यूज्ड. सो यू हैव टू टेक द इंडिकेटर्स. सो आपको यूज ऑफ करके देन यू यूज द प्रॉम आफ्टर लुकिंग एट द इंडिकेटर कैप्चर. सो आपको गोल ए है, you have to understand the individual patient, then you have to understand external quality, which is very, very important. लेकिन एक पेशेंट में आपको मल्टीपल गोल्स हो सकती है. फॉर एग्जाम्पल इफ आई टेक नी रिप्लेसमेंट, इंडिविजुअल पेशेंट केयर भी हो सकती है और क्वालिटी भी हो सकती है, क्वालिटी ऑफ लाइफ. सो यू कैन हैव मोर देन 2 गोल्स. इट इज नॉट दैट यू नीड टू हैव ओनली 1 गोल. सो नाउ सिलेक्शन में आपको वेरी इंपॉर्टेंट होगा कि आप सिम्टम को सेलेक्ट करते हैं, या लाइक पेन, फैटिग विच आई टोल्ड यू, आप उसको सेलेक्ट करते हैं, या आपको फंक्शनल स्टेटस, परफॉर्मिंग डेली एक्टिविटीज उसको सेलेक्ट करते हैं, और क्वालिटी ऑफ लाइफ. और आप तीनों में एक एक प्रॉम सेलेक्ट करते हैं. सो एक पेशेंट में एक प्रॉम भी हो सकता है या 3 प्रॉम भी हो सकता है पॉसिबल. सो फिर आपको रेलेवेंट आउटकम को इफ यू डू देन यू गेट द रेलेवेंट मेजर. सो यू हैव टू सिट विद द डॉक्टर, talk to the patient, why they are coming with, what is the treatment he is offering, by his treatment what does he plan to improve the patient's perception of his health. That is important. So we are connecting patient to doctor to process to system. So that is what you take it, and then you take relevant tools. So anybody can do it, patients and clinicians, decision makers. So everybody can use PROM, research or policy makers. 3 लेवल पे प्रॉम करनी है, एनीबडी कैन यूज इट. सो कहाँ आप यूज करेंगे? डोंट यूज इट एट द एंड, इट्स ऑफ नो यूज. So beginning itself, you have to, how will you develop PROM? Look at the scope of services of a hospital. आपका मेन स्कोप है कार्डियक, तो कार्डियक पर आप वेरियस प्रोसीजर क्या करते हैं, डिपार्टमेंटल स्कोप, उस पर आप एक एक का प्रॉम डेवलप करो. आपका स्कोप ऑर्थोपेडिक्स नहीं है, तो why you want to waste time in developing a PROM for orthopedics? एक है तो you can manage it. So you have to use it based on your scope through and through, before, during, and after, and you have to look at everything. So when to use PROM is through and through. ये नहीं है कि experience है outcome है. This won't work. Throughout you have to judge the experience. Throughout you're checking the outcome. Before, during, and after. It is not one-way technique. Now, when we look at application, so patient and look at again, let's look at this. Patient treatment, insight into health of outcome, that is application. Patient and healthcare providers, hospital के लिए क्या मायने रखती है? Hospital, once they do PROM, they can improve their screening and diagnostic, they can identify problems, they can improve joint decision making, they can monitor the patient better, and they can evaluate treatment and care, so they can support patient self-management. So PROM is useful to patient. He gets insight into himself, what he wants. He empowers himself by asking, I want this. Hospitals, inka ye advantage hai. So they will improve their quality of life. Finally, for doctors, you will also gain into an insight. Communication with patient is much better. When you communicate, you will also find opportunities for improvement. And then you will also know, okay, मेरे से ये नहीं होता, मैं यहाँ उसको रेफर करूंगी, उसको यहाँ रेफर करूंगी. Rehabilitation, for example, knee and hip replacement, very rarely we refer to rehabilitation. But if the doctor does PROM, orthopedic surgeon, he will realize the importance of good rehabilitation. He will develop a strong care pathway. At the end of the day, patient will be happy. Cardiac, he will develop a good cardiac rehabilitation. You are giving the patient the quality of life that he wants. So that is the purpose of PROM. आप एक patient को एक आदमी के रूप में देखेंगे, एक case, and you will improve your internal quality, external quality and transparency also, and helps you in research. So there are many questions है, आप इसको देखो. इसको हम दो तरीके से देखते हैं. एक जेनरिक बोलते हैं, different populations पे आप यूज करते हैं. That is SF36 EQ. One is SF36 and one EQ5D. All this is available. Short form 36 questions है, जो generic है, जो hospital में patient को we will be. This is on the net. That is why I'm not showing you. And EQ5D, that is also there, which will check you on health-related quality of life. आपको condition specific भी मिलेगा. Please go to Oxford or go to any of them. Condition specific. For example, respiratory में आपको various prompts questionnaire, already validated questionnaires आपको मिलेगी. Knee and hip replacement पे मिलेगी, behavioral में मिलेगी, psychiatric पे मिलेगी, cardiac पे भी मिलेगी. So you have whole lot of validated questionnaires already. Like I am giving you this, so आपको functional SF36 में 9 domain होते हैं. So you have physical function में, role limiting, body pain, general health, vitality. So ये domain पे आपको questionnaire मिलती है. So you can directly use this questionnaire, very important. And then EQ5D, जो anxiety, depression, pain, discomfort, already developed, use them. PROM is global में 5 domain होते हैं. This is very important. You can use it for cardiac surgery or knee surgery, जहां हम physical domain, fatigue, pain, emotional distress or social. So in our hospital, we use these questionnaires to do PROM. So it is available, not at all difficult, only you have to understand. For example, आपको एक outcome है, तो बोलते हैं patient reported outcome है, मुझे depression है, तो आप कौन सा measurement use करोगे? आप PHQ 9. When you go to the Oxford, they will tell you, for depression, use this scale. So you will do PHQ. These are all validated scale. आप उसको use करेंगे. Then you will do PRO, PM, patient reported outcome, performance measure. तो आप बोलेंगे, okay, इतना percentage में मैंने ये score था, मैंने इस score को improve किया. So only by behavioral therapy, not by drugging. So this is the way you go. So डिप्रेशन में जो है उसको स्कोर करेंगे, PHQ9 आप उसको मेजर यूज करेंगे, And then what is the improvement by using the PROM, आप उसको finally measure करोगे. This is the steps that you go. Okay, is it valid? Question hai. All these questionnaires are valid. They have been tested, but you can also develop your own square. So a conceptual framework मैंने depression को डाला है. You can look at it various ways. Physical functioning, वो जो depression हो जाती है, they won't go. You can do exercise. अब social functioning नहीं है, किसी से बात नहीं करते हैं. So you talk to friends and family how to work it out. Psychological. So the depression can be after a cardiac surgery. The depression can be after a knee surgery. The depression can be after a viral fever. But उसको देखना जो patient feel करते हैं, that is very, very important. So another example, patient diagnosed with cancer, वो मैं how long will I be alive? वो important है. And therapeutic में उनको nausea, pain, body image, sexual function, independence वगैरह, which is very important to patients, इसमें आप prompt कर सकते हैं. I'm not going to go into that. Example 2, very important is hip and knee replacement. Every other hospital has hip and knee replacement. You can take that. So some of the validated tools for hip and knee replacement is Oxford Hip Score. You can use it for varicose veins. There are a lot of questionnaires for VVUQ. You can use that as prop, and this will help you to practice, and then you can bring about your own scales later. So disease specific is one corrective tool and validated tool. So it is not biased. So that's the way these questionnaires are formed. So it is not biased. Patient will give their own answer. Now, PRAME, this questionnaire focuses on care process. So they usually measure later. घर चले जाते हैं, फिर आप पूछेंगे आपका एक्सपीरियंस क्या था. वो बोलेंगे मेरे को कोई बोला नहीं एम्प्टी स्टमक आने के लिए, मैंने ये दवाई ले लिया था, फिर मुझे वापस भेजा. कैटरेक्ट से मैंने एस्पिरिन ले ली थी, किसी ने नहीं बोला मुझे 3 दिन का एस्पिरिन स्टॉप करो. इट ट्रबल्ड मी अ लॉट बिकॉज आई वांटेड टू हैव अ विजन, दे पोस्टपोन. सो उनका एक्सपीरियंस आप बाद में पूछेंगे. So communication is the level of satisfaction of care. For example, आप लेंगे प्रेम. So picker patient experience questionnaire है आपके पास. So communication, information, involvement of care है. You can also use hospital consumer assessment of healthcare providers and system. वो survey also overall satisfaction लेती है. और general practice assessment. You can use any of these examples of PREM. Kaho has done a fantastic work. They have brought a white paper on PREM. I was also part of it. And we did how elders. See, nobody, when elders are brought, the son and daughter will talk. The elder will be sitting like this. Nobody will ask him even what do you want? Do you understand? Did you know what you're doing? What medications are you taking? He comes to hospital. He doesn't utter a word. Nobody talks to him. He's being treated. Drugs are put. He's sent home. At the end, nobody says, what does the elder feel? Is he looking after himself? Did he ever want this surgery? Does he want to live? Or, what is it that he wants to do? Does he want the tube inside his throat? So we did in elderly, and we were shocked to find that many elderly want to tell you what they feel, how they feel. And we got a fantastic answer because sometimes they're cognitively impaired. Then who do you ask? What is the ethical aspect of taking decision for an elderly who has dementia? उसको आप कैसे करोगे? आप just उसको बात ही नहीं करोगे, that is not possible. So you have to look at it. अब मैं to all the participants, this is a quiz. So all of you, please answer this quiz. PROM is patient reaction outcome measure. Is this true or false? Answer in the chat box. You can unmute and say, no, this is not true. If it is not true, what is the correct? If it is true, why so? Is PROM patient reaction outcome measure? Anybody can answer? Chat box, I can't see the chat box. Jui, just check the chat box. Hello? So many are there. I want them to answer the quiz. They have to answer the quiz. You can unmute. Hello, Deepak, Jitendra Nayak, सौरभ सिंह है, सोनाली है, कोई भी अनम्यूट बोलो. Is PROM patient reaction outcome measure? Anybody can answer. Please unmute and answer. Is it true or false? Somebody has answered in the chat box. Anyone wants to answer? Please answer. What is the correct answer? Patient? Is it patient reaction outcome measure? What is the answer?
Patient response.
Is it patient response? Anybody else?
Oh.
Anybody else?
Patient
Is it patient response? What is PRM? Anyone can answer.
Patient.
Jitendra Naik ji, Saurabh Singh ji, Sonali ji. So, patient reported outcome measure. I want the Jitendra, Sonali, very good. So, PROM is patient reported outcome measure. Okay. Now, assessing pain and mobility after hip surgery, is it PROM or PRAME?
Ma'am, you are not audible.
Hello, now? Now? Can you see my slide?
Ma'am, the volume is too less.
Hello? I can hear you
Ma'am,
all.
you are not audible
You
as
can
of now.
see the question and answer in the chat box. Assessing pain and mobility after hip surgery is PROM or PRAME? When you
Ma'am, you
assess
are not
pain.
audible.
Hello? From when am I not audible? Juin?
Yes, ma'am.
Just read the quiz, ma.
You are not audible.
You are very much audible.
I think you are mute.
No, just read the quiz. You only read the quiz.
Ma'am, you are...
PROM means a patient reported outcome is.
Very good. The second question. Second question. I'm audible. Okay. Assessing pain and mobility, is it PROM or PRAME? When you assess pain and mobility after hip surgery, is it patient-reported outcome measure or patient-reported experience measure?
It is experience measure.
What is experience here?
Pain.
Pain, is it a part of the symptom? Remember, when it is a part of the symptom, it's reported outcome. He has come with pain and he has come with decreased mobility. So whenever you're assessing symptom of outcome, that is patient reported outcome measure. By hip and knee replacement, you will reduce his pain, you will improve his mobility. Now, in the hip surgery, can you formulate a PRAME question? Formulate a PRAME here. All of you, and put it in the chat box, formulate question for PRAME. Remember one thing, whenever you're assessing function of a particular therapeutic area, it is patient-reported outcome. Patient will come with and severe angina. His quality of life is decreased. He can't take even 10 steps. Severe pain. He undergoes bypass or stent, whatever. Then what is his quality of life? That is reported outcome. Now, during the stenting, he comes, nobody tells him what the procedure is. And then, his IV line started and that was paining him. Nobody said that the IV line would be started. All of that becomes his experience. Okay. So what he experiences about the care. I want somebody to put question, otherwise I'll not move. Somebody formulate a PRAME question. 23 of y'all. Any one of you even unmute and tell me.
Audience, please answer.
Center. Anybody? Don't worry. Right, wrong, right, don't worry. We're all wrong all the time. We're all right all the time. Form a frame question for this. Because you all are going to develop these document. Okay. When is the best? Juin, read the third question.
When is the best
Juin,
time?
read the third question.
Patient reported outcome measures. 2 days after the encounter, in real time, during the visit, during the admission assessment, and after the consent for procedure.
So when is the best time?
When is the best time to collect patient reported outcome measures? Options is in real time during the visit, third one during the admission assessment, and fourth after the consent for procedure.
Anybody can answer.
Please answer.
I'll put it in the chat box. You have Sujata, Sumangala Bose, Insha, Jitendra Nayak, Kanaiya Kumar, Kaumani, Priyanshi Gupta, Abhishushan Jaina, Sabah Salma, Sandhya Paswan, Sonali, I like that name. Sonali, can you answer? Sonali?
During admission, one answer is 2 days after.
Very good. And then prom is
2 days.
you can do even later. So Sonali did not unmute. Sonali, all are there only. Okay, all right. Your institute. Okay. Next, Juan, read the fourth question. Very good. Some are answering now. Juan, read the fourth question.
Name 2 things that increased patient satisfaction has an impact on decreased and increased.
What is the impact? आप patient satisfaction को देखोगे prom और prem से in these, which is the most important impact? Decreased admission, decreased mortality, increased medication use, decreased pain complaint, fewer doctor visit, decreased hospital length of stay, fewer minor complication, improved disease prevention.
Fewer minor complications. Few minor.
Someone telling fewer minor complications.
Yes, fewer minor complication, improved disease prevention. Very good. Any other?
Very good.
More than one?
Decreased readmission rates and decreased mortality.
Yeah, definitely. So when you not decrease mortality may not be, but fewer doctor visits, and you'll also decrease the hospital length of stay when you take patient satisfaction. That's very, very important. So 1 minute to all. It's a lunch time, and taking class or during lunchtime is very difficult. So I'm just going to put this. Not this. Hold on. So examples of prom, just remember, whenever you're doing symptoms, functional status, quality of life. This is the levels. So when I'm assessing pain, fatigue, sleeping, symptom cognition, depression, all this becomes prom. Functional status, daily activity, social activity, how are they doing? Third, quality of life. So आप याद रखो प्रॉम में 3 लेवल देखेंगे हम. एक सिम्टम आप कैसे उनको इंप्रूव करोगे. सेकंड, फंक्शनल स्टेटस का आप मायने रखते हैं या नहीं. क्वालिटी ऑफ लाइफ का आप मायने रखते हैं या नहीं. ये 3 लेवल पर आपको प्रॉम करना पड़ेगा. प्रेम इज उनकी एक्सपीरियंस क्या है व्हेन ही गोस थ्रू ऑल दिस. जो बोला नहीं बोला, उनका डिसीजन मायने रखा नहीं रखा, किसी ने कुछ बताया नहीं, वो पेशेंट रिपोर्टेड एक्सपीरियंस मेजर है। पेशेंट रिपोर्टेड आउटकम वो कुछ सिम्टम्स पे आता है, फंक्शनल डिसेबिलिटी पे आता है, आप उसको करेक्शन करना चाहते हैं, लेकिन आप करने के बाद वो हुआ या नहीं हुआ, दैट इज आउटकम मेजर्स। सो डोंट गेट कंफ्यूज्ड, ओके। सो प्रेम इज एक्सपीरियंस ऑफ केयर, प्रॉम इज 4 लेवल देखेंगे आप, सिम्टम, फंक्शनल स्टेटस, quality of life, and other related outcome. So don't get confused between prom and prem. Anyway, at least some participation I brought you all in. Thank you very, very much for this wonderful opportunity. Join. I'm done.
But we are all.
Hello. Join, I'm done. Thank you all very much. Whoever is sitting there, thank you all.
Next. Moving. Challenges and solutions in process compliance to attain safe infusion therapy.
Last exit before lunch.
Yes, sir.
Start.
And
So good afternoon, everyone. Thank you so much, BD, to be collaborated with SGPGI in this innovative and ISCCM Lucknow chapter for being this innovative platform of maintaining the importance of quality improvement projects. So before me, to introduce on myself, I'm Dr. Gaurav Singh. I'm here with BD India. I provide clinical support to the organization. And as my earlier esteemed speakers have spoken about the clinical audits, the QIP improvement projects, I will taking you through the importance and how it will be implemented and how it can go impact on your lives and how it can easier way of having a work proficiency for you guys on those prerogatives. I'll just take you through few clinical studies and what are the prerogatives of having a quality improvement projects in your healthcare setting. So the agenda I will be taking through will be the setting of the patient safety goals and the challenges. So I will taking the patient safety goal and challenges, barrier in implementation of best practices, quality improvement project, 3T approach, and the best practices and the best outcome. To start with, I would say that what Dr. R.K. Dhiman sir and Dr. R.K. Singh sir have mentioned that patient safety is the hallmark of the quality. And for the patient safety, if I disaggregate into the components of the goals, starting with the proper identification of the patient, improve effective communication. As Pratibha ma'am was mentioning, that when we have to interact, going for any kind of a procedure, we have to be communicating it in an effective way, not only to the patient, but also to the interdisciplinary way. Because when we are working as an army. We are hand-holding to the patient, we are giving a handover of a patient. Stuff. So for that, we required a effective communication. Third will be the high alert medication improvement in the safety part. Fourth goal is what implements onto the prerogative of having a right patient, right process, and right prerogative of that 10 rights of the medication which we have desegregated into. Goal 5 is the reduce the risk of healthcare associated infection. As we all already seen that a lot of emphasis have been put on the HAIs, related complications, SSIs, and all those things. So I will be taking you through certain of those. Risk of patient harm due to the fall. So in today with the session of certain esteem, they have shown us all those features, how we effectively enhance our quality care, how we can enhance our patient handling, and how we can, in a way, enhance and improve our working. There are certain things as Pratibha ma'am and even Dr. Bhaumik, Dr. Dhankar have shown us that there are certain attributes. If it's related to the complication, if related to the safety of the patient. What I will be tailoring and focusing more about will be the safe. I'm talking more about safe infusion and injection practices is because this is one of the most commonest invasive procedure which happens into the hospital whenever a patient comes to us. This is the first line of contact which a patient get when it comes to contact of any healthcare setting. And there are certain challenges to it. So when we have seen that when we go for any clinical audits, when you are from forming any kind of a quality improvement project, we have to go for the we have to identify those challenges. When we get our challenges, then only we can effectively give the safe infusion and the injection practices. The challenges are, first and foremost, is the workload and the patient volume. If I take up the example of SGPGI being a tertiary center, is always in a role. We have all, I have worked in the emergency of the SGPGI as well. I have seen that not only the wards, you are also taking care of the patient in the stretcher as well. So this is an added labor to you. This is an added workload for the infra kind of a way. So how we can, as Dr. RK sir is working on making certain attributes, certain protocols, how we can remove the workload of stretcher and how we can effectively take the patient on the ward so that our work is also being impacted in a positive way. The clinical outcomes in being derived in a positive way. So for that, first we have to identify that we have overcrowded hospitals. Second, we have a high patient volume. In US, or if I take the reference of the global meet, they say that one nurse is one patient is the ideal scenario of having a patient care. But do we have in India? Do we have in our limited resources countries? No, we don't. Even in SGPGI, being one of a very much funded and very much established infra, yet in SGPGI as well, a nurse will be attending at least 15 to 20 kind of a patient. And that is an added labor to that workforce. So how we can align that workforce, I will take it up in my subsequent slides. Second key attribute is that lack of standardization. What Dr. Bhaumik has also mentioned, that lack of protocol and policies. What R.K. Dhiman sir mentioned in his inaugural speech, that whatever we are following in SGPGI is into the SGPGI setup. We don't know that if that has been percolated onto the periphery, like certain district hospitals, or even example that certain medical colleges which are even in Lucknow as well. So how we can percolate that, how we can take up those things in a perfect standardized way, we will taking up into that consideration. So first is that lack of SOP. We work very much intuitively on the infusion practices, injection and all those things, but we have learned it. If I will say it onto that academic part as well, injection and the infusion chapter has never been taught that intuitively part. We all, I mean, the young fraternity which is being in the college will agree onto that. They don't have so much of content in their textbooks, but once you go back, senior, when they go and they will start working, having a patent IV line is the first and the foremost thing which you require. Having a perfect IV line and having a proper dressing care of that IV line is the first and the foremost pillar of your workforce. So for that, how we can have certain prerogatives which we can have through technology, through in my subsequent slides. Lack of protocols, which I mentioned that there is no certain SOPs. People know that when a patient comes to you, they start with that, they have to start certain medication. And IV insertion is generally being taken up care by the clinicians of the. Then how and when we have to go for certain gauges, which site selection we have to implement it out. So that is also a lack in our setting, and hence we get complications like phlebitis, we get pain and swelling and all those IV related complications. Third is the lack of equipment and resources. We address that there is a high patient volume. We have seen that there is lack of standardization. And then if we have to empower our nursing staff, we have to provide them certain technology. Starting, if I start the era of infusion therapy, we have started with the steel wings. Steel needles were used for the infusion. Then we have shifted to the Teflon catheters, and now we are going for certain improved safety IV catheters. But so this improvement is being implemented because we want certain good clinical outcomes. And for that, we have to be empowered with that technology part as well. Jab tak wo technology we don't have it in our setup, how we can implement it out. So for that is part comes as the unsafe. NSI is certain thing which is already been have been taken up upon the blood and body fluid exposure. Whenever we are working near to a patient, we are always prone to having a blood and body fluid exposure. Hence, certain technology came up. Acutainers. So this is something which is gap in the infra, not having a certain gap, certain number of beds, adequate number of nursing amount, adequate number of training and technological. But not every hospital has those things. So this is something. Training and improvement is a continuous process. We always have to empower ourselves with the current practices and have to always learn and unlearn new things. Correct. Last is the training part, which I always prove that training is a continuous thing. What we have learned in 15 years ago is not a relevant thing right now into the current prerogative of the health infra. So we always have to improve ourselves. We always have to learn few new things. Hence, part comes of our regular audits and RCAs. When we have to identify that what is the root cause, what is the complication which is challenging us, and if there is a solution part with the training or to a technology, then we can implement it and get a. Second is proper lack of training. So, I mean, in PGI, we have certain dedicated schedules, modules for training, but not in every setup. Not in every setup, we have a dedicated team for having education and all those prerogatives. Fifth is the infection control issues. So all the RCAs, all the QIPs, which we have been talking about since the morning, part, because prevention is better than cure, what we always go for. So what, not only the prevention part is implementing onto the patient prerogative, it's not revenue part to the health as an infra aspect as well. So that comes on to the high risk of having NSIs and blood-body fluid exposure. So what I have taken as example, when a nursing fraternity or a nursing officer or a nursing leader have to cater 1 or 2 patients, then that catering will be done in a more effective way, in a more productive way. And when that nursing officer have to cater 15 to 20 patients, so that is a labor to her. That is NSIs and blood-body fluid exposures. Poor infection control and the infection control interventions. So there are certain attributes of the technology which where we go for the sample collection, where we go for the infusion as the technological part and the medication administration part. So I will take it up in my subsequent slide that how we can do that. Last is the medicational error. So not having an adequate medication administration to the patient, spillage of the medication, not having a proper flow rate to the patient is also something which is there. And hence the technological part comes into play of dedicated syringe pumps, dedicated IV sets, which decrease the chances of having adverse drug events or to the chances of having any error during so whatever the complication part is there, that is adding to that added length of stay to the patient, increasing cost of treatment to the patient. And you can also appreciate here, in India, we have almost 13 to 50% of a phlebitis. So you all could agree that whenever a patient comes to day 0, when we insert a IV line, is a green. The site is good, the dressing is good, but coming to the day 1 or the day 2, when we go for that, there is chances of having pain and swelling. There is dressing soiled. There is blood spillage. So how we can contain that through technological part, I will taking up to you in my subsequent slides. First is lack of empowerment. Empowerment here means that the technology, the protocols, the policy, giving a right direction to our healthcare professional is one thing which organization level have to work for. Lack of available resources and the safety. SGPGI also have that. In emergency department, we have started a QIP with Dr. R.K. Singh sir, and we are getting a good clinical outcome of it. So certain intervention have been measured in the emergency department regarding to the use of safety IV catheters, the blood control devices like needle-free connectors, and to that formation of a dedicated SOP that for which patient we will start with which barrier at the individual level. It comes on to the awareness that the colleges don't give that kind of a training to the grassroots level, that when they are the nursing fraternity is working on their academic part, they have to start with giving them a sense that how the technology is going to give them a good clinical outcome through the education and the technology training part. And lastly, the reward and recognition. So whatever the QIP and the clinical audits which Dr. Bhaskar have shown you of PRS hospital, he was taking a pride of saying that I have decreased the collapse from this. So this is also something which we have to take into consideration, that whatever good work is being done, we have to give it healthcare worker, because that is the added labor to getting those kind of things into a process part of that the quality improvement which have been taken to QIP. So Dr. Bhaumik have shown you that get an impact of it. So when we are forming a clinical audit, this is something which we go forward that we have to address, take up a problem. Then we have to address the for the training and the education of the professionals, that this is something which we will going forward. Lastly is the tracking part, going for the process and the outcome surveillance, that if we will implementing this training, this technology, how we are impacting our life and to the patient life. Second is the feedback and the outcome surveillance, which Dr. Pratibha ma'am was mentioning right before me, that PRAME and PROM comes into the part. Whatever the interventions which we are putting as per the part of technology, as per the part of education, how it is replicating and implementing onto the patient life. That will comes onto that part of feedback and outcome surveillance, which is been termed as PRAME and PROM. Lastly is the feedback performance, which Dr. R.K. Singh sir was mentioning, that if a patient is satisfied, then only I will agree on to the point that quality patient. So how the things work onto these things. So this is, it looks like a bundle, it looks like a very agitated slide. So we have segregated into 3 points. 3T, which we call it up as a 3T approach of forming any kind of a QIP. So when we go for formulation of any QIP, we have to go with 3. We have to take up a solution as per that technology, as per the education, and then we have to educate and train our healthcare professionals on those perspectives through customized training, through on-job hands-on training, through workshops. So a similar workshop setup which we have put outside, we will be showcasing you certain technology of safety. So these things comes into a part of safety and to the part of technological intervention which has been taken for QIPs. We adapt that bundle, we train our staff, and then we give them that technology. Intervene. First, we have to give a proper training, proper guideline to that healthcare professionals, residents, doctors, nursing fraternity, that this is something which we are using. Sure. Which we are using and how we can cultivate it and in a good positive clinical outcome by using at the right place, at the right time, with the right technology. So there are certain tracking programs like PRAME and PROM. There are certain tracking programs which BD have derived, which is onto the prevention of infection, which is PRIME, then onto the vascular access management, which is VAM, and the formation of infusion team. And one such program which we are running very effectively in the emergency department is the leadership of Dr. R.K. Singh sir. Dr. Mani and Dr. Tanmay sir is also giving us an enabler and a facilitator on that. You also have been trained by Mohit and Muskan onto certain technological interventions. So this is something which we are doing effectively in PGI, and I will show you that how it is being impacting. So I am giving, this is not PGI, but this is a case study of Indian prerogative. So what we have done, we have taken up the challenge of infusion therapy related to the. So for that, what we have done, we have taken a 2 intervention. We will be close. We will be using 2 things, shifting from open port to the closed port, and after any manipulation of the device, flushing of the line is been taken in this study, and how it has been impacted. I will show you that. This was the data. So central line was taken into the consideration. Study group, you can appreciate. So in the stopcock is the open port. So you rotate the knob and you give a medication or all. The chances of blood reflux, the chances of medicine spillage is there. So to cultivating that, what we have given, we have given them the split septum. So this is the needle-free connector. This is the closed port, correct. So if we put it behind to any IV line, there will be no reflux. There will be nothing which will be coming from inside to the outside, and nothing will be going from outside to the inside. So it acts as a check valve. And to that, we have given the flush syringes, prepared flush syringes, so that whenever we see any kind of a complication, whenever we go for any medication, we go for any kind of a procedure, then only we got to know that there is a complication. When we go for any kind of intervention, then only we got to know that there is any kind of a complication. So that when I am gone for a certain thing and then I have to come back, prepare a flash and go back. Instead of that place, if there is, so the moment I've seen the blood, when the moment, so these only two things will have been taken on to the patient of 547 patient versus to 549. Significantly appreciate that the CLABSI rate have been 6.4. So it was in 1,000 central line days. If I put it into the patient per 100 patient with the open port versus less than 1.5 to. So we have taken only two things as an intervention, and we have shown that. So every clinical outcome, everything. So this was the study which I was talking, is what been published in American Journal of Infection. This was done in India, in Mumbai and Coimbatore. So whatever the interventions, whatever the technology, the things comes into play, that the patient which is coming to us is not able to get this pour this kind of a cost thing to the patient. But in this study, they have also shown that by the use of these devices, if you can appreciate here, the cost per patient with CLABSI versus open port to the closed port, you can appreciate here that by intervention of $1, we have saved $124 of that patient. How? We have decreased the CLABSI rate, we have decreased the length of stay, we have decreased the use of antibiotic, we have decreased the use of pathological intervention. A patient length of stay added is not only the length of stay, not only the bed charge, it's also implement the pathological interventions, the antibiotic we are using, the bed charge, of course. So all those things have, when we have put it together, and the flush syringes which we are using looks like a cost to a patient, but in a way, in a longer run, it has been decreasing the cost to the patient. Correct. So on those things, so I will take you through certain technologies. So this was two things which were used, and on those parameters, there are certain safety technology part of intervention which BD have. So we have outside. I will really urge you guys to have a look onto it. So in this catheter, what we have. So when we are inserting it, or when you are going for any medication, you don't have to put a distal pressure injection. What we do, we go and put a distal pressure, then we remove that cap and attach a syringe. During these kind of a thing, we are manipulating the device. The vessel is this much, and there is a foreign body IV catheter also manipulating it. So whatever you do, whatever the best you will do in day 2 or half a day, I mean, after 24 hours, you will start getting pain, redness, swelling, these kind of a therapy, certain technology. So distal pressure, if I will place it out, I will say that distal pressure is something like taking a brick out of a wall, inserting a pipe, and we are watering that wall. And then we are going almost 8 to 9 times and checking that wall by Actually, that wall will collapse. A, B, and C shift. At least 3 to 4 bolus injection into 3 gives into the 9 to 10 times. 9 to 10 times I'm giving a distal pressure and manipulating that device. That would eventually lead to that complication. Phlebitis, and that phlebitis if it get aggravated. If I would say on a lighter note, in your care, Tanmay sir would have been come and say that let's have this patient on IV. In the morning, I will the patient get a spike of fever. Then what the Tanmay sir will say? Tanmay sir will say that let's observe it, let have the patient and so that irrational use of antibiotic is not getting into play. Administration part are going to impacting onto the negative way. When talking about NSIs and all those things. So we have a safety catheter. The moment we have our stillet out, there will be a plastic cap shielding it to it. So they will be not getting any kind of NSI for you. And what Dr. Dhiman sir was mentioning that we work into an interdisciplinary way. The paramedic staff, the housekeeping staff, that patient, that person might not having a that much of a IQ is dealing with our biomedical waste is not having a certain awareness unlike you guys. So for you into that hospital setting, what the person is also NSI for that patient or that person. So for that, we have been percolating of use of safety IV catheters and the use of these extension sets, which has been called as the needle face connectors. By the use of this, what we are doing, we are minimizing the chances of getting any kind of a contact of a blood with you and to the emergency as well, because emergency is the first point of contact of a patient with the healthcare. The patient who is coming to us is of an unknown source. We don't of the vigilant on whenever going off to any kind of a procedure with a patient. Going for the certain aseptic techniques. To conclude it out, I would say that we have these audits, we are doing this kind of a churn out of a data, clinical evidence, but how if we are not implementing it onto that patient bedside, onto our workforce, effort which we are putting onto those clinical audits. And the first and the foremost thing, start with that about behavioral change. At times we used to have technology, but we are so much onto our practices that we follow those practices. Hence, always shift to a better outcome. Shift and learn and unlearn. That's what I'm percolating here. Is that starting from the behavior of hygiene till the scrubbing, or whenever we are going for any kind of intervention, we are going for any kind of medication, we have to scrub the hub. And behavioral change, we require certain technology part, and that technology part is this here. We have the safety IV catheters, we have the closed pores for containing the blood. The movement you can appreciate here. During the time of cannulation, we can flush it out to check that we are in the vessel or not. Then for the medication, during medication, post medication, and after every attain certain few things out of follow the ethical and the code, and post my every shift, I will flush my line. Because what we are doing when we are going for any medication, we are giving a bolus injection, and then we are waiting at least 5 to 6 hours till the next healthcare worker, next nursing staff comes into play for giving that injection or taking any sample. Till that 5 to 6 hours, when the line is not manipulated, then only the chances of getting this kind of a complication aggravates. So hence we urge you to have those practices of shifting of close interventions like safety IV catheters and flushing of the line. So these things have resulted in a good way for the certain hospitals, and not only for the certain hospital, to the ER of the SGPI as well. So we have certain data that we will publish to you whenever we get a chance to it. So this is my urge to that to something.
We are now taking a break for 15 to 20 minutes.
ये अपने अपने पास कहाँ पे
खाएंगे तो अच्छा नहीं लगेगा ना।
उसके बाद तो सही है।
टेलीविजन
ले लेंगे क्या? अरे अभी मैं खा लिया, आप रखना है, अभी लेंगे आप लोग।
किशोर की बैठ देंगे ना इधर।
बैठ जाइए, बैठ के खाइए, बैठ आराम से यहीं बैठिए।
प्रोग्राम की रिकॉर्डिंग चाहिए।
दो मिनट के लिए आ जाना सर। हाँ चलना क्या? अभी आपको जाना है क्या? चले जाना है जैसे बताइए, मैं हूँ तो इधर ही खाना खाना होगा।
अच्छा फोटो के लिए
हाँ 5 मिनट के लिए, 1 मिनट के लिए हो गया सेकंड वाला आ जाएगा। ये वाला बड़ा कठिन था
आलू चाहिए। डॉक्टर हर्षवर्धन बोल रहे थे ना, वो जब आप लोग प्रोफेशनल लाइफ में जाओगे तब देखना कितना इसका यूज है, बहुत जरूरी है, क्योंकि हम लोग कंज्यूमर एक्ट के अंडर में आ गए में बहुत तरह
आएगा दिन कठिन ही होगा,
आने वाला दिन बहुत कठिन होते जाएगा, क्योंकि वी आर सर्विस प्रोवाइडर। ओके, जैसा सेफ आके आके पूछते हैं ये डिशेस कैसा रहा, मैंने बनाया, रेटिंग दीजिए। ठीक है, हॉस्पिटल भी ऐसे ही है, रेटिंग में चलता है। 2019 का मेदांता का एनपीएस कितना है पता? एनपीएस मतलब नेट प्रोमोटर स्कोर 79। इट वाज बियॉन्ड द एक्सीलेंट। whereas मणिपाल हॉस्पिटल ग्रुप का है 59। इट वाज सोशल। हमारे हॉस्पिटल को पता ही नहीं, गवर्नमेंट सेक्टर इसमें जाता ही नहीं।
लोग जोमेटो से खाना मंगाते हो, गाड़ी चलते हो, ओला उबेर सब लोग बोलते हैं रेटिंग दे दीजिएगा, अच्छा 5 रेटिंग,
क्योंकि हॉस्पिटल अभी बिजनेस सेक्टर है ना, हॉस्पिटल बिजनेस है। एजेंट भी बोल सकते हो, जैसा कंपनी में एजेंट होता है, हम लोग स्किल एजेंट, गवर्नमेंट प्रोफेशनल एजेंट। इसलिए बोलते हैं पेशेंट के सामने कभी गुस्सा मत दिखाओ। आपको पसंद नहीं है उनकी बातें, फिर भी स्माइल दे दो जरूर। वो गाली भी देगा तो स्माइल के साथ पॉजिटिव हो, बाद में जरूर गाली मारना। हमारे पीजीआई में अभी बहुत कॉम्पिटिशन आ गया, क्योंकि पहले इतना प्राइवेट हॉस्पिटल थे नहीं, अब प्राइवेट हॉस्पिटल आ गया। पेशेंट दे दो, वेटिंग टाइम ज्यादा है किसी चीज का, वो भाग रहा है प्राइवेट।
ट्रे ही फटी हुई है, सारी सब्जी नीचे गिर रही थी, मैं सोच रहा हूँ सब्जी कहाँ जा रही है।
देखते
यहाँ पे डालो, यहाँ पे
Just to attend. People are still sitting, are we discussing? सबको बोलना पड़ा भैया please जी. अच्छा बहुत सुंदर है, बहुत सुंदर. हेल्प करो हिंदी में बोल रहा है, हम भी हिंदी में बोलेंगे अभी उसमें आ गया था. Thank you. You're most welcome. अगर लड़का कैमरा सारा हो रहा है मेरे ऊपर ही आ गया है, देखो मैं कितनी काली लग रही हूँ. कैमरा चाहते बस कर
मेरे पास लेकिन सब्जी नहीं है, सब्जी नहीं है.
सूखी वाली है.
सब्जी है.
ये लो ना, सब्जी है तो इसमें.
अच्छा एक्स्ट्रा है ये.
शिवानी ने कहा
हाँ?
शिवानी ने
कहाँ है?
लाइटिंग पे.
पेट में लेगा तो सबसे पहले तुम करो वैसा. इतनी मोटी हो तुम, बाप रे बाप.
मार दूं.
अभी जब हम लोग ऊपर आए ना तो जैसे ही चढ़ी ओवर ऑलरेडी दिखा रही थी.
हम इतने मोटे नहीं है ना विशाल.
हाँ.
टेंशन हो जाएगा मुझे. उससे पहले तो फिर मुझे करने की जरूरत है. डबल ओवरलोड हो रही होगी ना. यस पहले आना स्टार्ट करो.
और शादी अकेले भी लिफ्ट में चढ़ती है तो ओवर ऑलरेडी दिखाती है लिफ्ट.
आप नहीं वैसे डाइटिंग इसकी तो जिम करते हैं आप.
मैं क्यों डाइटिंग करूँगा.
जिम वाले होते हैं ना डाइटिंग. इनका इनटेक आउटपुट बराबर हो जाता है, जितना ये खाते हैं उतना वर्कआउट कर देते हो.
इसको ज्यादा
तो ज्यादा देर रोटी नहीं खाना. मीठा तुम खा लेना. खा लेना
क्या
ना.
नहीं बहुत समझा हो.
ये है तो एक एक्स्ट्रा दे देगा. मैंने दे दिया.
या नहीं है, तुम डाइटिंग करो. और तो सैटरडे को ना जिस दिन फुटबॉल आई थी हमारे ऊपर वाले फ्लोर से आवाज आ रही. बाद में पता चला वैशाली दौड़ते हुए नीचे आ रही.
वो तो नहीं गया था ऊपर का. आगे दो. देखो इस कैमरे में क्या था. कैमरा मुझ पे फोकस कर रहा है, पूरे फुल टू बोरे हम ही नजर आ रहा है. हाईलाइट हो रहे साथ ही. ऐसा लगा भक्त ऊपर बैठो.
करना है हमको.
अच्छा आप कॉलेज कहीं चल के सो जाए
को मैं बाद में सिखाऊंगी कैसे इसके बाद प्रोग्राम होगा तो तुम्हें लोग बताएंगे ठीक है
मैंने नंबर दिया था
थोड़ा सा सीक्वेंस ये मैं डाउन कर सकती हूँ सिखा देंगे
अच्छा लग रहा है बहुत चीजों पे थी ऐसा लग रहा है बहुत दिन से खाना नहीं मिला अब बहुत दिन के बाद खा रहे हैं खुद को देख के
तो है
मैं डाल देता हूँ।
मैं सुबह से एक अमरूद खा कर आई थी
ठीक है आप बुला लेना शुरू करो। हाँ।
अरे भाई चावल दाल भी ऐसे तो दाल चावल भी खा रहा है तो आता
ये बातें इसमें जा रही होंगे सब हंस रहे होंगे
पहले क्यों बता सकती यो तो आप कर दो यार क्या से आप
नहीं होगा
थोड़ा सा दे दो यार क्या
तो चावल निपटा तो दूंगा
हाँ यार
लेकिन दाल के साथ
सब्जी रायता ले लो रायता चाहिए इसमें खा लो रायता सुनो इससे खाना तो खा लो ये नहीं खाना मुझे ये नहीं निकाल दिया कुछ भी। ये खा लेते तो वीडियो जरूर बननी चाहिए
इन सारी प्लेटों में नीचे की नाली भी देनी चाहिए
ये 10 मिनट के अंदर हो रहा है 5 मिनट लॉगिन हो जाता
I'm done.
मुझे तो भी पता चल गया कौन कह रहा था पूरी रात जग के करने के लिए
और ये खुला है रात में बातें कर रही है बंद है ये यार गलत जगह बता रही है बाद में गरिया बुला के अलग से
डायरेक्टर ऑफिस में बुला रही है।
बंद हो रहा है। तो बुला रही हूँ। आशुतोष, ऐसा ना हो कि आपको और तुमको
मैं बोल दूंगा यही
सुपर सुपर
मेरी आवाज में बात कर रही
सबकी आवाज चेंज कर देंगे। ये कुछ और नहीं है यार, बंद कैसे होता है यार, ये बंद नहीं हो रहा है। थोड़ा सा बंद कर दो। अरे नहीं, थोड़ा कुंडी वाले में वेट बढ़ाओ, तुम बहुत पतली होती जा रही हो। मन दो बच्चा, मन दो यार, मैं नहीं खाती प्लीज।
अरे नहीं,
हाँ वो मेरा ऑर्डर
चावल लेके गई है। ठीक लगा
वाले ये चला कर लिया। अरे तो अपना टिफिन नहीं दे दोगे उसमें लेके आएंगे। अभी है मेरे पास। हाँ, दे दो। अब तुम बताते हैं जाओ। मेरे रात के लिए नहीं है डिपार्टमेंट ये पेज में दर्द हो रहा है। भाई बैठ आ रही है
तीन 1 2 3 नवंबर और हमें तुम देखा नहीं रौनक है कि सोना तीनों मारूंगा पाड़ दे।
ओके तो मैं आऊंगी ना रौनक और अक्षय तुम अभी बाहर चलेंगे ना तो कर लेना। बाय मेरा बहुत पास उन्होंने
कौन है?
आने वाली है। नहीं नहीं
क्या? नहीं है।
सेट मैंने कॉल कर दिया है, ठीक है राजा को सेट
हाँ
इन लोग को बुलाना है क्या?
आप क्यों परेशान हो रहे हो? आप रख दो, कोई ना कोई ले जाए, आप मत परेशान।
मैं बोल रहा ना, इतना टेंशन में मैं इसके पहले भी जो प्रोग्राम करा था, बहुत टेंशन होता है पता है। एक तो पब्लिक का इतना ये आता है, फोन कॉल्स आता है, मैसेज आता
व्हाट्सएप
है।
पे ऑडियो का कोई इशू तो नहीं आ रहा है? ग्रुप पे आपने बनाया
सर एंड वन व्हाट्सएप ग्रुप पे मैं पूछा ये है तो अभी फीडबैक फॉर्म भेजेंगे।
इससे क्या ये आता है, पिछली बार तो बहुत अच्छा आया था, हम लोग बहुत सारे सजेशंस भी दिया था क्या क्या टॉपिक चाहिए, इसमें इधर उधर पेस्ट कर दे।
हम टाइम रखो नहीं हो रहा है पहली बार है किलो को बुलाना है ना कौन क्या निकले बुला दो
हम कब जाएंगे हम कब जाएंगे यहाँ पे हम कब जाएंगे यहाँ पे
चली जाए थोड़ा पैसा लगेगा
सच में यार हम लोग अंदर से बंद हो गए ना अब मुझे खुलेगा
सीएमएस का कैसे होता है
ये असली
उन्होंने ऑनलाइन तो थे ना
रुपया टमाटर ব্যাক করার জন্য হবে না বাকিগুলো ওরা মরে পড়ে থাকবে মরে যাবে ওগুলো আমার কষ্ট করে আনো
मोमेंटो तो सबके लिए है ना सर मोमेंटो तो सभी गेस्ट के लिए है ना ये राधा मैडम के लिए भी भेजना है राधा मैडम तो लेके नहीं गई थी ना हाँ
हाँ वो तो मैं लॉन्ग बनाया 8 लोगों ने
वो गुलाबी तो हम लाइक दिख रही है
सुनील को एक प्लान तो होगा है तो आंटी सर सर राधा मैडम के लिए मैडम को दे देना, ठीक है? चला गया, ओके चला गया, हाँ ओके, तेल दे देना, ठीक है?
ये दुपट्टे में और इसमें क्या ही फर्क है?
चिन्नी का दुपट्टा
दुपट्टे में ऐसे ही आते हैं। तो
जसदी स्टार्ट करो।
स्टार्ट करो।
We'll resume the session now. Zero effect and zero defect in healthcare focuses on eliminating environmental impact and achieving flawless patient care. This approach aims to deliver high quality services by reducing errors, waste, and inefficiencies. It promotes sustainable practices and excellence in healthcare delivery, enhancing patient satisfaction and safety. With this, I would like to invite our next speaker, Mr. Raj Gopal RG sir, to speak on his topic Zero Effect and Zero Defect.
Hi, good afternoon. Am I audible?
Yes, sir.
Thank you very much. So, let me share my screen. Screen is visible?
Yes, sir.
Thank you. So, my name is Rajagopal. I have more than 30 years of experience. I started my career with the Indian Air Force, then United Nations, and then I have been consultants for Quality Council of India, Confederation of Indian Industries, National Productivity Council, EY, Indotech, etc. So in quality, I started my career in Indian Air Force, and my quality career also was from Air Force only. And I served Air Force for 20 years. Then I became an independent consultant for MSMEs. And I'm a quality judge for Confederation of Indian Industries, where we evaluate projects for company like Maruti, Tata, Hyundai, etc. So that's basically for quality circle competition program. And then I'm a trainer for Six Sigma. I'm a Six Sigma Master Black Belt as well as project management professionals. I hope my voice is clear. Is there any disturbance? I'm very sorry because some work is going on in my office. So is it okay? Is there any disturbance, voice disturbance?
No, sir.
No, sir, not as of now.
Right. Okay. So see, ZDD is basically a quality concept only. So I would like to give some introduction about concept of quality and economic effect of quality as well as process approach. And then I'll come to the ZDD, Model of Quality Council of India. First of all, let me explain you the economic model of quality, economic effect of quality, because we say quality as a competitive advantage. Now, how is it becoming a competitive advantage? Right. So there are two parts of quality. One is the product quality itself. When I say product quality, we can talk about the service quality also, because you are into service sector. So product and service quality and product quality, and you can relate it. So when you take a product quality, it's about you are getting attracted towards like a mobile or anything you want to buy, or car or whatever it may be. So you look for the design, its packing, promotion quality, etc., advertisement, etc., customer care, etc. You take care of. So all this comes in the part of the product quality. So if you come to service quality, then you can relate it with the time taken to provide the service, the quality of people sitting in the front desk, the the communication to the customer. All these things comes to the service quality. So through that, when your quality, product quality or service quality increases, so that becomes a competitive advantage for you to get more sales and more customers. And thereby there are two ways of getting some profit. One is through increase your sales, and the other way is the neglected part of quality. Most of the time people think quality is all about the product quality or service quality. But there is another angle of the quality that's called that's the process quality. So whether it's a service sector or a manufacturing sector, people often do not take care of this quality and how it is affecting the economy of any business. So process quality is all about the way you do without any failures. You conduct your process without failures. There are two types of failures. One is internal failure and external failure. Internal failure is whatever happening, any mistake or rework happening inside your premises, and external failures are outside your premises. And both these failures increases your cost. So if you have better quality, process quality, then again your cost is going to reduce. So there are two ways of getting profit: either you increase your sales or reduce the profit cost. So why I'm stressing this, most of the time people do not see the other part, the process quality part. So ZDD or ISO or any system processes, everything is related to this. So most of the time we go for training or consultancy, we actually focus on this process quality part. Another, I just wanted to bring the origins of quality as well as the latest Six Sigma or ZDD, whatever it may be. So quality, it's all started before pre-industrial age. When in pre-industrial age, it was like a craftsman making, it's called, what do you say, a particular word is used for this kind of manufacturing. Crafts manufacturing, yes. So this is one particular manufacturing or service, whatever it may be. So before pre-industrial area, there was no machines, nothing. So one person who is responsible for designing the product or service, or delivering that product or service, and after sales service, everything one person. Then comes the Industrial Revolution. So from the traditional kind of business, it came to a mass business opportunities. In fact, manufacturing actually started, and then came the related services, right? So what happened during the Industry Revolution? There was a mass kind of production happening, but there was no quality control. So the first kind of quality initiative was keeping an inspector, quality inspector, and he checks the pieces good or bad. Like, okay. And then came the next major quality. All the tools today we use, whether in manufacturing or service sector, whatever tools we used, quality tools, it all invented during this World War II. So World War II, lot of problems happened, standardization problems, quality issues. So if today, whatever we see, whether it's a standardization, ISO standardization, etc., everything actually started after World War II, right? And then came another major, what you say, milestone, that's emerging Japan as a quality leader. You may be aware about this, lot of quality lectures you are hearing. So you may hear what the importance of quality, Japanese principles in quality. So they came with the total quality management, quality assurance, etc. And then came the latest during in 1980s to 2001. Lot of initiative towards quality came. That's like total quality management, then Six Sigma and lean management, etc. So whatever techniques, principles we hear today, it actually started for the manufacturing, and then it was extended to the service sector. For example, Six Sigma was for manufacturing sector, and then now Six Sigma is used in even hospitals and service sector. Service sector, a lot of Six Sigma project is being conducted now. Same way, lean manufacturing. Lean manufacturing, it's a totally different concept, like 7 ways, etc. So this was actually started in Toyota and Japanese industries, and then now it is extended to the service sector through lean management. So the concept of lean manufacturing, the 7 waste, is also there in lean management, service sector. So you also have in manufacturing, there are 7 kinds of wastages. And in service sectors also, there are 7 kinds of wastages, but in a different intensity, different levels. So why I'm stressing this? Because we should know what is the, how it all happened, etc. And now what is today? Today, we are into artificial intelligence, machine learning, data speed, accuracy, efficiency, and so manufacturing or service. So AI is playing a big role now. You can see in hospital sector, medical sector, a lot of technological advancement has happened. And data collection now, for example, if you want to, if somebody want to send a ECG to a doctor, it's very easy, and you can just get it graphically or digitally, communicating through WhatsApp or to this one. So it's all about AI. AI means it's every equipment, everything will have an IP, including person also have an IP through his ID card, a machine or the laptop or the machines you are using in hospitals. Everything has an IP, and it communicates through the IP, and real-time data is being generated. So there was a Six Sigma project we have done for a dialysis adequacy, I think. Somewhere KT over V, you may tell that dialysis adequacy is some measure is there, KT over V, where you have to maintain it somewhere 1.2 or 1.4, something like that. I don't remember exactly what is the standard. And then one of my student conducted a Six Sigma project over that. So Six Sigma, AI, data speed, accuracy, efficiency, these are all the latest quality related thing. And then came the latest concept called zero effect, zero defect. And this concept, less like rest, all concepts have been developed from Japanese, American industries. But ZDD is a concept by Indian government. So we should be proud of that. They have made a concept for ZDD, zero effect, and then some guidelines on that. And that is done by the implementing agency is Quality Council of India. So we'll come to that. So before that, let me tell you about the quality gurus. So maybe all of you know. It's Edward Deming is known as the first quality guru, and his concepts PDC and all you may be aware, and 14 principles of quality management, etc. Then came Joseph Juran. Juran's quality circle and quality improvement methodology is famous among the quality circle competition. There are 12 steps of quality improvement program, and first introduced by Joseph Juran. So he is also known as another quality guru. And then now there we have a lot of quality gurus from Japan, etc. So these are the main people, quality gurus. But then comes Phillips Crosby, and now for India, there are stalwarts, quality stalwarts in India. For primarily main 4 people who actually spread quality in Indian industries. First and foremost is late Sri Padma Sri Chandramohan. He was founder of the Punjab Tractor Limited, and he was the quality evangelist for India. And I was lucky to learn quality from him. And he started his first TQM Institute in India. Along with him, there are people like J.J. Rani of Tata, then Suresh Lalla of Kimpro, and TV Sundaram of TVS. These were the four people in TVS from South, and this Chandramohan in Northwest area. And these people actually adapted quality some concepts in their industries and also taught others to use it. Okay, so when we talk about quality, so we should know about the systems, improvement systems, management systems, etc. So basically, we all hear about systems, processes, etc. Now we should know it. If you are a quality, if you are learning quality, we should know about this. What is process? What is systems, etc. So basically, at the lowest level, it's all about activities. Whatever activities you are doing. Like for example, if someone comes to your hospital, the first activity is he will go to the reception and then he will tell his requirement. And the person sitting in the reception is to be made note down his requirements. He may note down his phone number, etc. And then he will be referred to a particular OPD or a particular doctor. So the first activity, so there are list of activities. So when you combine this list of activities, we call it as process. So we can call it as a registration process. I don't know what is the name given by you for that process, but let me call it as a registration process. Now this similar kind of processes, different processes, when we group these different processes, it becomes a system. So when you collect, so when what the collection of activities is called process, and collection of processes is called a system, and collection of systems is nothing but an organization. So an organization is nothing but collection of system, and system is nothing but collection of processes, and processes is nothing but collection of activities. So for any business, there are a lot of systems to be done or implemented and conducted. So any company, whether it's manufacturing or service, it doesn't matter. Any company will have four kinds of must systems. These are, one is their marketing or sales process. Second is the operation in the sense, the activities, your service activities, right? And then there is a quality management system, and then is a finance management system. These are the basic four things. There are HR systems also, but these are the four major systems that is run by any organization. So out of this, the quality management system, the best quality management system is ISO 9001 2015. Now ISO becomes a generic quality management system. Now then came, now when I talk about ISO 9000 system, this ISO 9000 you can implement yourself. There is no need of certification. But when you take a certification, it adds value, right? So when you take certification, there are two kinds of certification. One certification is a non-accredited, right? And another one is an accredited certification. So it doesn't matter you take a non-accredited also if you have a good systems. But again, when you go for an accredited system, then it adds value. So who is the accreditation body here? You all know, right? Can you tell me one accreditation body in India? Anyone?
NABH.
Pardon?
NABH.
Yes, NABH, National Accreditation Board for, isn't it? Hospital, right? NABH. Right, National Accreditation Board for Hospital, right? Now you are getting an NABH accreditation. Now there are 5 other accreditation bodies also. Like for hospital, it is NABH. For lab, it is National Accreditation Board for Laboratories, that's called NABL. And then people who are giving an ISO certification, there is an accreditation body for that also, that's called NABCB, National Accreditation Board for Certification Bodies. And then person like me who is giving trainings, etc., for them also there is an accreditation body called NABET, National Accreditation Board for Education and Training. Now, these all bodies are actually under Quality Council of India. You are aware of that, right? Quality Council of India. Now, Quality Council of India's 5 umbrellas, these are the 5 umbrellas of Quality Council of India. And the Quality Council of India, I'm not, I forget the year, I think somewhere 1919, before 2000, it was formed. And the first chairman of Quality Council India was Ratan Tata. And still they have that value system in that organization. And that's an autonomous body. And they have done a lot of quality initiative for Indian industries. And the latest by them is the ZDD, zero effect, zero defect, etc. So this is about process variation and all. I will not go into detail of this because it takes a lot of time. So let me come to the new concept of by Quality Council of India. Why I am taking this? Because you already aware about this accreditation. You are already maybe an accredited body, accredited hospital. Now who is giving this? They are all under Quality Council of India. And now the Quality Council of India's NABCB, the national, so it actually started, zero effect, zero defect was actually started when our Honorable Prime Minister took over in 2014. And in the 2015, August 15 speech, he mentioned about this zero effect, zero defect. And following is vision, Quality Council of India has made a program called Zero Effect, Zero Defect. But basically, now they have given this for only manufacturing sector, but KOCI is going to extend this zero effect, zero defect to service sectors and hospitals also. So very soon it will be coming for the service sectors and hospital. That's why I am just giving about this talk about this, right? So there are certain like ISO 9001, how a organization is getting certified based on ISO 9001. There are certain requirements, isn't it? The International Organization for Standardization, ISO, right? So they have made certain best practices for a quality management system. And they made some requirements, and any organization meeting that requirements, it's been audited through an external independent auditor. And then once they satisfied with the requirements have been fulfilled by the organization, then they are getting certified. Same way in NABH also, there are certain requirements. NABH auditors comes to you and they are auditing you against requirements of the NABH guidelines. So same way, NABCB has issued certain guidelines for this. So just open it. So zero effect, zero defect. Defect is all about quality, right? When you say defect free, zero defect, that means you have 100% quality. There is no customer complaint, there is no process defects, etc., etc., right? So that's all about quality. So defect is all about quality. So whatever is mentioned in ISO, most of the things are there in Z also, right? That's been taken, and whatever NABS guidelines. So all these guidelines have been taken in the quality defect part. Now comes the environment part. Environment part is all about whatever you do, you should take care of the environment. For example, the waste management in hospitals. Most of the waste management things have been followed by you. You are segregating the waste, bio waste, somewhere hazardous waste differently. And there is a system for all this. So it's very easy for hospital to get a ZDD certificate also, because already you have been taking care of this there. Now, coming to the requirement, there are 3 levels of certifications of Z certification. One is called bronze certification. Bronze certification is a simple with 5 parameters: leadership, Swachh workplace. Swachh workplace is also an important parameter for Z. Leadership, Swachh workplace, safety, quality management, and HR. These 5 parameters or 6 parameters is fulfilled, and bronze certificate is issued within 24 hours by Quality Council of India. And then the next level is silver. Silver certificate. So I am just showing you the generic requirements. Now for service sectors and hospital, another requirement is going to be coming within couple of months. It is going to be maybe another 3 months or 4 months, right? So these are the requirements of ZDD certification, zero effect, zero defect certification. So bronze, as I said, there are 5 parameters like leadership, Swachh workplace, safety, measurements of timely delivery, and quality management. For silver, there are 14 parameters like leadership, Swachh workplace, occupational safety, measurement of timely delivery, quality management, human resource management, daily works management. All these things are applicable to service also. Daily works management, plant maintenance and calibration. This is also applicable to you because calibration, you already do this calibration part in NABH, right? So if you see, most of the requirements have been fulfilled by you through the NABH requirements. Calibration is very, very important, right? Any machines or equipment you are using, if you want to see that the best result out of it, that machine should be calibrated, right? So there should be a calibration plan, then there should be a machine maintenance plan, then comes the process control and material management, environment management, etc. Supply chain management, all these things comes most of the requirements for manufacturing, but measurement and analysis is a good parameter for the service sector also. Then comes the gold parameter. The gold parameter, we are taking the risk management. Risk management also already covered in ISO 9001. Then comes the waste management. Waste management is about lean management. It's not about waste management, what you think about environment, disposal waste. No. The waste management here is about lean management. There are 3 kinds of waste called Mura and Muri. This is a Japanese concept. It's a lean management concept. Muda is 7 types of wastages. So 7 types of wastages is, one wastage is overproduction. Now in service sector, the overproduction is not a major waste. Then comes overprocessing. Overprocessing is a major waste in service sector. If you study your process, I don't have time today. I have only 30 minutes, so I'm not covering in detail of sometime, in another lecture, I can cover that also, process approach. So our processing is a waste. Then our inventory is also a major issue for service sectors. And then the waiting is also a big waste for you. Then comes movement waste and transportation. So movement waste may not be a big waste for you. If you see what is movement is all about body movement. So the fibers and all comes there, and in hospital it has been taken care. For example, in your operation theater. In your operation theater, you keep everything in such a way that in a very little moment you will get access to the scissors and all this equipment. So it's a kind of reducing the movement waste. So in operation theater you may be doing that, but what about the movements in your other areas like reception area, etc., etc. So lean management talks about all these waste stages. And then comes the technological selection and upgradation. How frequently you are investing capital investment. And then comes the natural resource conservation. These are all the extra parameter which is not there in the NBH. Natural resource conservation is we use lot of water in hospitals. So you must be having some water treatment plan, but are you monitoring that? So in the said parameter, we need to have a monitoring system for your wastewater, recycling of water, reuse of water, etc. All this part comes. And then the last part comes the corporate social responsibility. CSR part also comes into this. So these are the parameter. I'm not going into detail of all this parameter. I think this is all about my lecture today. So any doubt or any question you want to ask, please welcome.
If anyone have any question, you can ask. Okay. Thank you, sir.
Thank you very much.
Moving forward, hospital operation and efficiency focus on streamlining process to optimize patient care, reduce cost, and improvise resources utilization. This involves enhancing area like patient flow, staffing, and supply chain management. Efficient operation lead to higher patient satisfaction, better clinical outcome, and a more sustainable healthcare system. With this, I would like to invite our next speaker, Professor Dr. Sukhin Samanta sir, to speak on his topic, hospital operation and efficiency.
Good afternoon. Can you hear me?
Yes, sir.
Well, so my name is Dr. Samantha, Sukhin Samantha. I'm basically from India. I have been working in Cleveland Clinic Hospital, Abu Dhabi. So I'll be talking about the hospital operations and how we can improve the efficiency. So my disclosure, I don't have any conflict of interest, no financial supports or any kinds of, but I want to disclose that I work in this beautiful hospital, which have like a 90 bedded intensive care unit. And I also work as a quality officers at the level of critical care divisions. So being the world best hospital in the list, we have to maintain a certain qualities and certain safeties. So I'll be discussing on that, how our hospital operates and how we can learn from it, and the system of one of the best healthcare system in the world, and how we can take forward this concept into Indian context as a middle income, low middle income country in slightly modified way, and we can improve our hospital operations. So before I go into the details, we know that as a clinician, as a physician, so we only talk about the ED, we talk about the clinical departments, and we talk about the ICU, operating room, all these things. But to understand the concept of the healthcare industry, healthcare, if you consider healthcare as an industry, and with that we have a certain level of classifications like the tertiary care, secondary, primary care system. In a tertiary care system, the healthcare system actually divided into different groups of operations. One of the operations is the clinical departments or institute, which we are more used to, like ED, we have a critical care medicine, medical subspecialty, surgical subspecialty. Apart from the clinical, there are other departments, other segment of the healthcare system. So one will be most important is an academic and research and education system. There we deal with the undergraduate program, we deal with the postgraduate programs, and the further postdoctoral program kind of things. And then one more department I can say, like we have quality and safety. So the quality safety is one of the very essential segment of healthcare, because anything without quality we cannot improve. So there is a separate actually division for the quality and safety that deals with all kinds of quality safety of the patient families, as healthcare caregivers, and as well as all other non clinical things. And the other things to manage all these department is the functional unit is called the operations. So the healthcare operation department itself is a big organization. So how we can define that? The healthcare operation, basically it refers to the planning, organizations, and the coordination of day-to-day activities that impact the patient care and basically, and that impact the hospital organizations. So in simple terms, the organization that the part of the healthcare system, basically they manage day-to-day activity to keep the operations smoothly and efficiently. So to maintain a better healthcare system, basically you need a very good operating system. So this operating system, basically they take care of your administrative job. They take care of the financial liabilities as well as the legal aspect. In administrative job, basically they pull lot of data, they collect lot of data, and then the setting the employees as well as the patient's scheduling, and then maintain the patient record. In the financials, the leads with the medical billing, the managing the claims, and then revenue cycle management, as well as to how to improve the reimbursement system kind of things. And because this is slightly different from the government hospital in India, where most of the hospital are mostly funded by the government, partially by patient. But the private organizations, which are tertiary care hospital, there are cash patient, there are insurance-based patient, as well as some patients are like corporate. So in most of the developed nations, either they have a universal healthcare system from the government system, like the Canada or the United Kingdom, or if you consider the UAE as a Emirates, as well as USA, they mostly, the majority of the hospital are the private hospital, and then mostly they're insurance based. So the insurance based hospital, to manage the healthcare system efficiently, we need a good kind of record system, and then you need a value-based reimbursement system to sustain the healthcare segment. And then next come to the legal. Yes, the healthcare is a very important issue in terms of legal issues, because the legal is two part. One is the maintain the compliance related to healthcare, because it's a regulated profession. So in India, I think the healthcare regulation is mostly maintained by the NMC as well as the State Medical Council. They have a certain regulation at the different levels, as well as the credentials level at the level of hospital. So the certain person should do certain kind of activities restricted to that. So these are also things managed by the healthcare organizations. And then when these tasks are managed efficiently, and all this legal, administrative, and the financial, and then hospital healthcare system can operate in a better way. So coming to what are the importance? So what are the importance of the operation management in healthcare? The first of all, the important is it enhances the operational efficiency. How it enhances the operational efficiency? Because they basically improve the workflow, and then reducing the waste, as well as the basically ensuring the proper staffing, equipment, and facility. So this is the way they can enhance the operations. How to improve the patient care? So the operation department try to improve the patient care by streamlining the process, streamlining the process, how the system works, by minimizing the delay. Better communication will help the patient experience actually. And then the hospital management basically helps to support the hospital operation strategy. So hospital operation strategy means once you want to run the clinical department, quality or medical, each and every department, they have SOP and they have protocol. So to improve your quality, the system, so you in your department, the clinical departments, in your quality department or your education and academic department, there should be a standard operating procedures for all systems, so that this SOP is verified by these departments with the senior persons, and once it is accepted by the hospital committee, the SOP and the protocol should be known by the respective departments and the caregiver. And we should follow the same so that this is the way we can streamline the management and improve the operations strategy. And then we reduce the cost. That's also important. So how can you reduce the cost? To reduce the cost, most important thing is you need to basically, you need your system to be efficient, and then so unnecessary expenditures can be avoided, and then increase the patient satisfaction. This is also part of like one of our department is called the patient experience, which is rare in other country. Like we had a department of patient experience. So no, sorry, just wait. So we have basically we have a system of patient experience. So with that, each and every family, when they discharge, they tell about their experience to us. It could be good, it could be bad. With that, we have a data, and we streamline this data, and we can improve the from there what we are lacking, what we can improve from them. And so it's like a customer satisfaction kind of things, and this is also for the part of hospital operations. And the other thing will be ensure the compliance and safety. Yes, so that's important, as we have a safety departments, and we have the compliance from regulator as well as compliance from the hospital itself. So to smoothen this process, we have the operation management system that can do that. And other things to facilitate the adaptation of the changes. So the world has been changing very rapidly with the improvement of the technology, involvement of the AI. So how to cope up with this situation, so that our the healthcare the staff, like we call the caregiver, like nurses, allied health physicians, and other non-physician staff, they can grab the new changes in the technology, and how we can treat and train them, and to improve our functional efficiency. So these are the things, the changes is happening inside the hospital. And then quality is the department which is basically us involving to improve ourselves. But there are few areas we need to optimize the system. So what are the key areas? So to run a patient system, basically, so the when hospital dramatically improve its operation efficiency, so we need to look into the main thing is the patient, right? Without patient, there is no concept of hospital. So how we can improve the patient and patient experience, that is everything about, so that the organization can improve. So the different steps, actually we can involve the hospital operation team, and with the technology they can help us as well as the patient to improve the system. So the organization like hospital management, they can improve the patient flow, and they have smoothened the hospital transfer, the discharge of this patient with a systematic way. And once the patient is discharged, one is the empty bed, how can we optimize the bed and without wasting our much time, and then how we can like allocate the staff, equipment as well as supply to so that our management, without increasing the cost, we can give a better delivery kind of thing. And the next is the capacity management. The capacity management means now in a hospital, once started running, you gather a lot of data, and with this data you have some good data and bad data. So analyze that, audit that, see what we are deficit, and then how we can improve that. All this, the non-clinical work can be done by these operations. So like starting from the admission, like patient flow. The patient flow means the movement of patient from one system to other. Like if you have efficient system, online system of patient flow, like mine hospital, we have patient actually sitting in ED. We know everything. The patient is coming to the ICU. So before that, we can check everything. The hospital or management system make it streamline, so that we know most of the clinical data as well as non-clinical data of the patient, as well the admin data like patient demographics and address, other things. So it can be easily incorporated into the system by the hospital management. So now same thing like insurance. So once patient admitted, the insurance company can know that and how to the insurance can be claimed, insurance is acceptable or not, is it acceptable, how much can the it up to what level we can insurance is covered, all these things. So that is one of the thing important, and then this is basically help us basically as well as the patient for the faster admission and discharge, and then so that we can reduce the overcrowding and the unnecessary operational cost and unnecessary the prolonged stay of the hospital. So this one thing, and then transfer. So the patient came to the ICU or patient came to the one unit and moving into other unit, like from ICU to ward. So we need a proper communications between the department, receiving department as well as the sender, and we need a very much good documentations. What are that present patient problem and what things we need to take care of after that, and then equipment, right? So if the patient is transferring from one unit to other unit, if this patient is special kind of devices or special things. So all these things the physician will do, the nurses will do, but to make it happen, there is a if you have a good organizations like at the level of operations, they can make your experience smooth. And then same thing like discharge, when the patient improved and then discharging from one unit to the home or discharging to from acute care hospital to a long-term hospital, the rehab or nursing home. So discharging process is a complex, sometimes it takes long time. So you the physician told, oh, the patient is fit for discharge, and now the patient is physician rounded like morning 9 o'clock and patient getting discharged 6 p.m. This is not acceptable in terms of patient experience. So how we can make this smooth the system? So our quality basically, and then this our operation system will make it smooth. So they will take care where that we are deficient, like they evaluate what if the patient is, clinician will evaluate the patient is ready for discharge or not. So discharge doesn't mean that you discharge write a discharge certificate. So there are many more things to be done, like we need to coordinate with the family. We need to see if the patient requires specialized equipment, if the patient specialist prescription or devices or home infusions or nebulization, whatever. So everything should be keep ready with minimum time wasting. So this can be a smooth discharge process when we involve the operation system, and if we have electronic system, the way we do that. And then the bed flow, once the patient discharged, you have the bed is ready. So once the bed is empty, that doesn't mean the room is empty, doesn't mean the bed is ready, right? So you have to prepare the bed for the next patient. So how you can clean the room, how you can sterilize, and then how efficiently you, and if you have electronic system, then once the bed is ready, it will show in the system this is the room is available for and this floor, and then we can efficiently send one patient from ED or ICU to the acute bed kind of thing. So they will actually better manage the emergency and then initiate the optimum availability. And then with this, that, and then with the proper allocations, and we can do the real stratification of this patient. So, and with that, actually, it will help the nurses to reduce the burden. And then capacity management, what I was telling, that once you have like a 5 year 10 years hospital, you gather so much of information, you know where you're lacking, where you are doing good. So and then nowadays with the automated system and then AI, so basically you generate a formula. So these are the system we are lacking, these are the things we need to improve. So this data driven. So and with that basically, and then you know where your deficit and how you can improve the capex, like your budget for the next 5 years or 10 years or 2 years short term. So you can allocate accordingly from the data you generate. So how to improve the operation efficiency? The first and foremost important thing is in your department, there should be a hospital administration or there should be an hospital operation department. So each and good corporate hospital in India as well as the big the private in government hospital, I think they have the hospital administration department. So the hospital administration or the hospital operation department, they deals with the administration, finance, and the legal issues, and with So how they can help, someone should be related to billing and payroll, someone should be related to hiring, like the HR should be hiring and the credentialing process, and then contract compliance, and then someone should be coordinate with the safety and quality to reduce the risk, and the insurance management. And then if once you have electronic system, you can automate it those things, that will be less time consuming for basically the system. And then if you have a HR, the strong HR department, they should know how to improve the basically streamline the hiring process. They should know from their data that these are the manpower we need for in terms of physician, nurses, and other allied, and then how you can use that and and if they have a good streamlined system for the recruitment process, though there should not be a manpower issues kind of thing. Next, coming to the business intelligence, this is kind of a like new concept of using artificial intelligence in the business. So this is a software. Basically what they do, they collect data from the different area. Like as a physician at Cleveland Clinic, what we do as like the number of outpatient or inpatient we see, number of the data we generate, number of notes we do, consultations, procedure, whatever we are doing, everything is captured in the automated system because we work at an electronic health record. So the most important thing is electronic health records. So electronic health record is very essential, so they can capture the data, and with that they can say how is your efficiency, how many patients you have seen, how much you have generated the revenue. It's called RVU. So how much risk you have done, and then how much claim was the decline from your side because of your mistakes from the documentation kind of thing. This is an excellent tool with the help of artificial intelligence and automation software. They can actually tell your efficiency. And the business intelligence team will give you guidelines like how we can improve our documentation, how we can increase more revenue generation and get appropriate the medical reimbursement from this one. So these are the things which is basically not our physician domain, but this operation department teach us how to use the business intelligence, how to improve the data from the business intelligence. And also not much, but the regulation is very, very essential in the developed nation. I would say in India also the regulation is very important. So you should know the regulatory compliance, what you supposed to do, what you supposed not to do, what are your privilege in the hospital. So what are the procedure you do, what are the things you are not supposed to do. So you try to respect the legal system at the healthcare. So maintains the, I think, the compliance at the level of hospital, the privilege as well as the regulator at the medical council, and then and to update your licensing and to get a certification, recertification with the CME or CPD. These are very essential to update your knowledge. So I think the hospital operation will help you to guide, so and make you strict that you should follow these guidelines. And these are the one of the things. And also the hospital with the help of technology try to reduce the employee retention as well as the burnout. This is one of the things which is now next important to improve the cross departmental coordination. That is very important. So in the hospital, what is happening, it's a complex area, right? And the movement of patient happening from the on admission to discharge, from ED to OR or ICU to acute bed, and then discharge kind of things, and then again back to the outpatient. So when each patient is inpatient, giving examples, you have in the ED. So if someone call you that the patient needs to come to ICU, so the interdepartmental coordination is very, very essential, and communication. So the technology can help you. I can show you. I have this one device called the Vocera. So and then this Vocera is an excellent tool actually. With this Vocera, everyone can connect to each other and then can give the handover to us. What are the basic understanding of the patient? So sitting at ICU, I can have an idea, and from EHR as well as from ED physician, that these are the patient, these are the complaint, these are the main issues for this. So and then suppose, and then patient from ED went to the radiology, and then they took the sample, immediate blood sample, and then the medication, the immediate medication was given. So any issues related to medicine, any issues related to the labs and radiology, the respective department communicate with the Vocera. So this is something a bit costly, but I would say in India, what we can do is like each and everyone using the smartphone, right? So if the hospital, the operation department can just use a smart applications through like hospital management system, and through that, if every physician or the staff is connected, and suppose if there any critical result there and from labs or the radiology, they can communicate to respective admission physician. So the technology basically can help you to connect between the departments, and connect between and it will help to early, like if some blood culture comes positive, so immediately we comes from the basically information get us to and then we intervene accordingly without any delay. So this communication system, electronic devices will definitely help the operation department intervention. So this is one of the things I need to stay. And then next is the in training is very, very essential, because I told that 20 years back the medicine was different. Now 20 years later it's different. I'm not telling that we don't do physical examination, we do, but it's an evidence-based era. So many sophisticated in the investigation, so many software came, and then documentation system is here, and all this the investigative tool has the AI right now, so it can easily detect things. But to update from this technology, the doctors or the other healthcare staff should be oriented to this technological evaluations up to date, so that they can use it and they can take benefit of the automations kind of things. So from the proper writing notes to the electronic health records, and then this and the new tools, new device, new training is very essential. And then once you have a new tools, new device, new system, the healthcare regulator will change some certain requirement, and then policy needs, SOP needs to change, policy needs to change. And then so, and with this change, how can we improve? The operation department actually will help you to get it smooth. And then we should not forget about the patient's safety. The patient safety is very, very essential. The reason is like, so without safety, if your place is not safe, no one is going to come, unless it's they have to. I'm talking about the private organization, so you have to make a certain standard quality and safety. So there are certain organization international wise, like in Emirates, we most of the hospital, almost like in Abu Dhabi, actually 100% hospital are JCI accredited. So to maintain that standard to all the hospital, like in India, like if in private sector, if they try to make all the hospital like NABH standard, so the safety quality has to maintain. So to maintain the safety quality, each and every hospital should have the quality department and safety department, and they should not work only before just the just NABH visit or the JCI visit. To maintain, if they maintain the standard and quality, they should not require any like preparation before that. So IPSG, like in JCI standard, we follow the IPSG guidelines 6, 7, whatever they immediately change, the new is coming in the 2025. We need to update that. So same thing for NEBH also. Like if you follow the standard like safety quality protocol, like international patient safety goals, then I think uh, in the system will be very much smooth, and I think we can significantly reduce the safety and improve the quality. So only thing is this, that needs your proper training preparation, and the training to the healthcare physician, healthcare allied staff, and I think the technical part can be taken care from the operation department, and then in the system and decision making. So the healthcare need a solution. So this one is basically to how we can incorporate all the safety quality issues or clinical issues into a system, so that we should make a protocol and policy. And then the next one will be the how you can improve your system with the help of technology basically. And if you have a telehealth, I know that in SGPGI they have a very good robust tele system. They are helping other smaller hospital. That's good. But in near future, I think the telehealth is the answer for outpatients. I think slowly there will be no outpatient department, only inpatient, and the outpatient will take over by the telehealth system. So telehealth is very essential, but behind the telehealth, all these like kind of capex, all kind of technology things can be smoothly incorporated into the healthcare system by the operations. And then if they use the technology, use the AI to get the all the good quality data into a diagnostic and system, and with that the hospital will be a smooth smart hospital. So the automation, what we do like here in at Cleveland Clinic, like we have a very robust and one of the best in health care record system. So that healthcare record system pull all the data to the business intelligence as well as the AI, and that help us to say about how your compliance of health uh, regarding the procedure, where they are lacking, and how we maintain the KPI kind of system. But yes, there are a lot of challenges. Even in developed nation, there are a lot of challenges, and obviously India has to move forward. It will take more times, but yes, there are certain challenges we have, like balancing the efficiency of patient care and quality. So once you are talking about the efficiency and quality, the most important is the cost, So to initial investment to improve the quality and efficiency, you need a huge technological investment. That sometimes difficult in a smaller setup, but yeah, slowly in the building at a one-time investment is very high actually. But at the time being, with time, I think they will get the fruits kind of thing. And then the healthcare workforce and staffing, yes, some in the healthcare system in private as well as in mostly in the private setup, it's sometimes very difficult to keep the staff. Like people are changing their jobs, they are not satisfied with the job salary, not satisfied with the quality kind of thing. So nowadays people are looking for good standard quality of care where they will be respected. They will. So all this, the operation department can look into that, and they can see how where is lacking, why the physician and the nurses are moving from one hospital to other hospital. They can. And then I told about the technology implementation. The initial cost will be the most important, and then addressing the regulations and then compliance, because this is very important. We need to respect that. But sometimes we know the many physician what is happening, how much is the your CME CPD is required to, and many physicians sometimes they don't like not updating their license every like 5 years or something. They just so it's not the right way to do that. So you should get a CME point or CPD point and the upgrade your license at a certain period. So there should be some regulatory, and then you should have a privilege. Like you if you don't have a privilege to do that, don't do that. Okay, so it's a medical legal issues kind of thing. So these are the basically challenges at this moment, especially low and middle income country like India. And the nurses, what they're facing, like they're still putting a manual entry data. It's a labor intensive job putting all the data and writing in the pen and paper. So sometimes like they spend almost 30-40% time on documentation. So if they spend so much of time on documentation, then how much they will like how can they take care of the patient? Okay, that one thing. And other problem will be like communication. So in Indian system, we don't give much importance to the communication, which is very important. This is one of the aspect. So we need a very good effective communication system, like through CME, through workshops, so that we can unnecessarily avoid the communication gap, which leads to many of the errors. Basically, most of the errors are basically problem of the communication, not delivery. And then the lack of visibility. So the most important thing is, if your institute want to grow, your healthcare leadership should have a very good basically visibility. So if we don't have a lack of visibility in the future, how to improve the operation efficiency and the revenue as well as the quality and safety. So that is one thing. So the leadership should take care. And then we need like sometimes if you don't have the SOP, don't have the protocol. It's not individual care, and thus it leads to delay management and sometimes the mismanage, which lead to the patient care unsatisfaction. So to summarize my talk, basically the organizing operation efficiency hospital is a multi-dimensional approach. Hospitals should have a dedicated hospital administration department in collaboration with the finance and legal department as well as administration. So they should address the key areas. Hospital can improve outcome, they reduce cost with the efficient operation management, and then with the strategic application of the technology from like a hospital can shift from reactive to predictive and ultimately they improve the patient experience. The role of education is very essential to improve the upgrade the skill of this caregiver, including the nurses and other allied physician. And then the professional are well equipped and lead to change the implement. As a professional, we should have the mentality to change ourselves with the rapidly changing technological field and ensure that every hospital has a very good operation system and the quality department so that we can improve, standardize and protocolize our care. And definitely we need individualized and precision care at individual level, but to improve the overall quality safety, I think the standardization protocol and to improve one of the system, I would say hospital and department should have a KPI and they try to maintain that KPI, keep performing index. And it's not just the beneficial for hospital. If you have a good quality department, if you have a good operation department, it will basically improve the healthcare with long run with a profitability. And I think I'm done with my talk. So if you have any question, you feel free to email me. Thank you.
Does anyone has any questions? Okay, thank you, sir. Thank you, sir, for sharing insights. Moving forward, we have reached to the last topic of the scientific session. Now I would like to call again Professor Dr. Subhrajyotik Bhaumik, sir, to speak on his respected topic, healthcare and artificial intelligence.
Thank you, everyone. Let me just pull up my slides. Please let me know if my slides are visible.
Yes, sir.
Okay, so today this is the final session of this wonderful program, and today I'm going to speak about artificial intelligence in healthcare and pharmaceutical industry because healthcare cannot exist without pharmaceutical industry. I have no conflict of interest to declare here. So if we begin with artificial intelligence, let us look at the basic definition. Artificial intelligence is any computer program that does something smart based on a prefix computer program. Whereas in machine learning, the machine takes data and learns from by themselves. Currently, the most promising tool for AI in business is machine learning. Deep learning, again, is the next step for machine learning where machine learning techniques are used to solve real-world problems by tapping into various complex neural networks, and they simulate health or human decision-making. So as you understand, deep learning is a subset of machine learning, which is an advanced subset, which is a subset of AI. So this is in nutshell. About what deep learning and machine learning and artificial intelligence is all about. And if you see, the deep learning here is actually the subset of artificial intelligence. And this is a subset of machine learning composed of algorithms that permit software to train itself to perform tasks like speech and image recognition by exposing multi-layered neural networks. So there are But if we understand that why AI has evolved so much in healthcare, we have to go back at least 300 years. Samuel Johnson was a famous British physician who mentioned that knowledge is of two kinds. Either we know the subjects ourselves or we know where we can find this information from. But in case of the medical literature, if you see, it is very difficult to keep pace with the ever-evolving medical literature. In 2010, it was speculated that medical knowledge is doubling every 3 years and is projected to double every 73 days by 2020. But in 2020, the COVID pandemic hit, and it was speculated that the medical knowledge doubled every 3 days during the COVID-19 pandemic. So, a physician, if he has to keep himself or herself updated, needs to read at least 150 journals per month or 7,700 articles per year. But what AI can do is help these entire collation of the knowledge, and it can be curated in an easily searchable way. So AI helps in summarizing and analyzing large knowledge databases by automation processing, by predicting risk and suggesting intervention. AI helps in getting a diagnosis quickly, and by empowering patients to proactively manage their personal health. AI's use has been predominantly AI's use has been predominantly seen in radiology. See, if there are multiple number of normal X-rays, this study actually, which is published in the United Kingdom, clearly showed that the machine, if trained with normal X-rays, images, can detect normal X-rays very, very quickly and without any mistake. So there is no potential harm with autonomous reporting. This paper goes on to say, with normal radiographs, with the sensitivity of any abnormality more than 99%. So nowadays, what we see in many government hospitals, subdivisional hospitals, because of the scarcity of the radiologists, the normal X-rays are not read in the right time, and patients have to wait at least days and weeks. So if this artificial intelligence tools in radiology is implemented, it can result in detection of normal X-rays very, very fast. It has got a great role in oncology. This is information coming in from Cambridge hospitals in the UK. This Osiris project, which significantly reduces the labor-intensive process of manually outlining healthy organs or scans prior to radiotherapy, it has been utilizing the artificial intelligence tool. Regarding the revealing patterns in disease, getting to diagnosis quickly, AI has been very, very helpful. A paper published in the Journal of American Heart Association mentioned that over 33,000 patients with diabetes were studied, and they could detect that what are the characteristics were in diabetic patients. And this performance was, they also detected the statin non-use in patients with diabetes, and this performance was better than the human beings. Can AI practice evidence-based medicine? That is a big question. AI is very strong in relevant scientific evidence collation. It is currently very weak in exploring the patient values and preference, which form a very important component of evidence-based medicine. But AI is currently intermediate on applying judgment to complex clinical situations. So with respect to scientific evidence and clinical judgment, AI is leading, but with patient values and preferences in a country like India, which is multi-linguistic and multi-religion based country, it is still very weak. So there are problems with AI in healthcare as well, because some of this AI information, the AI database, the accuracy of the database improves. The accuracy of the database improves the outcome of the AI. So the diagnostic and the prognostic accuracy will depend on the characteristic of the patient in database, the completeness and accuracy of records, and the completeness and accuracy of information. So if you see this paper, which is published in the US, in this plastic surgery journal, you will see that many of these things were incomplete. Medical history was incomplete. Current medication history was incomplete. So, surgical history was incomplete in case of 63% of the patients. So if there is incomplete history in these AI databases, this can result in poor performance of the AI tool. And also, what is the potential liability of using wrong AI? Currently, India does not have any guideline for it, but United States has come out that if you use the AI tool, if you follow the AI tool and the patient outcome is good, then there is no problem. But if you reject the AI tool and the patient outcome is bad, then in the United States, you could be taken to the court of law for injury and liability charges against the patient. And also, if you follow the AI tool and it results in bad or at a session in a bad and it results in a bad outcome. So if you have followed the AI tool, it can result in injury and liability. This will also result in taking you to the court of law. Another big problem with the AI tools, which has been used worldwide, is the bias. The data is primarily westernized. In a country like India, we still have to build our AI tools because we don't have India-based AI tools. There's an example of how a discrimination bias exists in the United States, that these are two people who've been arrested for the first time after a petty theft. But because this guy is a white guy, his risk of committing future crime is only at 3, whereas this lady is a black lady, and because the database predicts that more black people are supposedly going to do more chances of having more chances of having a crime outcome. So the high risk of future crime comes for this poor black lady. So the databases include sample bias, which often are based on race and gender. And this is a typical example of that bias. Also, currently, the AI is a black box because there is lack of transparency on how it functions. There are very few people, including doctors, who understands how AI works. Despite the hypes during the AI tools in the pandemic, let me tell you, the AI tools have not performed very well. In a systematic review published in the British Medical Journal of 731 tools of diagnosis and prognosis of COVID-19, it was found that predictive performance was weak in real-world settings. The paper published in Nature also echoed the same thought that AI tools cannot prognosticate COVID-19 chest radiographs and CT scans. So there is a lot of literature coming out from the world which says that though AI is supposedly going to be the next wonder thing, is not actually so wonderful. Now, there was a survey done in these two developed countries, in the United States and in United Kingdom, that what people look for in their doctors. So the common things which were in both the countries were caring, professional, knowledgeable, honest, compassion, treats. These are the words. But these things are basically missing in AI because AI, when it functions like robot. So what is the future of AI in healthcare? The future belongs to man with the machine, but definitely not the man against the machine. I quote Dr. Jesse Enfield, who is the president of the American Medical Association. He said in the annual meeting of the American Medical Association that it is clear to me that AI will never replace physicians, but physicians who use AI will definitely replace who don't. Coming to the second part of my presentation on the AI in pharmaceutical industry, the pharmaceutical market of AI is booming. There was an increase in the AI market from 200 million US dollars in 2015 and to expected to become 5 billion US dollars by 2027. The 40% projected growth of 2017 and 2024 indicates that AI will revolutionize the pharmaceutical and medical sectors. 10 minutes. 10 minutes for 10 minutes for it. Various pharmaceutical companies have made and are investing in AI because AI is making their life easy. And I'm going to show how AI is making their life easy. if you see that AI can play an important role in clinical trial designing and monitoring, in quality assurance and quality control, in pharmaceutical manufacturing, in pharmaceutical product management. AI also helps in drug discovery. It shortens the time of drug discovery, and very, very quickly it also does the drug screening. So AI in drug discovery is very, very a common thing nowadays, where you have tools which can predict the 3D structure of the target protein. It can do de novo drug designing. It can design biospecific drug molecules, and prediction of the reaction yield is very high. It can also identify the therapeutic target. There are various AI tools used in drug discovery. I'm not going to get into details. If somebody is interested, they can read this paper on drug discovery today, where these tools have been mentioned in details. AI plays an important role in QC and QA in the pharma industry, because without QC and QA, a lot of the industry products are rejected. And the FDA amended the current good manufacturing practices by introducing quality by design approach, which is an AI-driven approach. AI has played a very important role in clinical trial designing, because usually clinical trials require 6 to 7 years to complete, whereas if this AI tools are introduced, then it shortens the time by which the drug can be and the drug can enter into the market. However, we have to understand that 1 out of 10 molecules will only enter the market, and which results in massive loss to the industry. This can be also reduced by using artificial intelligence tools in clinical trials. So it helps in clinical trials by analyzing clinical trial data, identifying patient subgroups, optimizing trial designs, and definitely helps in pharmacological screening. AI in pharmacovigilance is very, very important, because the pharmacovigilance is nothing but the adverse drug reaction assessment and analysis to figure out what are the various side effects of the drug. In 2018, between 2008 to 2017, FDA approved over 300 drugs in the United States. And during that period, FDA recorded more than 10 million adverse event reports, of which 5 million were serious and 1.1 million were related to deaths. Now, analysis of this data is a very, very cumbersome thing. And this failure to analyze this data can result in future hazard to patient safety. So pharmacovigilance automation tools with AI are now being practiced. They have been embedded in the electronic health records, social media, and other forms of reliable and tangible real-world evidence. Vigilance is a software platform which uses natural language processing and machine learning to identify areas. There are various researches which have been conducted in pharmaceutical companies in 2020, of which the companies have reported 80% improved efficiencies with AI and 50% reported lower costs. So pharma companies across the globe, especially in the United States, want AI to enter. So AI helps in pharmacovigilance, helps to detect drug toxicity as well as predict patient safety. So there are various benefits of using AI in pharmacovigilance, because it helps to reduce the PV case analysis timing. It improves the quality and accuracy of information. It can handle a lot of data from the incoming data formats and can be used for identification of ADRs. But the concern is that whether this data is credible or not. Secondly, are ethical implications, whether the privacy of all the patients' data is being maintained or not. If there is any bias, we spoke about the data bias. Secondly is many people believe that AI can actually replace the massive jobs which people have got, leaving many unemployed. And AI systems may lead to unintended consequences, such as amplifying data biases and generating unexpected results or analysis, and resulting in adoption of the AI in pharmacovigilance being very slow. So there are few companies like Bayer, Sanofi, Boehringer, Takeda. They have already embedded AI system to improve the working in the fields of oncology, cardiovascular system, and central nervous system disorders, to improve their drug development. So the take-home message is that when it comes to the pharmaceutical industry, AI is changing the way how drug discovery and how drug designing is taking place. AI improves clinical trials conduction and strengthens market positioning of the approved product. Also, in post-marketing pharmacovigilance, there's so much of data coming from molecular clinical databases, social media, and biomedical literature, and AI can play a pivotal role in reducing the case processing time. And this has improved the functioning and reduced the cost of the pharmaceutical company. So with this, I would like to end my presentation. If there are any questions, I'm more than happy to take them.
Does anyone have any questions? Okay, thank you, sir.
We have reached to end of this webinar. And with this, I would like to invite Assistant Professor, Department of Emergency Medicine, Dr. Utsav Anand Mani, sir, to deliver a vote of thanks.
Thank you. Good evening, everyone. As we come to the conclusion of this remarkable event, I would like to express my heartfelt gratitude on behalf of the entire organizing committee led by Dr. Tanmay Ghatak as organizing chairman, Mrs. Juin Datta Ghosh as organizing secretary, and myself as the organizing scientific secretary. This national level quality webinar has been a testament to the collaborative spirit and dedication of all those involved. Firstly, I would extend my sincere thanks to the Indian Society of Critical Care Medicine, Lucknow branch, Quality Cell of Department of Hospital Administration at SGPGIMS, and the Emergency Medicine Association, EMA UP, for their unwavering support and partnership. Your commitment to promoting quality in healthcare has been the cornerstone of this event's success. I'm deeply grateful to our chief guest, Professor Dr. R.K. Devan sir, our esteemed guest of honor, Professor Dr. R. Harshvardhan, Professor Dr. R.K. Singh sir, Professor Dr. Sanjay Dhiraj sir, for their presence and valuable contribution. Your insights have greatly enriched today's discussions. A special note of appreciation goes to all our distinguished speakers whose expertise and thought-provoking sessions have been insightful and inspiring. Finally, I would like to commend the organizing team, all the participants and listeners. Your hard work behind the scenes have ensured everything runs smoothly and seamlessly. Thank you and safe travels home.
Okay, thank you, everyone. Thank you, everyone, for being a part of this webinar. Okay, we are done now.